and maybe it will continue today, and I wish everybody my gratitude as well as good luck for the remainder of the conference. Chairman, sirs, all of you here, and also notably I will say Acharya, Vishwanathji Karad, who was very impressive by his work and his philosophy, which was throughout the day sort of coming vibes through the entire atmosphere, and I'm so happy that I had a chance to come here. I want to share today's topic given to me is to talk about the open and safe thyroid surgery. So before I actually get into the meat of it, let me just see what makes it unsafe. There are medical conditions that makes it unsafe, and they are listed down there. But I will not dwell and spend time on it, because that's the job of the endocrinologist and the anesthesiologist who are going to team up with you. And I will never touch a patient unless these two people give me a good go-ahead signal to get into the surgery. But let's see what makes it surgically unsafe. The things that make surgically unsafe is intubation and airway. I mean, that's not necessarily only an anesthesiologist's problem, but that is also our problem. Time and again it occurs to you that maybe tracheostomy is a very easy option in case they fail to intubate. It is not really true. And particularly a patient who comes to you with cancer of the thyroid, particularly anaplastic cancer which has invaded all over the place, and you have got no way to get either a tube in or a tracheostomy tube in, and you are put into a dilemma usually in the middle of the night. And the person that comes handy to you at this time is none other than a cardiac surgeon who can quickly do for you a cardiopulmonary bypass and buy you time enough to get into the trachea at the lower level by dividing the cancer. But I will also not dwell on those conditions, partly because of the paucity of time. What are your surgical safety marks? And let's just go through them quickly. One of this pre-operative imaging. If you befriend a imaging guy, you can almost create a 3D image of what you are going to see and do before you actually even begin. The teamwork. Everybody in the team is important. It is not just the surgeon. It is even the small neurotechnician sitting there and managing your neuro monitors, and if he wakes up a little goof up somewhere, you can be in trouble because you see the nerve, you put a signal, doesn't work, and you get into a panic. Have I given a neuropraxia? I mean, those who are into cancer surgery will put a next dilemma: do I go ahead and do the other side, or do I not do the other side? That is a famous Greg Randall theory that you can stage your surgery. I mean, that doesn't actually work for us, but theoretically, yes. And the most important thing is, all day yesterday, it got hammered into you, and I just want to reiterate what we learned yesterday, is to look at that anatomy from different angles. The anatomy, as a surgeon would see, like an open surgery, is straight end-on view of things. But when you're doing an endoscopic surgery, if you're going from the top, you're seeing a top-to-down view. If you're going from below, you're seeing below-to-top view. Now, these all understandings had to be there. Oi, what happened? आता सकाळी आपण नाटकाच्या कोणाशी गप्पा मारत होतो मी. नाटकाला एंट्री घेताना स्टेजवरनं 3 लोकांना नमस्कार करायचा असतो. एक तर सरस्वतीला, दुसरा डायरेक्टरला, आणि तिसरा माईक आणि ऑडिओवाल्याला. कारण तुमचं आयुष्य त्यांच्या हातात असतं. तुम्ही एंट्री घेतली आणि त्यांनी ऑफ करून टाकलं तर गेले तुम्ही. सेम हिअर. सगळ्यांना and start the journey of surgery, you have to be very safe and always befriend following things. Yesterday we had a very good talk by our friend from Italy, and he spoke to us about the adjuncts, particularly electrosurgical devices. You have to befriend them. Limitation and appropriate indication. also befriend 3 people. Anesthesiologist, for me it is very important, she is my wife, I can't be not befriending my wife. But more importantly, the radiologist. He can give you a minute detail about the tumor and actually create an impression in your mind, where is this growth going? Where is this tumor moving? Are there lymph nodes? Are there lymph nodes which are going to trouble me? Pathologist, you see, blow me. I had done on one occasion a super duper VIP patient. A large cystic lesion with a tumor in the middle. The FNSC showed papillary carcinoma. We went ahead and did the full surgery. The guy was with me, and he's a surgeon, his mother. But when we actually removed the tumor, there was just no tumor. It was a large cystic lesion. And I said, my God, have I overkilled it? So we rushed to the lab and we found that one corner of that cystic lesion was a PAPCA. This will happen, and your pathologist has to be on board with you. Now, I'm not reinventing when I talk about techniques, but I will surely share the lady on the top left corner who died 11 months after surgery because of persistent, intractable postoperative hypocalcemia. And that, not reinventing the wheel, but what these 2 guys at the bottom, whose names and whose pictures appear in everybody's talk before they can complete their presentation on thyroid. But look at the man at the top, William Halstead. What did he comment about these 2 people's surgery? His comment was, Bill Roth was a flamboyant, flashy surgeon. So on way to the surgery, he knocked off the parathyroids, left some thyroid behind, and his patient died of tetany. On the other hand, Cocker was a meticulous surgeon. He removed every milligram of thyroid, so his patient developed myxedema, but they did not have tetany. I mean, that was a great message coming from William Halstead. And therefore, my talk will rotate around these things. This is a $1 million picture. I wish Deepak Balsubramaniam was there in the audience. Deepak, we talked about the branching of the superior thyroid artery. Look at the superior thyroid artery. It is not just 2 anterior posterior branches, but there is another branch which is taken off even before these branches, and that goes on to form a loop. I'll show you more pictures of that later, and supplies the superior parathyroid gland. I think this is a picture which I cannot show enough number of times. And then as we move on through my talk, I will let you know how to deal with this. You see, there is a recurrent nerve, there is a carotid artery, there is an inferior thyroid artery, but mind you, that is the picture, keep it in mind, that divides the level 6 into level 6A and 6B, and you want to get all those nodes out, and how to go around that will be also a part of my talk. I will share with you all the experience that I have with all these structures. And the first thing is, in my days when I was taught, and I'm not telling how old I am, but it was exposure, exposure, and exposure. Everybody talked about exposure. You expose, you expose. And we take incisions. The bigger the incision you took, the bigger the surgeon you are. The smaller the incision you took, he doesn't know much. The whole thing is changing. It is no more bigger incisions, larger incisions, and bigger exposure. It is small incision, but a beautiful view through an endoscope. So got to know that. So that is no more true. But what is talked about is, if you are into a sort of a open surgery, we talk about the scar. I'll share with you how to better your scar. Never incise like the old timers say at the same spot. You go on the skin and the platysma and bang into the deep fascia. Go away from that thinking. We have to stagger your incision, one on the skin, and the platysma is cut at a different level. Now, why do I do that? I do that because I want to have these 2 incisions heal separately and have an interposition tissue. That makes my scar supple. And if the scar is supple, it doesn't look so bad, it doesn't get tethered, it doesn't get hyperpigmented. And therefore, that's a very simple trick to do. Don't use cautery from the word go. I've seen young guys doing it. They practically cut the skin with the cautery. Think what is going to happen. If you cut the platysma with a cautery, which is a commonly done thing, a millimeter of the platysma on either side is dead. It is devascularized. It's a necrotic now. And you are going to put him back together. So you are making 2 necrotic areas to heal to each other. Will it ever happen? It will never happen. And therefore, if you have used cautery, ensure that the platysma bleeds when you close, so that you have got a healthy muscular platysmal layer to meet each other and heal nicely. And also examine the skin edges. But skin edges, yesterday beautiful demonstration, moving skin, that doesn't cause so much damage to the skin. But the earlier way we were trained to put the skin, by skin stack suture can cause a lot of damage to the skin. Ensure that is not happening to you. Then flap elevation. You see, another thing, we change every time. I change in my own career from the beginning now. Earlier the flap was raised up to the mandible. Then it came down to hyoid. And now it even come down to the thyroid notch. What's the principle guiding here is that what disease you are handling. If you are handling malignancy, you will need to see the underbelly or the posterior belly of digastric. And therefore your incision should allow you, the flap should allow you to go into level 2A and B, and that means the flap should be high. On the other hand, if it is a benign condition, no need to do that dissection. Again, the bottom one in my days was suprasternal notch and the lower limit of goiter, guiding principle. No more true, because you don't need to go that deep. Because if you go that deep in the suprasternal notch, you will create a potential space in that area which accumulates seroma later on and gives rise to a nasty bump here just above the suprasternal area. It can be avoided by not going so deep on the flap. The second is midline dissection. Everybody talks about it. I honestly tell you, I spent quite a good time in making sure that I got the midline, because that is the key cornerstone in working on thyroid. You can get lost. You see, if you are doing a 2 centimeter, maybe 4 centimeter, midline is not an issue. But do something like this, midline does become an issue. And the guiding principle here would be between the jugular veins, median raphe, thyroid notch, trachea, and suprasternal. Just guide this. But what happens if you get this? There is only one anterior jugular vein which is bang in the midline. And that in such situation, what might come handy to you is to actually excise that nerve. I think yesterday we saw that also, that take the whole vein out and then you will see the beautiful midline raphe. Now, what do you do with these things? I mean, thankfully you will not face this, but I face this because I work in a belt where there is endemic goiter, massive goiters. Now, if you see this, the old dictum was keep the veins on because they are going to reduce the edema of your flap. I have an alternative, and this is my alternative. I will recommend that you take all these veins off. It is not sacrum sanctum that you don't touch these veins. Just excise them completely and you will get a nice beautiful picture and you are carefree. Because every time you retract, you are worried, do I damage the nerve, a vein, and do we start bleeding? So that's a trick. The thing is middle thyroid vein. I have seen this umpteen times happening, and yesterday I was slightly apprehensive about people doing the middle thyroid vein with electrosurgical devices. I will be scared to do it, personally myself. But I'm sure whatever you do, you get that vein first, and then this is a step I recommend for all of you who are entering into this area, is to isolate the jugular vein from top to bottom. You do that and you are absolutely certain that you will not end up with a nasty bleed during the surgery of the middle thyroid vein. Because middle thyroid vein, if it gives way, will directly go into the jugular vein, and that's a nasty situation to deal with, not so easy. Now, elevation of flaps, another trick. You see, as ENT surgeons, we are also dealing with the voice. And we are also worried about the post-operative voice, not only as a result of the nerve damage, but also as a result of mobility of the larynx and the strap muscles. People don't pay much attention to this. There is no need when you elevate the flaps to remove or to elevate the flap individually. The God has given a beautiful fascia which is between and enveloping these muscles. So if you maintain this fascia, these two muscles will not stick together. If you isolate them, whether you are doing by lateral trapdoor approach or you are going to midline approach, do not differentiate or do not dissect and separate the two straps. Go under the straps or whatever you want to do, but don't dissect between the straps. Now, here is a learner thing for you. We all do neck dissection and we all meet ANSA. Yesterday this point was very well made in one of the discussions, that end-to-end anastomosis of recurrent laryngeal nerve vis-a-vis ansa cervicalis being put into the top end of the recurrent nerve should you have a cut nerve. I think this is where we learn that the nerve is bang there, and we try to see that picture every time you will do a neck dissection. The other thing is also appreciate at what level the nerve actually enters the strap muscle. Because when you want to cut the strap, in case you have to cut the strap, you have to remember you cannot cut this strap down below, because you will deneurotize the muscle and you will have a muscle but no nerve supply. So you need to cut this above that level, so as close to the top end as possible. But should you do that thing, then always remember, if you have done a mistake, do it completely. That means you have to cut the strap. Don't just cut the strap, but elevate it up and down to its origin at the top and insertion at the bottom, so you will get the maximum benefit of what you have done. Now, word of caution about this kind of a tumors if you get. We all talk about bear strangle. Now, I'll come to that bear strangle in a minute, but when you release the lateral lobe, sometimes you may end up having a nerve which is so much plastered onto the pole. So therefore, that bear strangle is something which I will again come back later on when we talk about the recurrent nerve, is not a very helpful guide. Jolt strangle, Reeve strangle, we talk enough about that. But the thing here is, at the upper pole, whatever method you are using for sealing these vessels, I insist that you do it one by one. You don't get them like an artery forceps, or you get those as a one big clamp, because that's the surest way to knock off the external branch. I insist that you take them one by one, the artery, the vein. You will get at least 4 or 5 of success. We'll talk about that again in a few minutes. And then also see where is the nerve going. It's not always safe to put a blanket, because it is just possible that you will cut that nerve. It is not a vascular plane. It contains a nerve in that particular area which is moving. I don't have a pointer here. Do I have a pointer here? Anyway, look at this picture again. The nerve is coming below and then entering to cricopharynx. Should you put a large electrosurgical device or maybe a big massive clamp at the top, you will end up getting that nerve cut. An EBSL nerve is important. It is not important. Now the RLN, let's talk about RLN. There are various approaches, but the best is imagine. How many of you see a baby on this picture? Can you see a baby boy? Those of you who have seen a baby in that picture will get the RLN ziffy. You will have no problem in seeing it, because you have to imagine where it would be, and that imagination comes through pre-operative workup with imaging and everything, and you will never ever have a trouble, although all that theoretical things exist. This will all go for a toss. All this knowledge will go for a toss in a large goiter. But a large goiter can change all these things. So all this theoretical knowledge will remain with you, and you will end up killing the RLN. So don't worry too much about this. This is $1 million picture. The friend of yours is a nodule of Zucker candle. Watch that Zucker candle there. There is an inferior thyroid artery. I wanted again Deepak to be in the audience to see this picture, which is coming from below, going behind the nerve and supplying the superior parathyroid. The same artery sends another branch which is going downwards towards the inferior parathyroid. And where are the branches get into the thyroid? Never. It hardly supplies the thyroid. I'll show you and prove it to you more slides. But here the picture is the most reliable guide to get your nerve is a nodule of Zucker candle, which is a posterior condensation. Same picture on live. That is Zucker candle, that is the nerve, those are the parathyroids, and that's where bang you get. So my way of identifying the recurrent laryngeal nerve is at the top, at its insertion, just below the nodule of Zucker candle. Now, therefore, this bear strangle, I said I'll come back to this picture, becomes a redundant phenomena because of these things only. Now, why would recurrent laryngeal nerve be abnormal? Vessels, berry, thyroid, and your assistant enthusiasm. Your assistant, if he is very enthusiastic and pulls the gland across, he can literally pull the nerve across the front of the trachea. So always remember, I had a little giant called Bali. He was wider, taller, almost twice my size. And every time we started operating, I said, remember, Dara Singh was not surgeon. I am sorry, you don't know Dara Singh. Dara Singh is a big time wrestler, big man. I said, he was never a surgeon. The surgeon need not do be a Dara Singh activity, just gentle. And almost this particular vessel, we saw that yesterday also. I mean, always as the nerve divides and gets, one goes backward, one goes forward, and then there are this inferior thyroid artery, which is coming up to there and getting into the superior parathyroids. One branch is going into the inferior parathyroids, and there is this little branch which will come underneath and above it. And always remember this. If you don't get this and try to cauterize that, it will be a disaster. Both. Look at these divisions. Beautiful picture. The RLN is dividing into so many branches. And so is inferior thyroid artery. But where is it going? Is it going into the thyroid or is it going into the parathyroid? It goes to the parathyroid mostly. And therefore the time has come that we think that inferior thyroid artery is an artery of parathyroids. Another picture. That's the nerve. That's the inferior thyroid artery. Comes up, goes up to the superior parathyroid and just sends a twig into the... And this theory, I mean, we talked about Madam Mehta from Pune. And that time we talked about Lopa Mehta from Mumbai also. She is the one who prompted me into dissections where started proving that this vascular loop exists. And the theory was, God, when He creates something, is better surgeon, better architect, better designer than any one of us. He has given double supply to all the important organs of the body. He has given 2 arteries for the heart. He had given circle of Willis for the brain. So how can God be so not considerate that He doesn't give double supply to the inferior and superior parathyroids? There is a vascular loop and both these vessels contribute to the parathyroid, except we are not aware of it. Now, rare variations. The one is very obvious. This is a direct, non-recurrent. Can you know that there is going to be non-recurrent before you start? Any juniors can. How can you tell that I am going to see a non-recurrent today? Can you guess it? Can you diagnose it? Of course you can. If you are friendly with the CT scanner, he will tell you that there is an abnormal subclavian. And if it has an abnormal subclavian, there is an abnormal recurrent also. So just be friend, talk to the anesthesiologist, radiologist, and this is possible. What is not possible, that second picture. Second picture is a low recurrent laryngeal nerve. That means it almost enters with the same fashion, but it doesn't go into the thorax. That's the one which you need to care about or worry about. Anybody, any guesswork, where would you get this? Left-sided, non-recurrent, recurrent nerve. Situs inversus, that's the only condition where you get it, because the whole thing is right to left, left to right. But this is very, very rare. I hope you never get it, because we should get it. And this is a picture I wanted to show again from yesterday's talk. See, everything is seen beautifully. This is a picture I deliberately take after my work is done by an endoscope. This is not a direct picture. This is an endoscopic picture. Why did I do it? Just to prove the point. Endoscope can take you very dangerously close to the structures. You are very close to all the important structures. They look so beautiful. I mean, I was very happy yesterday. All day I enjoyed thoroughly. As some would enjoy music, I was enjoying all the surgeries. You see this, but remember, you go very, very close to the structures you don't wish to apply. And the dangerous item is the electrosurgical device. And I'm so glad that you talked about that yesterday and made everybody aware that please use it very judiciously and knowing how it works. But if you see this at the end of your surgery, that's a recurrent nerve which is dividing into 2. That's the inferior thyroid artery. That's your superior parathyroids. Those are your inferior parathyroids. And that vein, that arterial branch I mentioned, which goes over the nerve into the thyroid and take care of that. And if you see this picture as you operate, maybe you are a well postgraduate thyroid surgeon. But 7, this can happen to you. On a Saturday, you want to go to a conference on Sunday morning, your flight is at 10 o'clock, and suddenly this happens. There is a non-recurrent laryngeal nerve, and there is a huge inferior thyroid artery, which is just coming below and getting it. That's a disaster. You need to cancel your flight because you may not be finishing in time. But you need not worry if you spend few Sundays with the cadavers. Look at how beautifully the dissections goes, and you can swing on the nerve. But look at the arteries, things moving. That's inferior thyroid artery going below and going up. Same thing. If you have these pictures in your mind, then probably you will not get so scared with that non-recurrent nerve also. Should it ever really happen to you, and this has happened to me also, how to deal with the recurrent nerve in case you have accidentally done it. It's no big deal. We are all using microscope as ENT surgeon. We are all using loops as head and neck surgeon. Couple of stitches and you can see the day through and the nerve works. Don't worry. Now I come to the final part of my talk where I say, eyes don't see what the mind doesn't know. Look at all these pictures. I showed you that picture before, but that happened to me in year 2007. But I'm doing surgery much before that. I never saw that. It was all the time there. Look at this top picture, 2000. That's an artery coming from below, getting into thyroid. But that one branch is going upwards, which I never saw. But I started seeing. So my talk is about now parathyroids. Now, we talked enough yesterday about parathyroid, so I will not spend time on this. But what I want to talk about this as many times as I can talk. I've said that before, I can never stop. The subcapsular dissection, how many of you are Pakiza time? Pakiza किसी ने देखा है? Pakiza was a big time movie in India. It's my age, my era. And there was a song, Parde mein rehne do, parda na uthao. That means there is a draping on the top of the nerve and the vessels. If you don't disturb that fascial drape, you will never injure these structures. The best way you can see is the last picture. If you keep it like this, don't bother to show. In a workshop situation is good. You want to impress everybody how beautifully you can dissect. But that is not necessarily the way you will do it in every day. Try to just be there and not dissect. Let it be covered with the fascia. Now again, I'm giving all this for Deepak actually, and he's not there, I know. Look at the inferior thyroid artery. It supplies and it goes behind, and you can see this one. This is another $1 million picture. Inferior thyroid artery sends one branch up to the superior thyroid and then gets up into the thing, and the recurrent nerve is over it. Where is the branch for the thyroid? There is nothing getting into thyroid. Another one. See this big structure going, that's not the nerve. The nerve is here and going across you. But the arterial supply is that. Where is the branch going into thyroid? There is no branch going to thyroid. Everything is being spent there and there. Please remember this in all the things you do. And the last thing I'll talk about, ligament of Berry. That's the area where I have got all my accidental injuries to RLN. RLN doesn't get injured in the lower neck. RLN doesn't get injured near the artery. RLN often gets injured here, and be careful with this final attack. Remember the vessel, and that's a disaster when that vessel runs parallel with the nerve and enters the larynx, and that's where the electrosurgical knowledge will come handy. Think about this. We talked about that yesterday. I did a small experiment when I was young. I did monopolar, I did bipolar, and I subjected that tissue to histopathology. And I studied the lateral vascular damage. And it's scary. When you work near the nerve or the parathyroid, and if I tell you what millimeter damage you can cause, you can see on the picture, it is scary that when you go close to the structure, you are inviting trouble. So be aware of this. The next is the one which talked about enough, so not wasting time. This is the stretch. This is your assistant Bali, Dara Singh coming in. He pulls everything, and the top end he creates a knuckle on the recurrent laryngeal nerve. And a little rash dissection there will knock off the slice of the recurrent nerve. That's where it gets injured mostly. Now, the bleeding is never an issue, but if you see a blushed parathyroid, believe it is a dead parathyroid. A blushed parathyroid which looks violet, crimson or any color other than yellow is not working, and therefore you need to think about it. Don't make them blush. I will just come to the autofluorescence techniques because I see some of the postgraduates. There are two ways of doing it. One is a camera based, the other one is probe based. Now what's the difference? The difference is this. For a camera based thing, it's not so easy because then you need to shut off the lights, but what's importantly, it can identify the parathyroid in a larger field. What's the probe based thing? In probe based thing, you have already seen the parathyroid. It doesn't help you to know where it is. You just confirm that they are there. The other advantage of camera based is it can actually show you the vascularity and whether it is perfused or not perfused. I will just say that it enhances. it is not a foolproof thing. Either both of them, andocyanin green, camera, PTI, whatever you use. It's not foolproof. They have their own problem, but it definitely makes you sure that this is not just parathyroid, but this is a functioning parathyroid. This is a vascularized parathyroid which is going to work. Because if it doesn't is vascularized, you can always take that parathyroid and do something with it. Now look at this. All that parathyroid bottom there is not functioning. It is looking very bad. That color is not good. Don't like it. Put it to the camera. This one, I put it to the camera and I see this. And I am happy now. Because my both parathyroids are shining well. And therefore I know that they are in position and working. But look at this picture now. This vessel is seen, but the parathyroid is very sad. It's black. It's not perfused. And that will require some rescue. And the rescue can come in way of warm saline, papaverine, weight, repeat the whole thing and ensure. And all this doesn't work and still you got a dead parathyroid or avascularized parathyroid, you think of implanting it. Now sometimes these are very easily retrievable situation. A big hematoma on the parathyroid. Never leave it like that because this is going to cause trouble. Just puncture it, release it, parathyroid come back to normal color, and then if not, then reimplant it. My technique, the last picture is to show, never ever make a pocket in the muscle and put a parathyroid there. It is almost ensuring that you put a coffin 5 feet below and put the sand on it. Why? Because if you put a pocket and then put a parathyroid, there is a hematoma around that parathyroid, which is surely going to not allow the newer blood vessels to come in. It will all fibrose and you have a dead, coffinized parathyroid sitting into whatever muscle you choose. So the only way to reimplant is to smash it, give it to the nerves you don't like, and go away, smash, 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 smash. Make it into particle, which you can suck into a small syringe with a 18 gauge needle and inject in muscle of your choice. Where you inject, we can talk later. That's not a point here. Now, which of these is a true RLN? We have seen this picture before. Now, what comes handy here is, I hope this works. Can you make it work if it can work? Doesn't matter. I'll tell you what. You can have in that situation, you can have your probe, intraoperative nerve monitor, and start stimulating them. It is fun, I tell you. It is fun. You can stimulate the main trunk, boop, 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 reacts. You treat the back one, nothing happens, but you can see the muscle contracting. Because what is contracting is the inferior constrictor. You go up in the front, again it doesn't contract. It's a sensory nerve. And then you go right bang in the first nerve, and then you get the beep. So it's a fun. So use that nerve monitor, and it gives a wonderful feeling. That didn't work, doesn't matter. It worked? And last, yeah, and I'm not finished. This is the last picture I want to share with you because I have a wrong notion about me when I go around the country that I do like this. No, I don't do like this every day. This is a cervical epidural anesthesia. That patient is an Adivasi tribal lady with that kind of a goiter. And we still, Amit is sitting. You have seen this happening there. And that's how we did it. At the end of the surgery, before she leaves, she has a drop of drink. And that's only water, I can tell you that. That's a saline she's drinking. But I want to put the facts right. I don't do this every day. This is my special technique. I use it. We do around 12 to 17 thyroid on an average in this camp in a matter of day. But this happens there because they are tough patient. They are very rugged patient. They can lie there with their head extended, fully conscious, fully aware of what I'm doing. We actually talk to the patient as we go through. And therefore, this kind of a surgical thing is not something which I recommend, but everywhere I go, they talk about Mergat. Even if I go abroad, they'll talk, cervical epidural. Even yesterday, Mohan was asking me, Mohan, I don't do it every day in my Nagpur practice. This is a very special thing, which is only reserved for my tribal practice. And lastly, the biggest adjunct for any thyroid surgery is not an endoscope, it's not an electrosurgical device, it's the time you spent in the anatomy hall. Even at my age, I make it a thing that at least I conduct, this is a trick, I conduct cadaveric thyroid workshops. Actually, I'm educating myself. Because every time I do in a cadaver workshop, a cadaver dissection, I'm enlightening myself. So I do several workshops. I recommend all the guys, if you get a chance, don't worry about this soft embalm, hard embalm, doesn't matter. Anatomy remains the same. You need to struggle a bit more with the hard bodies. But do that as much as you can and develop a team. Very important. You see, the wheel is only as good as the little cogwheels inside it. A motor car won't run, a small fuse will go, and you are stuck on the highway. And that small fuse needs to be repaired by a 12 standard A grade technician, and say, oh my God, I am FRCS. And this guy tells me, no. He knows what he knows, and he's one of the very important member of your team. So develop a team that includes everybody, including an OT attendant. I was so happy yesterday, everybody who was assisting, including the most senior surgeon amongst us, was appreciating and encouraging the assistant, appreciating the theatre staff. I was very impressed by all of you, because you knew the value of teamwork. It is never you and you. You may be projected. Dhoni is not the all who won the World Cup. Kapil Dev was not the guy who won the World Cup. There were 10 people behind him who had won the World Cup. So remember those 10 people and be grateful to them all the time. Thank you all very, very much.
Wonderful lecture, sir, and it's an eye-opener. We learned many things, and especially your one-liners. I think they were full of knowledge of whatever you have learned in the last 50 years. It said that anatomy is very variable, and aberrations in anatomy happens only in hepatobiliary area or gastrointestinal area. No, it doesn't happen. Anybody who has spent time with thyroid, he knows that it exists also with
Can I just add a line there?
Yes.
One liner?
Sure.
Your patient has not read the Gray's Anatomy book before he was born.
Yeah. Right. Thank you very much. And if there are any questions from the audience, yes, sir. Please come to the mic, or somebody give him a mic.
Good morning, sir, and thank you for the beautiful lecture. Actually, this is two parts to this question. The first is, have you ever encountered a situation where you could not identify the recurrent nerve?
Second question? I love the first question. I'll answer that question elaborately. Second question.
The second is, you were mentioning the nerve monitor. Is it very effective for the extralaryngeal nerve, because the nerve impulses or the feedback you get from the monitor is not very robust as far as the nerve is concerned, at least with the technicians that we get back in my hospital. So are you routinely using that for the...
Yes, I will answer both the questions. I'll ask the first question. How often does it happen that you have not seen the recurrent laryngeal nerve? And how often has happened that you have not seen the external branch of the superior laryngeal, both the nerves? As regards to the first nerve, fairly often you don't see it. If it is a so-called hernia type 1, it may just come up top and go away and you will never see it. So don't worry too much about that part. However, can you confirm that your safety, your nerve monitor can come handy? You can give that impulse into that corner there and you will get the crackers constricting. So that's one good use of nerve monitor being used for the, not the recurrent nerve, but for the superior external branch. Now as regards to how often I have not seen it, right? Honest answer, I asked the same question in one of the panel discussions that I conducted at a big national level. It was a big meeting and guys sitting there were no chickens. They were really hardcore thyroid surgeon, and the answer came, yes, it does happen. So if you don't see it, don't worry. Even the bosses have not seen it sometime. Why does it happen? It happens because, and mostly this will happen on the left side, not so much on the right side, is because the nerve is come really in the groove quick and it stays in the groove, number one. The tumor has practically developed its own capsule, so the thyroid moves as a one gland, and therefore there is a lot of soft tissue on the recurrent laryngeal nerve. And therefore you will not see it sometimes. This happens. And should this happen, what you should do is try to look at the bottom. Don't look at the entry point. Look a little bit below and you'll always see it there. You have not cut it, number one. Number two, again here the nerve monitor comes handy. Once you have seen that and you get a signal, you know that it is working. Now third thing about loss of signal, and sometimes do you therefore not use it routinely. You should always use it if you have it routinely, because everybody then knows how to do it. In the beginning, the anesthesia is not so happy to use the tube because they have to double confirm it. But they become a habit now. They just do it, it's done. Whole thing becomes very fast. Troubleshooting becomes very quick. Everybody knows what might have gone wrong, and therefore they took appropriate action. I was probably arrogant about 10 years back. I was that time, I know it all. Why do I need it? I don't need it. But then I was already on the nerve monitor for the European system. I had got it, I was not using it. I said, यार चलो वापरते अभी इतना बड़ा पोस्ट दे दिया तो कुछ करना पड़ेगा. So I started using it. And now I tell you, I am equally orthodox advisor that yes, if you have it, you must use it on every case. Because it's not just a one use for it. It's not just the continuity. You can also plan. You can dissect the tissues more. You don't leave much tissue in the entry point of the nerve because you are scared you may damage it. You are seeing it and you are going and remove every milligram of thyroid tissue. Big advantage. Staging of the thyroid, I told you about the contralateral lobe. You do this side, you have lost a signal on this side. Do you stop? I don't stop. I go ahead.
Thank you, sir.
Can I just ask one more question? Do you use any Lugol's iodine for these big glands and vascular gland in an attempt to make it more firmer or to reduce the vascularity of the gland?
Yeah, good question. It was a practice when I was a resident to give Lugol's iodine on an assumption that the gland will become little more tense or maybe solid, allow you to do dissection. No, it's not done anymore anywhere. It has a Joe Basidoff effect coming because of that thing, and therefore I think it's not practiced as much as I know. Yeah, I'll answer that and we'll stop. She's pushing me, get out. No, I'll answer that question because it's important. In my early days of works and demonstration, I used to dissect that nerve from practically root of the neck till its entry point in the joint. I don't do that anymore. I just know where it is, I know the plane, and I carry on. No need to do that.
Thank you very much, sir.
Thank you, sir, for the profound insights on the topic. I would also like to thank the moderators and the attendees for the valuable inputs. I'd like to call upon Dr. Naik sir to come up on the stage and felicitate the chairperson, Dr. Pradeep sir and Dr. Shivmurthy sir. Okay. Dr. Kasne sir, please.
Why don't you also come forward for the photographs? Yes, sir. The दूसरा दे दो ना. दूसरा क्यों नहीं आया?
Hello. Check.
Directly पहले आदि inauguration.
Sir?
No.
Okay, good morning to all. My name is Dr. Priyanka Maulik, and for the next lecture for the day, we have on the topic Advances in TOEVA, Tips for Beginners. Okay, sorry for the interruption.
short of time, we'll be starting with inauguration first.
Inauguration first.
First inauguration.
Acha.
Just introduce, because the first lecture was slightly detailed. We'll be taking first the inauguration, as Dr. Palnivelu sir has to leave for his flight.
Okay.
We are changing 2 lectures, which will be after the inauguration in Keynote.
Okay. I'm sorry there's been a little change because we are planning to take the inauguration first since Dr. Palnivelu has to leave for his flight. So we will now make arrangements for the inauguration first. Please bear with us. हो ओनली 3 नाही फक्त 3 पलनीवालू आणि 2 गेस्ट ऑफ ऑनर्स बस बाकी कोण नाही सर बोट ऑफ थँक्स आपलं हे स्पीचमध्ये ईडीचं कोण देणार वीरेंद्र देसाई आलेलं मॅडमने ते सांगायला लागेल ओके इथे Huh? Noko? Good morning, everybody, distinguished guests, esteemed colleagues, and dear friends. On behalf of the organizing committee, it gives me immense pleasure to welcome you all for the inaugural function of the International Thyroid Conclave. I would now like to request our esteemed dignitaries to grace the dais with their presence. The dignitaries for today's inaugurals are our chief guest, Dr. Chinnusamy Palanivellu sir, Chairman of GEM Hospital, Coimbatore, our esteemed guests of honor who have graciously flown in from beyond the borders, Dr. Pablo Moreno Llorente from Spain, Dr. Angkun Anuwong from Thailand, Dr. Sachin Naik, Professor and Head of Surgery Department, Mymar Medical College, and the organizing chairperson of the conclave, Dr. Tushar Khatsne, Professor of Surgery and Chief Operating Officer at Sri Saraswati Karad Hospital, Dr. Narendra Lohkre, Organizing Chairperson, Dr. Sandesh Gaude, Professor of Surgery and Organizing Secretary, and Dr. Shiv Mehta, Organizing Secretary of the conclave. We are just waiting for our founder president. So we'll just wait for them for 2 minutes, sir. No, tu आ रहा है. नहीं नहीं नहीं. A round of applause for Sir. We are very happy to have our respected founder president of Mayur Group of Institutions, revered Professor Dr. Vishwanath Karat sir, for the inaugural function. As part of our tradition, we begin our every auspicious occasion with the World Peace Prayer. The World Peace Prayer is a prayer put together by our own founder president, revered Professor Dr. Vishwanath Karat sir. It is a prayer not pertaining to any region, religion, caste, or creed. It is a universal prayer for bringing peace to the entire mankind. May I now request everyone to kindly rise from your seats and fold your hands in prayer and think of your teachers and gurus as we pray together for world peace.
प्रतिपाद्या जय जय स्वसंवेद्या आत्मरूपा देवातुति गणेषु सकलार्थमतिप्रकाशु म्हणे निवृत्तिदासु अवधारि बोधि गुरुर्ब्रह्मा गुरुर्विष्णु गुरुर्देवो महेश्वरः गुरुः साक्षात् परब्रह्मा तस्मै श्री गुरवे नमः। पूर्णमदः पूर्णमिदं पूर्णात् पूर्णमुदच्यते पूर्णस्य पूर्णमादाय पूर्णमेवावशिष्यते। ॐ शान्ति शान्ति शान्तिः।
Thank you. Please be seated. May I now invite Dr. Tushar Khatsne to kindly deliver the welcome address.
A very good morning to everyone. On behalf of the Board of Trustees, MIT Group of Institutions, the Managing Committee, the faculty and students of Maima Medical College and Shri Saraswati Karad Hospital, I welcome you all for this International Thyroid Conclave 2025. Firstly, I wholeheartedly welcome our beloved founder, Dr. Vishwanath Karad sir. Thank you, sir, for your blessings. As always, you have always been inspiring and keep pushing us to do better and be better. You, along with our executive directors, Dr. Virendra Gaisa sir, Dr. Suchitra Karad, all have been instrumental in support and guidance for such kind of activities. Welcome you all for this international conclave, and it is my distinct pleasure to welcome our esteemed chief guest, Dr. Palnivellu sir, and as everyone sitting in the audience have learned laparoscopic surgery, minimal access surgery from him in some form or the other, and his monumental Herculean work across all India for promoting minimal access surgery is so inspiring that we need to look no further beyond for inspiration. Thank you, sir, for accepting our invitation and gracing the dais. It has always been our endeavor to promote excellence in academics and have global perspectives, and we have with us for this conclave the international faculty, Dr. Pablo Moreno Llorente and Dr. Ankun Anuwong. Dr. Pablo from Spain and Dr. Ankun from Thailand. Yesterday we have seen excellent surgery live demonstration, and we have a rich day ahead with insightful talks. And thank you all for for coming here and witnessing the live surgery. Welcome you all, welcome all the distinguished guests all from all over the country, and especially the postgraduate students who have come in large numbers, and it is indeed a great opportunity to make the most of it. Thank you all once again.
Thank you, sir. We are privileged to have with us today Dr. Palani Velu, an internationally acclaimed surgeon, pioneer of laparoscopic and minimally invasive surgery. He's the founder chairman of GEM Hospital, Coimbatore. His groundbreaking contributions have transformed gastrointestinal surgery and inspired surgeons across the world. May I now invite our founder president, revered Professor Dr. Karat sir, to felicitate Dr. Palani Velu sir. Next, I'd like to introduce our guest of honor, Dr. Pablo Llorente. Dr. Pablo Llorente is a leading expert in endocrine surgery based in Barcelona, Spain. He's the head of endocrine surgery unit at the Hospital Universitari de Bellvitge. He has dedicated his career to thyroid, parathyroid, and adrenal surgery. He's known for pioneering minimally invasive thyroidectomy techniques in Spain, including transaxillary and transoral approach, to name a few. I'd now like to invite Dr. Suchitra Nagre ma'am to felicitate Dr. Pablo. I would now like to introduce our second guest of honor, Dr. Angkun Anuwong. Dr. Anuwong is a well-renowned laparoscopic surgeon from Thailand. He's one of the leading proponents of minimal access surgery, especially TOIVA. Currently based in Hong Kong, he holds a position in minimally invasive and endocrine surgery division of the Department of Surgery at Police General Hospital. May I invite Dr. Virendra Ghaisas to felicitate Dr. Anuwong. Another tradition deeply rooted in our Indian culture is of lighting a symbolic lamp of wisdom as a mark of auspicious beginnings. Light signifies knowledge, which is spread to one and all, and has been the constant endeavor of this entire group of institutions. May I request all dignitaries to kindly come forward and light the ceremonial lamp to bless this occasion with the light of knowledge and wisdom. kindly be seated. We are truly privileged to have with us a guest of honor from across the borders, and we are eager to hear their thoughts. May I now request Dr. Pablo to kindly say a few words.
Thank you very much. It was a surprise for me to know I have to say a few words. Just to tell you that I have no words to say thank you. It is my first visit to India. I'm impressed about your hospitality, about the way you organize things, and I really love your country. The few days I've been here, I can tell you that I like it and I love your country. Thank you very much for everything and for hosting me. Thank you.
Thank you very much, sir, for your kind words. May I now invite Dr. Anu Wong to kindly say a few words.
Thank you very much for everything. So this is my third time to India. Wow, it was very impressive. You know, Thailand and India has a very close relationship from ancient time. Even the religious, Buddhist, and culture spread from India to Thailand. So I feel like home right now. So thank you very much for this hospitality.
Thank you very much, sir, for your kind words. May I now invite Dr. Suchitra Nagri to address the gathering.
Thank you, Ojas. Very good morning to all of you. I'm standing here proud to represent Myanmar Medical College and Sri Saraswati Karad Hospital. And for all the dignitaries on the dais and off the dais, I would like to tell that it is the legacy of Dr. Suresh Ghaisa, sir, which we are carrying forward to give the utmost priority to all the academics in the educational institute. And I can just mention few that I think Virendra, the Department of ENT, we have started so many workshops in Myanmar Medical College, though it is a cadaveric workshop or Thyroid Conclave in 2007. Palnivelu sir was asking me yesterday that I think this is the first of its kind where only thyroid surgeries are focused. So congratulations to Department of Surgery and Department of ENT and the team of Sri Saraswati Karad Hospital who have demonstrated the surgeries wonderfully yesterday. And I'm so happy that all the stalwarts from the field of thyroid surgeries were present the entire day yesterday. And I was listening to the panel discussion in the evening. And I was so proudly having that feeling of leading this team of Myanmar Medical College and Saraswati Karad Hospital, along with Virendra and Sachin and Sandesh and Tushar. And thank you, Dr. Lokare, for bringing this idea to Myanmar Medical College for conduction of this International Thyroid Conclave. I think we all are blessed to have Karad sir with us today, and I think he is a source of inspiration for all of us whenever we are thinking of conducting some kind of event. He just says, go ahead, and there we are having a successful 2 days event. And I'm sure the lectures and symposium which will be throughout the day will give more inspiration to all the students, the junior surgeons, I'll say, to come forward and have their own techniques. We have Palnivelu sir with us who has the technique on his own name. So even if few students from this auditorium will have such kind of future in this surgical field, I'll be grateful and I'll be proud of all of them. Once again, I welcome all of you, all the dignitaries on the dais and off the dais, and I wish you a wonderful day ahead. Thank you so much.
Thank you, ma'am, for your encouraging words. It is my honor and privilege to invite our founder president, revered Professor Dr. Vishwanath Karat sir, to kindly share his thoughts and bless us with his valuable insights.
wants to listen to you. So maybe we can directly go with the keynote. All numerous add the chairs. Some presentation for the sir? You have slides are there? Slides are there?
But without slides also we can talk. But I'll take the slides, keep it here, no projection. But I'll talk.
There's been a slight change of plan. We are now going to have the keynote address by Dr. Palanivelu sir. It is my honor and privilege to introduce Dr. Palanivelu sir.
Already introduced, no?
So then
Okay.
a little more, sir, if you don't mind. Born in a humble background, Dr. Palanivelu worked hard with steely determination to achieve his dream of pursuing medicine to help the underserved. He completed his education doing MCH in gastroenterology and joined the Coimbatore Medical College as faculty, where he got inspired to do laparoscopic surgery. In 2001, he established GEM Hospital and Research Center at Coimbatore, which became the center of excellence in South India for laparoscopic surgery. He is the founder, president of the Association of Minimal Access Surgeons of India. Dr. Palanivelu's surgical work is marked by a number of firsts and innovations. He developed what is now called as Palanivelu's technique of esophagectomy for cancer esophagus. He was among the first to perform laparoscopic Whipple surgery for pancreatic cancer. He developed minimally invasive lap technique for excision of choledochal cyst with hepatocogenostomy. He has also used the hydrated trocar system for hydrated cyst excision. Single incision colorectal surgeries, lap gastrectomy for stomach cancer, and duodenal bypass for intractable diabetes are some of the surgeries that he has done. Regarded as a father of advanced laparoscopic surgery, he pioneered the spread of laparoscopic surgery all over India, introducing it, training surgeons, making it more accessible and cost-effective. He has contributed to the academic world along with his clinical innovations. He has over 200 peer-reviewed research articles and has authored many authoritative medical texts on laparoscopic surgery, including The Art of Laparoscopic Surgery, which is a Bible for upcoming laparoscopic surgeons. These texts have been translated or published in multiple languages, like Chinese, Korean, Spanish. Many of his articles and videos are used as teaching material across the globe. In spite of his achievements, he never forgot his resolve to help the underprivileged, and he has been a philanthropist providing free and subsidized surgery for the needy patients. He has been honored with awards including a fellowship ad hominem from the Royal College of Surgeons of Edinburgh. He was honored with the first BC Roy National Award for pioneering work in lap surgery in 2006 and again in 2016 as the Eminent Medical Person category. He has received an Olympic silver medal in International Olympic Surgery Award in 2009. He was conferred the Bhishmacharya Award in Minimal Access Surgery by the Amasi for a significant contribution to lap surgery in the country. I could go on, but with time constraints, I cannot say that we are indeed very, very fortunate to have a towering personality like Dr. Palanivelu as our chief guest today. Over to you, sir. Sorry.
Thank you for the kind word. Good morning to all of you. Respected founder, CEO of Mir MIT Center, and correspondent, and Suchitra, and management group, organizing committee, and of this International Thyroid Conclave. I am truly delighted and to be part of this event. And today, presence of Professor Viswanath Karath, founder, CEO, and truly have to introduce myself different way rather than saying our previous, the way introduced me. Sir, you and me are all not much age difference, maybe younger to you, Early 50s after independence, South India faced a severe drought crisis. So farming is the only way for a day-to-day living. No other way. We started moving to either Burma, Malaysia or Sri Lanka. That time Sri Lanka called Kandy, Malaysia called Penang or Singapore, and some of them to Burma. We moved to Malaysia as laborers. My parents were palm oil estate workers. And I was studying there Tamil medium because most of the states in Malaysia and the British guys knows how to impress us. Each state, nearly 80-90% people were in South Indians and Tamil-speaking people. So they had a Tamil school. I studied up to 5th standard Tamil medium. Then what I decided, after 62 Indo-Chinese war, I got furious against Chinese. Better I should go to India study. And decided to discontinue my way schooling. My parents could not have sent to me India, no money. So I worked as a daily wage laborer for 3 years. And before that, I was few months as a toddy shop accountant, 10 rupees per month. And 3-4 years gone. When I came to India, no school was willing to admit me because my age was 70, studied 5th standard, no certificate. Then finally one school, still that God, that headmaster was there. He admitted me in 8th standard in higher elementary school. I finished 8th, they went to 9th. 10th, God always punish if you do a mistake, because I studied in a different boy's name. Boy's name happened to be Palanivalu, but his father's name Periyasamy. Periya meant big, South India. My father named Chinnusamy, that means small God. See how I was debarred from school. And again, 1 year we fought again back to school. I finished SSLC age 21 completed. Then pre-university course I have to go, 22nd. In spite of this, I took a challenge that I want to become a doctor. Imagine, so many years struggling, financially nothing. Still I want to become doctor. Why? I lost my younger sister with pneumonia, no doctors. My own finger fracture, left ring finger is deformed. While working in the bullock cart, throwing stone, one of the stone crushed my finger, no doctors. That made me, I should become a doctor, so determination. And that God's grace, I could get distinction PUC, but no money to pay the fees for MBBS. My village, all the people collected money, supported me. Then I joined MBBS. Throughout MBBS, my village people supported me. Later, my professor surgery identified me, you will become a good surgeon, joined MS. Otherwise, I had no idea of how going to MS. Then I went to MS Madurai. Madurai saw cancer patients not getting proper care at that time. Okay, I should become a cancer surgeon. No MCH in gastro or onco available at that time. So I came to All India Institute, got training in fellowship, gastroenterology, went back. Then MCH came. I finished MCH. Then that's where life starts, my own. And the lucky was the laparoscopic surgery came in. I don't know how many people may not know, Manohar Joshi from Pune conducted the World Congress Digest Surgery at Delhi. And there Hollander showed a video of lap Kohli. That's not his video. He told, I am not doing laparoscopy. This is my friend's Dubois video. That video, I think, changed my life completely. But that video made a problem for Manohar Joshi. He was the organizing secretary of World Congress and Council of American Council that time. Why he showed a video before FDA approval? He was not only, he punished such a way, his membership was removed from the CICD, and that was the story that time. But luckily, that video helped many of us like this to want to. Sir, I think to say that is a way my life and coming to this field. That determination, while doing practice at Coimbatore Medical College, again the problem. Our farmers cannot to stay 10-15 days in the hospital and again after a couple of months again. So that also made, that is the time the keyhole I thought. I never thought it was going to make it so much revolution, but I decided to do it. First time doing it at Lab Kohli even before Delhi. That was the trend. Then I did a Lab Kohli. Then my mind started extending the keyhole to all the procedure. That is the time made it. And really, and today all know, and whenever I go to Korea, Japan, China, other countries, always feel we are master of all subjects, no? See, if you look at me, American, Japanese usual, he is doing one side Whipple, the other side doing hernia, the other side doing gynae, like, no? So one cannot become a master. Those days, okay, for teaching purpose I started. But my mind was there, like Korean should do stomach only, Japanese. Like, why not? No, that was a trend going. Now today I could see this program happened only on thyroid. That is where. And another thing, look at Western and countries. And I used to go to States frequently, American College of Surgery and SAGES, and but some or other, and want to pick up. And I could see the difference between here. They used to charge $1,000, $2,000 one day course for whether it is hernia or anything else. Americans. So for them money is nothing. They are everybody businessmen. I was little. I paid $1,000 for one day training, and that I was not even allowed to complete, finish the lab coli. And halfway through, 2 o'clock, no, time up. They removed the instruments, went back, $1,000. And 1991, imagine $1,000, how much? But no, dollar is not easy. Manmohan Singh later changed that thing, then next year, this way. So that was my mind, something we should do for Indians. How to do? Everybody cannot travel, spending money to go and come back. When the state or central is no budget for this kind of training, but if you go to Sri Lanka, they send. If you go to any country, they send. But here, if you send, you must be a political influenced guy or something else. No talent was recognized. That was a trend. That made me to something. Think over what to do, But Asian countries today, Angun said a word, spiritually Thailand and India is connected. 100%. Whole Asian countries, including China, somewhere we have a strong relationship. And if you go to history, 2,000 years, 3,000 years, 5,000 years, there was a binding between all these regions. And that, if you ask Koreans to come, you ask Angun to come, if you go to Japanese, they love to come to India to teach. If you call them, we want to have some surgeon to go to their place to learn, immediately they say, they provide opportunities. That is, if you go to West, you have to spend more money. But if you go here, you spiritually are bounded to do. So I thank both of the speakers. I had to go to Spain. I used to do life surgeries at Madrid. We have a strong relationship, very strong with them. And from my background, to do this level growing, it is all because of our Indian surgeons encouraged me to do these kind of things. That's why I don't want to move out of my Coimbatore because my native place. I want to be with the people. I became a doctor to do. So I think today, something keynote lecture, anything, subject, no point of talking to you, thyroidectomy or complication. Yesterday, whole day live surgery showed wonderful way. That theatre facility, Sujra, wonderful hospital you have, very nicely enjoys anesthetist, staff nurse, selection cases. Everything is so nice went on, and everything has been discussed. And then what is the point of talking keynote? Okay, I thought something else go beyond. So open, laparoscope, robotic. What next? That's why I want to tell the youngsters, now those days, if you want to become doctor, you can become doctor. You want to become a specialist, fine. Now, next 5 years, I don't know, none of us know what is going to happen, the technology going to. It is technology-driven world. We don't know how next year, after 2 years, 5 years, artificial intelligence, just like every day, something is coming up. And that's why we have to look at. 2 of my fellows from Coimbatore went to America. And you all know Tesla, you are talking to how so much. Everybody knows Elon Musk. But nobody talks about the man who made a Tesla car. The Tesla car was made by Coimbatore engineer, very young guy, and he's really admired. I met him, they were talking so much when I met in America, saying that our fellow young guys doing, even Mahindra, that electric car is, Veluchami is from near my village. So there were some or other, if you have some vision, then you can make it. That's why I thought few words about how we have to look at our future. That is more important here. And see, yesterday we all talked, okay, thyroid, yes, fine, thyroid, all these limitations. Every surgeon was very cautious yesterday saying what is their experience, what is literature. very nicely. That is the way correct. But beyond again, something we have to look at. And I am asking, how many of you know diabetes can be cured by surgery? Raise your hand. Raise your hand. Anybody? Just so 3, 4, 5 people. That means it is something, it's a new science happening it. When I was MS, I did not know that diabetes can be, diabetes means tablet, diet control, exercise, insulin injection, then have to die with a heart attack or some failure of kidney. That was the trend we know, public people also know. But when we did also, and many centers in the world did, and whoever not control the drug and exercise, then we operated, we did not know, we did bariatric surgery, but diabetes is gone. When we presented the technique, sages gave us best video award. But when we tell diabetologists in India, no, surgeons are bluffing. That's what they told. 2008 and 6, when the news came, patients saying, my diabetes is gone, but diabetologists say, no, it cannot be. See how people are against. Then 2010, American Diabetology Association made a guidelines and refined the cure. 2 years remission, it is good. 5 years remission called cure. Even cancer also cured, we call 5 years. Same definition they used. It article came in. Then the diabetologist agreed. Similarly, how many of you thought that transplantation going to make it life like this? No. Even a recipient liver, they are Koreans who made it, we are surprised. Now Indians also started doing it. So something we don't know, it is happening it. And never thought that hernia can be operated. It can be done without recurrence. And daycare, next day they can start working it. So that time we did not know. Recurrence always hernia, that's what taught. Cancer again, we thought incurable. No, cancer is also any other like disease. It is treatable. In fact, 50% of the cancers, we know why it comes. We can prevent them proper way. If not, early cancers we identify, we can cure. And this is, even if you surprise, if you do a colon surgery, gastrectomy straightforward, second, third day they can go home. Still, public people are fear of cancer, but even ourselves also. If any doctor also suffering that same problem. So science getting traumatic changing it. Then what is relevant to thyroid? If a thyroid one can do, I don't know. I'm not going to say this is where it's going to be, but we have to keep mind open. For example, flap yesterday, you have seen every surgeon raising the flap, different approaches, axillary, baba or neck, whatever in the oral. But flap can be raised and from entire anterior neck and laterally without flap necrosis if proper technique used raising the flap with the intact platysma. If you can raise such a flap, then you are creating a very big space. Pneumoperitoneum, when you created, abdomen becomes so much you have play. Those days thought keyhole do better open and see. But now the people says don't open, put it pneumoperitoneum, put a scope and see, because your space like a sky. You are working with a lot of ways. So similarly, thyroid also can be done neck. Okay, what else? Still cancer 2 centimeter only we can operate it. What to do? So any size, anything we don't know. Even the nodes, entire neck can be cleared, pakka, with the available technology, even right now. But I don't know next 6 months or 1 year. And abdomen again, we thought like a pneumoperitoneum, cancer, unique cancer. When I did 93 C rectum, patients accepted, surgeons could not believe. Then I have to do every cancer live. Even Whipple operation 98, when I did world first, so in short, none of the people agreed. 2000 sages gave award, but still surgeons were skeptical. Then coming, only a few surgeons accepted between 2000 2010. Then 2007 I showed a live at laparoscopy, then only they believed. Then again said no, robotic laparoscopy, robotic can be done, laparoscopy not possible. Again Hong Kong we had 2 screens, one robotic, one laparoscopy proved. Then finally 2010 is a year accepted lab Whipple. So any cancer possible, visible. Similarly, thyroid clearance also can be done. One may ask, spillage, everything. We have to look at different way like that. For example, those days we don't know cancer margin. Now we have a contact probe We have intelligent knife, and we put the tissue, it is cancerous or non-cancerous, it tells you, so that you know margin. Second thing is, robotic surgery, I don't know how many Japanese and Koreans revolutionized. For example, it is 3D, and open surgery, no doubt, yesterday, and you shown so much wonderful. But whatever you do, and the margin between the tumor and the vessels, plane, robotic surgery shows much more than here. And instruments are film, tin tip, work with the vessels. It is not like a bulky cutting. Tip, Japanese surgeons tip only, just like going the separation so well it can be done, clearance. And more than that, if it is necessary, even that vessel 1 or 2 millimeters or 5 millimeters infiltrated, that can be resected, sealed. So that's why it is all going. But what benefit? We may ask, ICG, target therapy, I don't know how many of you. ICG, not only detecting cancer, you can target with the chemotherapy, and suppose I've done RO resection, fine. But ICG shows extent beyond what I can't remove, then ICG tag can be used to focus that particular cancer control. Similarly, again, here also possible. When aortic artery aneurysm, when there is narrowing, 80%, 90% can do surgically, what else that cancer being a part of the wall, taking it? Possible. I'm not telling that to do it. Second thing is, so clearance also you have opportunity to diagnose and take it out. Resection also done. Not only that, I don't know, I'm getting a robo next week to my hospital, and that it is not like any other robo. It is with the artificial intelligence. I was holding the instrument, slightly holding it. It tells, doctor, you are holding tight, relax. See, it is artificial intelligence tells me how to hold, no? So even it corrects you. It makes you to hold instrument, hold, like a GPS. However, you are trained expert in car driving, without GPS, some places you cannot go because of the ways you identify. Similarly here, wherever you go, it tells you, plane, everything. You have a simulation put into computer, can find out. Not only that, now this robo, ultrasound, perioperative, you can do it. And not only that, entire CT, MRI can put into the robotic. During surgery, yourself you can see. So, we don't know the technology, how going to be changed. And they asked me to do it for next 50 cases to tell us, they want to know how performance of this robo. This is the first robo with artificial intelligence coming to India. They have not marketed it. And so let us have to see. And now, after 6 years, 1 year, the robotic system, how it is going to be? No, I will few slides. No, see, next, I will change, Yeah. Next slide. Yeah, changing, you change, yeah. So, here, however you are skilled, however you are in this, you can see open, you could do thing, loop also you can put it, you think it too much. Focused camera and project here, your tip of instrument will be shaky. Laparoscope, slide control will be there, physiological. But robotic complete instrument program, no tremor. Tremor, filtering the physiological tremor is the most important thing. Then you can save dissection can be done. Next slide. And here you can see it is a restrict type of physiological tremor filtering, sharp. That is where it is going. Next slide. And those days, robo, no feedback, haptic feedback. Now it has come. Even this robo which I am getting, it has got a feedback. And it is hereafter, what we learn, teachers should stab or do something teaching. Here it is going to be machine learning. It is already algorithm being done. So it is teaching itself is going to be simulation lab, this, then that likely going to be. And next one. And not only that, bigger size. So recently gallbladder has been studied with a robot. Nothing was, everything done by robo. And when it wanted to appreciate tissues, the tip knows detecting tissue, what it is. Suppose it goes by like a surgeon also going in different direction, no? Going cystic duct, oh, this is a cystic duct, it knows. Or cystic artery, if it is differently comes back and goes. Automatically did 35 cases, and without any complication, robot did the gallbladder surgery. Similarly, not like that big way, micro robots and medically operated, it is flexible. It is a kind of things going to come. And some places we can't reach at all, it can reach. Even a narrow space, magnified so much, you can enter like the way. And hybrid means not that open up hybrid. Hybrid means in addition to laparoscope, robotic surgery, artificial intelligence surgery, everything is coming called hybrid. Rather than call, it is a new technology for surgical practice. And there only MRI, CT, ultrasound already there, MRI, CT also intraoperative going to come. Right now we can put it, all the imaging what we have, we can visualize doing it. Next one. And telemedicine. Here, I can sit at Coimbatore, I can operate at Saraswati Center. And this is a different kind of things. I can ask, I'm going to operate an hour. Teaching also same thing, guiding it. And so, Japanese 4 years before, the Japanese Society of President spoke in American College. All the OTs in Japan going to be connected, making one OT complex. That every OT will have every facilities, surgeon can operate everywhere. They wanted to make it up. See how vision it is going to happening it. So expanding the specialized care to reach any part of the rural India as well as even Africa, anywhere. Next one. And see now, artificial intelligence, big data, tailored surgical individuals. It is, thyroid means it is individual patient is the more important, and depending on the type, tissues, reaction, everything. And it tells you when you are operating, you are going to make complication because the data has got artificial intelligence. It tells you. You must be cautioned every step when doing it. So complication is going to be less. Even post-operative enhanced recovery, it takes over completely. Next one. And semi, still now we are very happy because we are operating. It is only a semi. And future generation you can look at, it is going to be all mixed laparoscopy, robotic, artificial and 3D printing. And we are everything, virtual reality, augmented reality, all going to come. It is going to be something new, minimally invasive operation. There we have to keep in mind whatever it comes. And it is too much technology also confuse, disturb. But you have to choose the best of these, putting into, make it a safer to reach the goal of cancer cure or whatever surgery. Next slide. And I think this complication reducing it, and current percentage of mortality, everything it gives you. Are you fit to do that operation or not? That gives us our mark, how much you trained or not, it is going to tell us. Next one. And it is not only that, decision taking, execution, post-care, everything it is becoming. That's why when we went to Taiwan, that time we were talking, it was, see, like this. Here, like, it is becoming truly a guidance and feedback. Next slide. And new surgery for generation, what I thought, lab open, whatever, robotic. And something is robotic or any technology, keep it up. And minimal invasive way, cutting edge technology is available now. And hereafter, mostly cancer, we don't give blood, Whipple or esophagus now. And cancer surgery, tumor margins, it tells you, so incomplete surgery cannot be. And it is all going to be a guided surgery. So that's way, I look at that way now, and I don't want to go beyond. Next slide, I think it is over. So this is where we have to keep it together, joining it. So next surgery, we don't know, we have to pray and keep it open mind and ready to learn and to adapt it. And that is only based on the coming up. Those days, laparoscopy slowly came. Robotic also slowly took 20 to 5 years to come. But AI is not like, it is faster changing it that way. When I want to do the benefit to all patients making pronisvagectomy, all cancer, I'm so very happy. But now also I'm happy, but the cost is only going to be enhanced. And India government has to encourage to bring this technology cheaper and allow us to do it more. And people are still, 90% of people are ignorant about health. Problem is legally all this there. It is not just like we can implement. That way, I think, take it. And I wish, and this occasion to say, all of us will work together to make it a healthcare in India. But India is always considered very cheap, and everything is possible. Now we could have seen last 10 years the way it is getting changed. And founder, CEO of this, like, support the medical fraternity can brew. Already I'm happy. And the programs going on, teaching, it is very important in that way. And all institutions should support. Ramesh and Paulo, Ankon, every faculty, I'm enjoying life with them, that way. And this occasion, I take opportunity And I started briefly when told, I want to name the book. Kalam only asked me to write the book. He said, Palanivelu, your life interesting than me. And he said a hope-like title, but hope I felt. So I put a guts, nothing else with me. I put a poem, nothing poem, then only wrote this. So guts, boldness is the only asset which I could make it. I want to present to our founder, CEO. I invite Sujitra also and Professor, CEO of this institution to come. For library also I want to present a book.
Thank you so much, Dr. Palanivelu, sir. We are privileged to gain wisdom and guidance from a world-renowned surgeon.
Thank you very much, and since I have to go to airport, and congratulations to the organizers making a wonderful live workshops program, and thanks and appreciation to the institution for the giving support. Thank you very much, all the best. Thank you.
Thank you, sir, so much. It is my honor to invite our founder president, revered Dr. Vishwanath Karat sir, to kindly share his thoughts and bless us with his valuable insights.
My dear learned friends from the medical fraternity, and what a good wonder that I have a book in my hand by, what's the name? Palanivelu. I feel fortunate, and I am reminded of the year 1996, when I had called some gentleman from Tamil Nadu for making me understand what is the mind, matter and spirit and consciousness. These were the 4 words which I was in quest of. And today I got the answer for the same from my friend. I think I am not the authority to speak here, but being an engineer, having a little bit of understanding of all the new words like the artificial intelligence, Google, Facebook, all these new words which has opened a new vista for the entire world. And medical field is certainly going to be a very, very interesting and forward-looking area. I was thinking international thyroid. It's the international experts who have come here on thyroid. But thyroid will be same from the whole world, and every life, the smallest of the small living cell, which has the body, the brain, the soul, the spirit and the mind. And what is the chemistry of mind is the main question for me. He made a mention about the openness of mind. And possibly, friends, I had the fortune of 1996, when the first Parliament of Science, Religion and Philosophy, based on the words of wisdom, spoken by the great noble son of India, Swami Vivekananda, who had then speaking at the Chicago Conference, the first World Parliament of Religions, he had said one very important sentence. And he said, Remember, union of science and religion / spirituality alone will bring harmony and peace to mankind. ये मन की बात है भाई. What is the chemistry of mind is the main question which this medical area and the health department and the experts like my friend, they should try to guide the society. आजकल मन की बात होती है लेकिन दिल की बात होती नहीं. You know it, friends, I'm going to make some remarks. What is the world scenario today is the main question for every one of us. And you know it very well, the coronavirus and the COVID-19, which had shut down the whole world for 2 years. But is the Prime Minister, the President, and the chaos, confusion and bloodshed and the massacre which is taking place world over is so horrifying. And whether the doctors or the people in this field have also a duty to show the pathway. कि कोरोना क्या है, वह वुहान लेबोरेटरी कहाँ से आ गई भाई, कैसे जन्म हुआ, and wherever the Prime Minister and the Presidents, I don't want to make any names to be commented upon, but we as a faculty who have been concerned with the well-being of the society, maybe in the health department or the medical department, but equally true by educating the people and make them understand whether we can make a change of mind. And as I said, mind, matter, spirit and consciousness. Whatever the reasons may be, this meeting of all us coming together, having the great words of wisdom spoken by our keynote speaker, I have a very great satisfaction. This institution recently the world over there is a discussion, given in this institution, especially this very statement which I am making, philosophers sent Jnaneshwara to Albert Einstein. This is a universal statement, and when we say this, friends, remember, as I said to you, when I had the fortune of organizing the first World Parliament of Science, Religion and Philosophy, and for the first time the men of 3 different departments came together. It was Dr. Vijay Bhatkar, the great computer scientist, who was the guide for this mission. And I still remember we had been having some American gentleman that time who was given the prize for this philosophical thought and approach. And finally, when the Einstein or the great scientists from the medical field too, when they have said the time has come to start the schools of consciousness and reality, ultimate truth. What is the ultimate reality? What is the ultimate truth? And as I said to you, I repeat again, the words like the mind, the body, the brain, the spirit or the soul and the mind. And what is the chemistry of mind, as I said to you, which I do not know myself. So these are the various areas wherein the medical field and the people like the great people sitting here in the audience, they have to think on these lines too for the well-being of the society. It's a very long story, but I can say the scenario which you should see, the chaos, confusion, bloodshed, massacre, terrorism, horrible violence taking place world over, is also a concern for every one of us. We cannot isolate ourselves that I am only for the medical field And Einstein says you should start the schools of consciousness for ultimate reality. What is the ultimate reality? What is the ultimate truth? What is the Almighty God? Are these words of ridicule? Are these the words which you have to make them understand? The department like this, the medical care, or the right word which has been used in international thyroid, may be a reason, maybe a subject chosen. But this is not only limited to only thyroid, but the health department, and possibly we have to guide, really speaking. Coming together, I think I'll be grateful.
Thank you.
That we should come together and openly discuss these issues. That's my personal feeling. I'm grateful for giving me this book with the great words of wisdom. Thank you so much, sir.
Thank you.
Dhanyavad. I'm grateful.
Thank you, sir, for your pearls of wisdom and for illuminating this gathering with your vision and guidance. May I now invite Dr. Narendra Lokare, organizing chairperson, to deliver the vote of thanks and express her gratitude on behalf of the organizing committee.
Good morning, everyone. Respected chief guest, distinguished dignitaries, speakers, delegates, and guests. On behalf of the organizing committee, I extend my sincere gratitude to all of you for joining us today at the inauguration of International Thyroid Conclave 2025 in Pune. We are deeply honored by the presence of our chief guest, Dr. Palanivelu sir, Honorable Karad sir, and other dignitaries, whose inspiring words encourage us in our pursuit of excellence. Our special thanks to our special guests, Dr. Pablo, Dr. Ankung, for gracing this conclave, and our heartfelt thanks to speakers and experts for sharing their invaluable insights, which will guide and enrich our discussions throughout the conclave. Lastly, I thank all the delegates and attendees for their participation and enthusiasm. It is your presence that makes this event meaningful. Thank you once again. Thank you.
As we come to the end of the formal inauguration, it is time for Pasaidan. Pasaidan is a prayer written by the 18th century Indian saint Sant Jnaneshwar for the spiritual upliftment and well-being of the entire world. May I now request all to rise for Pasaidan. Basunath. Okay, no sir, no problem. So you can sit. Please be seated, it's all right. Please fold your hands, close your eyes.
Ata Vishwatmake Deve Yeri Vagyatni Tushave Tushun Madjave Pasayadanahe Je Khadanti
various states of India and the whole world. I would like to tell you this prayer which you heard. This is called the universal anthem. Okay. Every nation has a national anthem, but the whole universe, if it's to have a common universal anthem, this would be the universal anthem for the entire world. Not because it is Indian. It was written 750 years back by the greatest philosopher of the world, Sant Dhaneshwara, who wrote these words of wisdom and has given a message to the whole mankind. And he is the one who said that time, rising of the sun in the east and going to the west is an illusion. And there are so many statements like the Socrates and many other people. So please remember, it is not a national prayer, it's a universal prayer which has been put up in the UNESCO Paris office about in the year 1996 itself. So I am tempted to make a statement to you. Let us not restrict ourselves to only India, our own only religion, our own only the message which India has to give. You can see here on both sides. On one side we have Einstein, the Newton. On the other side we have the other great people. And see the two photographs which indicate to you a message to join hands together for a common cause of promoting the welfare of the society and promoting the culture of peace in the whole world. That's my personal request to you, friend. Thank you so much. I'm grateful.
We will now take a short break of 5 minutes and resume with our lectures. Thank you, sir. And this marks the end of our inaugural sessions. आपल्याला परत तिकडे लावायचे ते आहे ते नाव फक्त तीन आहेत ना आपले नेक्स्ट ह्याचे स्पीकर चेअरपर्सन्स प्रियांकाला पटकन बोलवून घे 5 मिनिटं.
Actually, we are lagging behind the time, so we will start the next session immediately. So it's not a 5-minute break, it will be a very short break. So please come inside the auditorium as soon as possible. Nothing less than anybody. Good. Nice. That's it.
So he's taken it.
So thank you. Santu. Sir, thank you so much, sir.
Pishupura Sanjay. Shanti Pishu. त्यांची एक हे घेतो.
कोण कोण येते त्यांना सांगायला पाहिजे. हां
I'll just get see if.
No, you don't go ना मैम.
No, but Jason sir है कि नहीं?
जैसिन सर तो मेरे को हाथरे सर ने सुबह बोला था ही.
request all the delegates to please be inside conference hall. We are starting the lecture of our guest from Thailand, Dr. Anuang, immediately.
Hello. Check. Hello.
Good morning. We're beginning with the next lecture for the day. First, I would like to invite our distinguished chairpersons for the session. Dr. Jaising Shinde sir, a respected senior surgeon from Pune, also served as the president of the Pune Surgical Society. Dr. Siddharth Shah sir, a prominent head, neck and skull-based surgeon associated with Zydus Cancer Center in Ahmedabad. And I would also like to invite Dr. Virendra Ghaisas sir, an eminent ENT and rhinoplasty surgeon from Pune, also the executive director of the hospital administration of Maimar Medical College, Talegaon. I would like to invite our speaker for the event, Dr. Angkung sir.
Cool. Thank you very much. Can I have my slide, please?
Hello. Hello. It's my proud privilege to invite Professor Anuang, who is a friend and my mentor for transoral endoscopic thyroid surgery. Hello. Hello.
Check. Hello.
Anuang is synonymous to what we know today as the true scarless thyroid surgery. He's pioneered and mastered this technique and is propagating this, teaching and preaching this technique worldwide. And he's been a very gentle, humble and a kind person, always approachable and always welcomes you with a big smile, always. I had a privilege of getting trained under him, and I invite you for this wonderful talk today. Thank you.
Thank you very much. So today I'm going to talk about the TOEDRA. So Dr. Narendra asked me to give you this idea, my tip and tricks for the beginner, because some of you here may not know about TOEDRA. So I will remind some history a little bit about that, and then I go straight into the step-by-step tip and tricks and end with my video. Okay. No conflict of interest. So what is TOEDRA? So you may know that it's referred to transoral endoscopic thyroidectomy vestibular approach, which is the true scarless thyroidectomy. Yes, absolutely no scar. And time flies so fast. You know, I did my first case in 2014, I think, and that is I think the first case was my operation. This is a picture captured from the first case, and remind me in the beginning periods of this transoral thyroidectomy, which is 2010 to 2014, I have the opportunity to meet this kind of people. Dr. Ines Karakas, Kai Wiesel, Tata Benichev, all from Germany, and Dr. Wilhelm as well. This is 3-4 guys from Germany. They are the group that's starting the transoral thyroidectomy but sublingual approach. but they don't know each other, but incidentally eventually they try to develop this together. I have opportunity to meet all of them, and then this is Dr. Kim from Korea and Dr. Wang from China. So we develop together, not only me, but we share idea and try to develop this thing together. And when I came back to Thailand in 2014, I did this. The first case, the transfer endoscopic thyroidectomy by aurovesicular approach. So I moved from the floor of mouth operation, the sublingual approach, into the aurovesicular area, which is better. And this is my first case, as I mentioned you earlier. This is Friday, 28 March 2014, one day earlier before my birthday. This is my birthday cake, I think. This is the 45 years old female, the right gynoid nodule 2 centimeters. I operate her about 2 hours post-op. And you can see that this is before surgery and after surgery, which is like nothing happened. So you can see that this is the endoscopic view of my first case, which is not nice at all. And this is a wrong plane. You can see the strap muscle up here. This is a wrong plane. But operation went very, very well. This reminds me that this might have the potential to be a good operation at that time. And then I had the opportunity to publish on Thai's newspaper in 2014. That's why people of the country know about this operation and came to see me. That's why I can develop good numbers. And I have opportunity to do a live demonstration over the Thailand in 2014. And then this is the, I think, the game changer of my life, because I have the opportunity to present the World Conclave of Surgery, which has been held in Bangkok, Thailand, 2015. I present this series of 60 human cases on that time. This is I think, the largest series on that time as well. It's just like a bomb, a boom, explode to all over the world. So many surgeons come to my place to see my operation, and I have opportunity to do academic traveling during the past 11 years. And you can see that I went all around the world to just to share my idea, to do lectures, and to proctor, and some country I can do the operation as well to teach them. So if you this is my papers, that comparison between grave disease, open thyroidectomy, and thyroid. You can see that the operative time is longer in thyroid. This is normal because of we have to have the flap dissection, equipment preparation, or something like that. But roughly around 30 minutes longer than open thyroidectomy. But other parameters, just like pain score, blood loss, is not. Blood loss and complications is not different, but somehow thyroid has less pain than open thyroidectomy. This is my data on that time. And another paper in surgical endoscopy, about 200 cases. And I can do in parathyroid as well, even the primary adenoma as well as the secondary or tertiary as well. And this is the comparative papers, the largest series on that time of mine, published in JAMA Surgery, compare the thyroid and open thyroidectomy. This is our data, and show that the operative time is longer in thyroid group, 30 minutes, and blood loss complication is the same. It's not different at all. It means that the safety is not different. And we found that thyroid has less pain comparing to open thyroidectomy with significantly data like this. So this is our paper. And not over the past 10 or 11 years, I did around 6,000 cases with less complication. Well, I have major complication like that. 3 major hematoma related to the size of thyroid. You know, at the first 4 or 5 years, I try to maximize my indication. That's why 10 centimeter I did with thyroid as well. But right now, do not do that. There's no time to experiment at all, because we want to do the safety for the patient. That 10 centimeters require open thyroidectomy because of major bleedings. So I have 10 conversion to open thyroidectomy, 1 infection I told you earlier, which is the penicillin-resistant drug as well, and 1 tooth tracheal injury, 1 CO2 embolism, and you can see the nerve palsy is not that different from the open thyroidectomy. It can be very safe. And right now, this operation is currently performing in 45 countries all around the world, all continents all around the world. And if you search on PubMed, you can see that the amount or the numbers of application is not increasing when search term the transfer endoscopic thyroidectomy. So this next is the patient selection, and this is the recommendation for not only the beginner but all of you as well, is my idea. Patient selection, current data criteria that I selected the patients who have this kind of operation. So you can choose benign, single, multiple nodule, including AUS, follicular neoplasm as well. Size does matter. Size does matter because for recommended thyroid size, 6 centimeter with oval shape is okay. But right now, if you want to be safe, I recommend about 4 centimeters. And you can do in velcro grave disease, in toxic adenoma, you can do as well. But if you want to do in cancer, remind that don't operate greater than 3 centimeters cancer nodule, because of you may have difficulties in extracting the specimen out, because cancer nodule is so hard. Not only that, for cancer greater than 3 or 4 centimeters, there is a chance to have the lymph node metastasis as well. That's why I try to limit my education like this. And if you want to do the reoperation, no more than 2 weeks, or you can wait more than 6 months is okay. This is the selection criteria. And this is absolute contraindication. Lateral neck metastasis, do not do that. Substenoid greater than grade 2. Grade 1 is okay, but grade 2, don't do that. Distant metastasis, adjacent organic involvement, medullary thyroid cancer, and uncrossing grave disease, you cannot do this with Edward. But for the beginners, just like if you want to start this operation at first, for the beginner, just like 1 to 20 cases, I recommend to do only benign nodule until you pass the learning curve. Only benign nodule, and the nodule should be less than 2 or 3 centimeters. 2 centimeters is perfect because of the gland is big enough for you to practice it. If the nodule is just like 1 cm, it might be a little bit difficult for you. You know, normal thyroid gland is very difficult for the beginner, trust me. 2 or 3 cm is okay for just to practice in the first few cases. And if you are a right-handed person, choose right thyroid nodule, because if you choose left thyroid nodule, you have to cross your hand. It's very difficult, or you have to do with your left hand. It's more difficult for you as well for the beginner. So right-handed person, choose only right side thyroid. And if possible, you can choose, or you have to choose a female patient, because of female patients, the female doesn't have a dump sample. A dump sample may obstruct or limit your movement of your instrument. Greater than 40 years old patient is better than teenagers, because teenagers tend to have the tense or fibrous or very tense tissue, so it's very difficult. So female greater than 40 years old patients, right thyroid nodule 2 or 3 centimeters is a very best candidate for the beginners, trust me. And no thyroiditis, no grave disease, no toxic, no cancer in your first cases, unless you pass the learning curve, let's say 20 cases or something like that. About the position in intubation. So in the old technique in 2014, you can read in my paper on that time, this is hyperextension, and I only insert the nasal-tracheal intubation. But the problem exists when I try to do the hyperextension, because of hyperextension tend to have the narrow working space comparing to normal position for thyroidectomy. Hyperextension comes with narrow working space and difficult to operate, especially in the long neck patients. And right now, current technique is slightly extension, then open surgery a little bit. No hyperextension anymore, unless the patient have the substernal goiter, I will do hyperextension. But for the normal thyroid, just slightly extension, then open surgery slightly. And you can use the orotracheal intubation or nasotracheal intubation. This depends on you, because of somehow you want to irrigate the IONM, the nerve module is the level. And port insertion is very important. So you may ask, you may heard questions from the audience that how about the maintenance of injury? Yes, you're right, because of we are operating here under the chin, which you have the mental nerve. So the mental nerve comes from the mental foramen here. So we here just in area between first premolar, something like that, and give the 4 or 5 branches, supply the lower half of the chins and the lower lips as well. You can see the red area. This is the right mental nerves over here. So in order to avoid the mental nerve, you have to have the better strategy to prevent it. In my old paper, you can see these pictures in my old paper. In the first paper, 60 cases, this is my own incision. In 2014, you can see that 10 centimeter horizontal in the center. And then you can see the green line vertical is referred to my previous port insertion. That have the possibility to injure one of the mental nerve. That's why I have maybe few cases of mental nerve injury. The patient and specimen extraction is very, very difficult because of the center incision is only 10 millimeter. So I refined since 2017 to be this. You can see that from center incision, just like 10 millimeter, I extend into the 2 or 2.5 centimeter instead. And I move the incision from here, from here into close to the lower lip as much as possible. This can avoid the mental nerve injuries, so 4 branches very well. And with the bigger center incision like this, you can extract your specimen more easily. Well, this is the picture when we totally insert the port, 3-port insertion. Well, I try to find the port from the company that has a very small head or small housing. If you use bulky housing port, 3-port together, you cannot move your hand easily. But if you find for this company, it's from a Korean company, or you can use some other companies' port as well, that help you very much in movement. You can see that the lining of the port, 3-port, is just close to the lower lip as possible. Below here is from cadaver. You can see that the mental nerves over here. 4 branches of the mental nerve. And port insertion is up here, right? So this can be avoid the mental nerve injury at the main branch very, very well. It might have a chance to make some injury to very side branch or small branches of mental nerve, which can be recovered by time, let's say 1 month. But the main branch will never be injured anymore. Well, I use harmonic. Also, in my case, you can use other instrument as well. It depends on your preference. For the camera, I use 30-degree scope. 30-degree scope play major role because of it's just like the top-down view. You can see everything, every structure, just like top-down view. You cannot use 0 degree. 0 degree is somehow difficult because of it will be conceal your operation or confuse your visual. This is a 30 degree. You can see everything. You can see the nerve here. But if you change to 0 degree, so your thyroid and your cricoid cartilage may obscure your vision. So you cannot use it 0 degree. Use only 30 degree rigid scope. I will show you how to do port insertion. So I use the Bowie a little bit and then use the clamp for get over past the chin. So here and make some blunt dissection just like Dr. Narendra did yesterday. It's the same. And then use the dilatation, a dilator, and then put the port in. So I skip it very fast. And then for the lateral port, you can see that up high here, just close to the lower lip as much as possible, and then inject the hydro dissection, and then do the port insertion for the bilateral port. So you can see that the linings of the port is keep close each other. Small housing port is very, very important. So it lets you to move your hand freely. Now it's a step by step. So after you entering into the scope, and I always use the hook as my right hand to create 3 holes together. You can see that the hole is made by dilator. 1, 2, 3. I will do dilate just like fan shape. 1 center, left and right, and then you will see a hole like this. 1, 2, 3 hole. So I use the hook to connect it together, and somehow I use harmonic for faster dissection. Try to create a hole just like the dome shape like this, and then you will see that below here is the strap muscle. Above here is the platysma muscle easily. And when you complete dissect, create the tunnels already, you may see that above here is the fat and platysma. Below here is the strap muscle. In this patient, he has the right thyroid gland, so you can see the strap muscle. Next step is to opening the midline, just like open thyroidectomy. I've used the hook with monopolar and do a shallow cut here, Do not do the deep cut at first because of you may make some injury to trachea and thyroid itself. And then you may do a shallow cut back here until you found here the cricoid cartilage. So question is that how do I know that this is cricoid cartilage? You may feel from the tip of the instrument, you may feel this is a bony sensation, which is the cricoid cartilage. This is the benefit of the endoscopic over the robot. So cricoid cartilage is the landmark. You can see that you can use the grasper, try to open up, and you can use the harmonic cut it, follow it down there to sternonotch, like this. Cricoid cartilage, your left hand, grasp and open it, and use the harmonic to cut it. Will be like this. So you will see that this is the thyroid here, thyroid gland. This is the white tissue, the white structure here is a trachea. And it will be like this when you export everything. Because you are standing here, you are standing above the patient's head, it will be just like downhill here. It's a cranial caudal view. So this is the cricoid cartilage. This is the isthmus, trachea, and then sternonotch over here. It will be like this. It's a very nice view. And then I will do the lateral dissection by do the pop-up manual. What is pop-up manual? You can use, left hand is a grasper. You can use left hand tie to make a pressure at the posterior side of the trachea as much as possible. And then you will see something like this. And then you try to do the capsular dissection. So this is not the plane. The plane is here. You can see this is sternothyroid muscles over here. You try to peel off here, just like peel the orange peel, using the energy device. You can use L-hook as well, depends on you, to export the real thyroid capsule as much as possible. You can see that my left hand is still push the gland down here, up here, like here. And then, and I think you have to cut the sternothyroid. If you don't cut this, it will be difficult to export the superior pole. How to cut it? Use the L-hook and cut it back like this. Cut it back like this. Cut it back. So export this as much as possible. And then you will see the everything. You can see the superior pole. And I would love to use the external hanging suture because of in open thyroidectomy, we use the Army Navy to track the strap muscle to the lateral. But in endoscopic, we don't have that. So I will make the, this is a silk or white crew, depends on you. Silk number 220, and then make the suture from outside and wrap around the sternothyroid as much as possible and go outside again. And let the assistant to pull the string. And then I will start from the pyramidal lobe dissection. So use your left hand. Your left hand is a grasper. This is the cricoid cartilage, right? Use the left hand, grab the tissue above the cricoid as much as possible, and then cut it below here. This is the way to start to cut off tissue just above the cricoid cartilage. This is very helpful when you try to dissect in cancer patients because of you want to get rid of the delphin lymph node as well. And then when you get into this, you will see the white structure here, which is the trachea. So you cut the isthmus here, down there. It will be like this when you cut everything. So you remove the pyramidal lobe here, you remove the delphin lymph node, and then you cut the isthmus. So this is the trachea. And then there will be an superior pole dissection by let the assistant to pull the string into the lateral as much as possible, and then you have everything. Oh, time's up. Okay, I will hurry. So, and when you export it, you will see the carotid artery to the lateral. And then I will go into the jaw space, accessing the jaw space. Jaw space is the key point because of you will be easily access the superior thyroid. Jaw space over here and push over, and you will see the external here. You can see the external branch over here. If you come here and make a U-turn here, this is the external branch. So you lift it up and you cut above it. External branch. It will be like this. This is the right side external branch here. This is the jaw space. For the left side, the same story. So lift up the jaw space, and this is the external branch over here. and then you cut the superior pole. And you will see the parathyroid here, upper parathyroid, and then preserve it. And then there's the lower parathyroid over down there. And then you will see the nerves over here. Recurrent nerve will expose in front of your eye when you do appropriate action. But somehow you may think that this is the recurrent nerve, and then you cut above the nerve. That is not right, because of you can see some structures over here above it. It's an anterior branch of the recurrent nerve, which can be found in this operation 30 to 40% in my experience. In the literature, it says 40%. In my personal experience, I found it's about 30 to 40%. Be careful about that. It can be happen to you. And it will be like this when you complete cut the anterior branch and posterior branch. It's very important. And somehow you may see here, what is it? This white structure, it is a non-recurrent nerve. It has to be, in some cases, I found it is 6 cases of the 6,000 cases, non-recurrent nerve in the right side. This can be as well, non-recurrent, be careful. And then nerve monitor can be very helpful in the beginning of your try. So if you have it, you can use it, and it's very useful, trust me. And then I will complete the lobectomy by using the harmonic to cut above the trachea and then dunk it into the specimen. And when you remove it, you have to use the sponge forceps, go inside the bag and then grabs it. We use push and pull technique. So your left hand is pushing the bottom up, while your right hand is trying to squeezing and go along the curve of the mandible. Okay, it will be like this when you have a complete evidence. You can see that the lymph nodes here, level 6 and 7, you can perform this very well. It's very, very clear. And make a suture later. And the wounds here are closed with 2 layers. The muscle inside and the oral mucosa is continuous lock. And I will make a pressure dressing around chin for 24 hours. Maybe overnight is okay. Overnight and then remove it. It's okay. That's it. And the diet, on day 0, they can sip water and drink water. And day 1, in the morning, they can have liquid diet and soft diet as well. And day 2, they should start from the hospital with regular diet. Okay, I know. Okay, this is video. That's it. Thank you very much. Yeah.
Due to paucity of the time, we'll be taking the questions during lunch. Thank you so much, sir, for this very valuable session and for teaching us the tips and tricks for performing endoscopic procedures. And I also thank the chairpersons for chairing this session. I request Dr. Kachne, sir. I request Dr. Naik sir to come and felicitate. I request Dr. Siddharth Shah sir to stay back for the next session and also for the felicitation program.
A very good afternoon, everyone. I would like to call upon the chairpersons for the next session on robotic thyroidectomy. A renowned laparoscopic and robotic cancer surgeon, Dr. Sailesh Putambekar sir, the famous laparoscopic and endoscopic surgeon, Dr. Suprashant Kulkarni sir, the laparoscopic and bariatric expert, Dr. Sanjay Kolte sir, and a well-known otorhinolaryngologist and head and neck skull-based surgeon, Dr. Siddharth Shah sir, who is already present with us. We welcome you all. I would now call upon the great academician and honorable speaker, Dr. Amit Agarwal sir, on the stage for this talk. Sir is a pioneer in general, laparoscopic, bariatric, and robotic surgeon with multiple fellowships. He is a senior consultant at BL Kapoor Super Speciality Hospital and owns his own surgical center. Over his career, Dr. Agarwal sir has contributed through numerous publications. Sir is a frequent speaker and educator at national and international workshops and masterclasses in minimal invasive surgery. Over to you, sir.
Good morning. Thank you. Very good morning, dear chairpersons. At the outset, I'd like to thank Dr. Naren and his team for inviting me to Pune. This is my first visit to Pune. I'm really enjoying it. Yesterday was really an academic and a surgical feast. and we had wonderful surgical display of minimally invasive thyroidectomy. So in the next 15-20 minutes, I'm going to share with you, give you an overview of the robotic thyroidectomy, the different approaches, and how I do it. So this is my previous place of work. I was in SGPGI as the head of the Department of Endocrine Surgery, and this is my new place of work. I bring greetings from Medanta Hospital, Lucknow. So I'm very fond of this slide. Dr. Pablo is here. All Europeans tend to think that the word goiter was discovered by Italians way back in 16th century. But in our literature, 2,500 years back, in Shushruta Samhita, the word goiter is described. And in fact, he has described the different types of goiter. So this is like 2,500 years back. So we have a rich ancient history of goiters. In the modern world, thyroid surgery carried a very high mortality, and it was in fact banned both in the Europe as well as across the Atlantic. However, from that festering time, it is the work of these 7 thyroid surgeons who have delivered the thyroid surgery as we see today. And Dr. Capra is here. Yes, Dr. Cocker is always on a slide when we talk about thyroid. So the initial emphasis was on decreasing the mortality, but now the concentration has shifted. We all talk about giving better cosmetic results, prevent recurrences, and prevent complications. So today my talk is focused how to give a better cosmesis to our patients. So the surgical approaches of thyroid removal could be an open approach, an endoscopic approach, and now the robotic assisted approach. Why do we need these? You know, in this part of the world, there is a greater sensitivity for these anterior neck scars. And therefore, the traditional thyroidectomy produces a scar, which in expert hands may not be that bad, especially after 6 months after surgery, but they do leave a scar behind, which our patients don't want. And therefore, these alternative or remote approaches were developed. The application of robotic was in other areas, and it was a matter of time only before it was applied to thyroidectomy. We are all aware of the advantages of thyroidectomy, and just to reiterate, more precise dissection, improved visualization, good magnification, surgeon-controlled visualization, and you have a tremor filtering system as well. And of course, you have a greater degree of movement of the instruments. Now, robotic approaches initially started with transaxillary, and we are all aware of Chung from Korea, who really popularized. He now has done more than 5,000 cases with transaxillary approach. But then the Baba approach was devised, which was more near to our open traditional method of thyroidectomy. It was modified to a rabbit approach. We have a modification of rabbit approach. The facelift approach or the retroauricular approach did not really become very popular with the surgeons. And then we have the latest is the robotic Toitwa, which is truly a scarless approach, but has a very steep learning curve. So I'll give you briefly about the various advantages and disadvantages. This is the common view of the area of dissection in robotic Baba approach. And it involves different stages. I'm not going into detail. We already had a session yesterday. So, but the thing to understand that it is the closest technique to our open traditional method. It gives a very symmetrical view of the thyroid. And these are the 4 ports which you use in the Baba approach. But it is modified rabbit approach from the surgeon in Bangalore. The advantage with the rabbit approach is that those who do not have an exposure to endoscopic surgery can actually utilize this approach, where you make the ports through an open technique. There is no need for an endoscopic dissection of the flaps, and it's very fast. Actually, you do the entire flap dissection with the robo. So it just takes 5-7 minutes to, in fact, dissect the entire flaps, and I'll show you in a video soon. We all are aware of the limitations of endoscopic approach. We have a 2D representation, and the flexibility, of course, now with your flexible endoscope, that limitation can be overcome. And the endoscopic assistant should be experienced, and the learning curve is actually rather steep as compared to robotic. So this is very funny, you know, robotic thyroidectomy has a less steep learning curve as compared to the endoscopic curve. Briefly, the transaxillary approach is a good approach, but if you have to perform a total thyroidectomy, perhaps this approach may not be the best. And it does carry a small amount of risk for non-thyroid related complications like brachial plexus injury and anterior chest paresthesia, which can be very discomforting to the patient. A retroauricular approach is now, of course, out of favor because there was a lot of injury to the marginal mandibular and the angular nerves. The transoral approach is really a good approach, but there is a steep learning curve and you cannot perform a lateral neck dissection with them. That's the biggest limitation of the transoral approach. Baba approach, as I mentioned, is very symmetrical. You have very nice view of both the lobes of the thyroid. You can perform lateral dissection, you can perform central dissection, all the nerves are safely preserved, But as I mentioned, the endoscopic raising of flaps is a bit time consuming, and this limitation is overcome in the modified rabbit approach, where you can raise the flaps with the robo. Patient selection is very important. We have talked about it yesterday at length. This is the initial ATA guidelines, and you see how the guidelines have changed. They mentioned that don't operate for Graves' disease and substernal extension, previous neck surgery, but now we are operating on larger nodules. I think Gyan operated, as he mentioned, on a 10 centimeter goiter. So the extensions, the indications have expanded, But for a beginner, as Anu Wong mentioned, you should choose an ideal patient, a small goiter, a female more than 40, unilateral, benign. That's important. So I hope this video works. So this is an open technique, or the Baba, the modified rabbit approach. On the right side, the axillary incision is made, and you're raising the flaps. But I must tell you, I have recently changed the technique and went on the left side first, because then the scissors are in your right hand when you dock the robo. So in this, you dock only two instruments, and your scissors are actually in the left hand. So you have to raise the flap in the left hand. But if you start on the left side, you put the scissor in your right hand. So now my preferred side is starting from the left side. And the breast port is placed within the areola, so that the scar is almost invisible after a couple of months. So this is the right side breast incision being made for the second port. So after these two ports are made, then you dock the robot. Not the full robot, only two arms. And then you raise the flap till the opposite side, and then you put the rest of the two ports on the left side. So raising of flaps is very quick in this method. Sorry, I made this robo for uninitiated people just to see how a robot actually moves. So the green light over there, you see, that's meant for targeting. But for thyroid, you don't do targeting. But for abdominal procedures, you do targeting. So at the moment, I will be docking only with the two arms, raise the flap, and then move on the opposite side. So I've raised the flap, and now I'm making the other two ports on the left side. Because once your flaps are raised, putting in these ports is very easy. You just put it in that space that has already been created. In SGPGI, we had two consoles for training purposes. So when we sort of purchased, we insisted that we have two consoles. All training institutions should have actually two consoles. So this is the flap raising that is done. I prefer to use monopolar scissors. Gyan showed that you can use monopolar hook as well. When you purchase a robot in an academic institution, you get a set of 200 free cases. So therefore, we could afford to be a bit more liberal. So I'm using 3 instruments. On the left is my bipolar, and that is the CADIA or ProGrasp. He is your best assistant. That's the advantage of Robo. You fix it, he won't crib at all, you know. That's the advantage. So these strap muscles are being taken off from the thyroid. I prefer to go from the superior pole first. The tip of the scissors works very well, you know. So that's the space being created. Initial few cases I used harmonic, but harmonic in robot is only one-time use. It's very expensive. And there's no need. You have a fantastic bipolar. This bipolar works very well. Now on the inferior pole, I'll stop when we see the nerve, then I'll stop. So once I established the program at SGPGI, then Gyan took over when I moved out from SGPGI, and I'm sure he's doing a good job of the cases. We are a training institution, so it's good for the trainees, our MCA students, to have an exposure to robotic surgery. So you can tease the tissue out with your bipolar. That's the advantage. Any kind of bleeding, arterial, venous, you can manage with bipolar. Now at this point, I change the camera port and swap it with the instrument so that you have a symmetrical view of the end-on view of the thyroid. So some of the movements in robotic are a bit different from endoscopic. So you have to sort of unlearn your endoscopic maneuvers when you do robotic surgery. So that's the nerve, and you couldn't see the audio, hear the audio, but in the next video I'll show you how they use the neuromonitoring during robotic surgery. So that's the nerve. That's the parathyroid being dissected down. Okay, so I'll move to the next video. So just look at the beep sound, which is kind of music to the ears of an endocrine surgeon or ENT or thyroid surgeon. So this beep is very important, and you can use neuromonitoring very safely in robotic surgery as well. You just connect the probe to your monopolar scissors. Instead of diathermy, you use the neuromonitoring. A couple of cases, I started with transaxillary, but I was not happy with this approach because you need a very special retractor. It keeps slipping, so that's not the best approach for robotic. Then we move on to the BABA approach. This is one of the cases we did a bilateral approach, small tumor 4 into 4 centimeters. This was the specimen. The third case, this we used the modified rabbit approach. It was a larger nodule. It was 5 into 5 centimeter. And we did it by a modified rabbit approach. Then we became a bit bolder and we started doing for even a toxic nodule. So this was a case with the toxic adenoma. This is the scan showing the adenoma on the left side. And this is a specimen. Then we used total thyroidectomy for a multinodular goiter. This was the specimen, total thyroidectomy. And this is you can see the scars are hardly visible. If you give it intra-areally, the breast scars are hardly visible. Then this case we did this was a case of PTC. We did a TT with CCLND. So doing CCLND is very easy with the BABA or the rabbit approach. This was a modified rabbit approach for a total thyroidectomy in CCLND. And then we did a transoral approach, as Anu Wong showed. This was a 2.7 centimeter nodule. And we did a robotic toitwa in this case. And this is the incision here. This is the postoperative picture. So we moved gradually from a hemithyroidectomy for a benign goiter to total thyroidectomy, and then for papillary cancers, and then the transoral approach. So I think as a beginner, we should gradually move to attain expertise. And we started with the axillary approach, then the BABA approach, the rabbit approach, and then the modified. And now I'm very comfortable with this modified BABA approach, rabbit approach, especially from the left side. So unfortunately, in endocrine surgery, there are very few robotic programs in the country. One at SGPGI at Medanta, we have one in Chennai, one of the students is in Bengaluru, and then Jaipur. So very few endocrine dedicated robotic programs are running in the country. We were talking about Kusum curve, so every surgeon can frame a Kusum curve for their cases. And you will know when the learning ends and the period of acquiring competence, then the acquiring of the expertise, and then mastering. So this Kusum curve, each surgeon should actually sort of make it. This helps the trainees to realize that how many cases you would really need to develop an expertise and mastery in this case. So robotic rabbit approach gives the best symmetrical view of the thyroid, both sides, laryngeal nerve, the parathyroids. It's oncologically safe for intrathyroidal PTCs. The crucial word is intrathyroidal. You can easily perform lateral neck dissection, central dissection in these techniques. Learning curve is not very steep, that is very interesting. And it can also be performed by those who have not had any endoscopic thyroidectomy experience. You can easily graduate from open surgery to robotic surgery. So thank you very much for your kind attention. And if there are any questions, we'll be happy to take it.
Thank you so much, sir. It was wonderful presentation and very, very knowledgeable.
Thank you.
Any questions? Yeah.
It is very delighted to know all these recent advanced techniques of the approaching to the thyroid. I go back to our residential days. In 79-80, of our faculty, ENT, Dr. S.R. Patil in Sangli Miraj Medical College, that time he completed 300 thyroidectomy under local anesthesia with cervical block. How do you quote about this? That was so simple. It was simplest, economically also very good. Patient recovers, has got less any complications. And we are leaving that end, which is the best, and we are hunting here. It's good, welcoming, but how you comment about that?
Yeah, I won't be really able to comment about the thyroidectomy and the local anesthesia because I and my anesthetists don't have any experience. But of course, it's good to know different techniques of anesthesia and different techniques of surgery. See, the whole idea is that surgeons should have all the techniques in the armamentarium, and you give your patient the best. If the patient demands, insists, you can give a robotic technique. If the patient does not afford financially, you can do an open surgery. So these are techniques to master by each of us. Of course, we cannot do everything, but whatever contemporary is there, we should try to master that and offer the best to our patients.
Yes. We have absolutely come from horrid surgery to the present surgery of thyroid. So thank you so much for your excellent presentation, sir.
Thank you.
I would like to thank our speaker, Dr. Amit Agarwal sir, and our esteemed chairpersons. I would now request our moderator and chairpersons to kindly take their seats. I now call upon Dr. Priyanka to head for the next session.
So we begin with the symposium session for the day. First of all, I would like to welcome the moderator for the session, Dr. Rakesh Neve sir, who's the current director at Sterling Multi-Speciality Hospital, Nigri, and LifePoint Multi-Speciality Hospital, Wakad. For this, I also invite the chairpersons, Dr. M. Devakar sir, who is a prominent ENT surgeon at Kowai Medical Center, Hospital, Coimbatore. Dr. Shrikant Solav sir, who is the founder of the well-known imaging and diagnostics center, Specs Lab, Bavda, Pune. Dr. Apurva Mundada ma'am, oncopathologist from Tata Memorial Hospital and currently working as a consultant at Dinanath Mangeshkar Hospital. And Dr. Gyanchand sir, who is a highly experienced minimally invasive and robotics endocrine surgeon in Lucknow. Dr. Amit Agarwal sir again, and also Group Captain Surjit Bedi sir, who is a distinguished general and oncosurgeon serving as the professor in the Department of Surgery of AFMC, Pune.
A very good morning to all, and I welcome all my panelists. Next slide, please. So I guess the pathologist is not so we have a comprehensive panel with us with unfortunately the most important person, the pathologist, not around, and that is something which actually decides what we do on each case. Having said that, we will try to, because all the surgeons here are very experienced and they can actually cover up for the. So we start off with the 27-year-old lady who has got a swelling on the left side of the neck since 2 months. I guess I will not get into very basic things like thyroid function tests and all that. But yeah, the first thing could be an ultrasound. So would you like to take the first question, sir, as to what is the role of ultrasound in thyroid cancers, in well-differentiated thyroid cancers?
Ultrasound is a very important investigation, as you rightly mentioned. What we ask for is ultrasound with color Doppler, so high resolution ultrasound. So it gives you a picture whether you are dealing with a benign nodule or there are chances of malignancy. And I would suggest that when I write ultrasound thyroid with TIRADS classification with elastography. So I'm sorry, I'm just adding something to it. So when you have a complete, so you need this information to arrive. And if you have TIRADS 4 and above, and the size is more than 1 or 1.5 centimeters, you would go for the next set of investigation. So ultrasound really helps you to predict, especially the TIRADS scoring, about the possibility of malignancy. So our main concern is to rule out malignancy in a thyroid nodule.
So after he has pointed out the characteristics for malignancy in a nodule, are there certain features, Dr. Devakar, for the nodes?
So apart from the primary thyroid nodule, we look for neck node metastasis. We examine the central compartment and the lateral compartment in detail. Ultrasound is very sensitive in picking up small pathological nodes, nodes which contain metastases which are generally 1 centimeter or more, and therefore not only to know the characteristics of the primary nodule to stage the neck is also very important. Where ultrasound lags for assessing neck nodes is where if you have a bulky thyroid tumor, you cannot really assess the central compartment neck nodes, the nodes which are usually posterior to the thyroid gland. So that is one limitation if the tumor is bulky.
I think two features should ring a bell, you know. One is if the nodes are cystic and if they are microcalc in it, the possibility of PTC is very high. So besides other features, these two features are very important.
That's what exactly I also wanted to highlight, that if a sonography is a very excellent tool in even identifying the nodes, barring the central compartment nodes, which obviously will be hidden by a thyroid malignancy or a growth there. But otherwise, sonography is very useful, and it identifies cervical lymphadenopathy in more than 30% of the cases, which would obviously change the malignant management upfront. So, Dr. Surjit, would you like to take the question? We all know about the anatomical location of nodes, and what is the most common location of metastatic nodes in DTC?
It's talking about this thyroid, especially the nodes that are affected are, we call it the lateral group, you know, level 2, level 3, 4, and the central lymph nodes which are affected normally. And we also talk in terms of involvement to the level 5 also, depending upon the location of the nodules in the thyroid malignancy. Normally what we generally see, level 2B nodes are not generally involved in cases of thyroid malignancy that we see.
Correct. That is the most common situation. Only for upper pole in certain situations, very rarely you could have those nodes involved. But otherwise, as he has appropriately mentioned, these are the most common nodes we should clinically look for, and also ask your sonographist to look for them. So guided FNAC is obviously a given thing, and I guess non-guided biopsies should not be encouraged at all, though a gland looks normal or whatever, but just do it. So in this case, I guess the pathologist here is now, Apurva is with us. So would you like to add something about the molecular testing? Do you do it? Does any one of the panelists actually do it? Molecular testing for as an adjunct to FNACs? It is open to all of you.
Actually, FNACs, we follow the Bethesda system to report. If it is a proper malignant report, it means papillary thyroid carcinoma. But otherwise, the other follicular or the oncocytic, the other tumors, they fall in the category 3, 4, which remains a dilemma for the treating clinician. That is where you can apply molecular testing. If you have that BRAF V600E, that typically points that it is a papillary thyroid carcinoma. If any other mutations, RAS mutation, it is for follicular, but still there are follicular adenomas also which can have a RAS mutation. So basically, if you are using molecular testing for FNAC, only BRAF V600E is what will help you to make any kind of decision.
Would you like to take the question?
So, molecular testing have 3 roles. One is dubious condition like Bethesda 3 and 4, where you want to confirm and limit your surgery. So in that case, it is important. And second is to prognosticate. If the very aggressive tumor, if you have and you want to prognosticate, then only it is important. And third is about some cases where you want to do some further metastatic tumors and you want to do some targeted therapy. In that case, molecular testing is required. So these 3 conditions where the molecular testing is very useful.
So my policy for nodules in Medanta is that if you have a Bethesda 3 or 4, I would give an option for the patient to go for molecular testing of the aspirate. Most of the patients do agree. And as rightly mentioned, if I get a BRAF V600E mutation, possibility of PTC is very high. Not 100%, but very high. and I'll go for surgery. So that helps to convince the patient to undergo surgery, and as Gyan mentioned, it helps you to decide whether to go for a hemithyroidectomy or a total thyroidectomy. Because BRAF, though controversial, literature is, controversy is there, but still, to my mind, if BRAF is there, it does confer a poorer prognosis. So I would go for a total thyroidectomy in that case.
Yeah. Can I add a quick point?
Yes, please.
The molecular testing is not widely available. It is expensive. So bearing that in mind, I don't routinely ask for molecular testing for Bethesda 3 and 4. If the patient is going ahead with surgery, for example, based on the size of the nodule, then molecular testing has a very limited role. Where it has a role is if you opt to observe the patient with Bethesda 3 or 4, and if you do molecular testing, if it is negative, then it kind of gives a reassurance that you can keep the patient under follow-up. But if it is positive, perhaps you can urge the patient to go ahead with surgery. That is where I think it's very useful.
Yeah, I think because of the availability of high-resolution ultrasound, you are getting a lot of patients with very small nodules, 1 centimeter, 1.5. I do recall a couple of patients who had a family history of papillary cancer. Now, this is a very difficult situation. Patient wants us as doctors to tell them 100% whether it is malignant or not.
Correct.
So molecular testing, if available, and it's not very expensive, now fortunately it's widely available, it's a good idea to get it done. So at least for the postgraduates to remember, that's a good thing to ask for. If the patient can afford it, go ahead and do it.
Since the topic of surveillance has been brought out, Dr. Surjit, would you like to comment on that? Do the Indian thyroid guidelines even consider active surveillance and or not?
For the Indian setting, I'm not sure, but for active surveillance is known to, is described as a part of a ATA guidelines for something which is less than 1 centimeter. And the patient is, the individual is, he's an intelligent patient who can be followed up. We have the facilities available to follow up the patient. And the patient understands what we're talking about. The whole understanding of the patient has to be counseled for this thing, and it has a shared opinion that we take. So active surveillance is known for a lesion which is a low risk, less than 1 centimeter that we can follow. Unilateral.
So, would you be okay if there are multiple nodules with all less than 1 centimeter, with one of them proven to be positive for active surveillance?
So generally, it is described for something which is unilateral, very small, and which can be kept on close follow-up as such. Generally, for multifocality and all these things, generally not described.
Okay, so this was a large follicular adenoma, but there was a small focus of papillary carcinoma there. Single, less than 1 centimeter, there was no extra thyroidal extension. Apurva, as you have seen that there is a mention of BRAF mutation there. Do you mention such kind of findings in all your reports? Is it mandatory, and what is the role?
Yes, actually BRAF now we have an IHC, which is a very cheap option as compared to the molecular testing. So it is recommended you do the IHC for any kind of non-invasive tumors with a follicular pattern and papillary-like nuclear features. This is a very small focus. Have they commented on invasion? There is no invasion. So basically, and BRAF is also negative. So I think this is good to.
So what would be the surgeons going to do ahead with this particular patient who has undergone a left lobectomy outside and come to you?
Yeah, just micropapillary thyroid cancer. So just you have to observe, counsel the patient, observe very low risk patient. So it's not need to go for the completion total thyroidectomy in my mind.
Yeah, I would agree with Gyan, but again, BRAF positivity, the surgeon and the patient should keep in mind, and a close follow-up is really required for the patient, but definitely no completion thyroidectomy.
So if there were some difficult mutations found on that, do you also do the other mutations like what have been mentioned here on the histopath specimen?
No, on the histopath specimen with IHC, we just have BRAF V600E IHC. That is, it will detect only the V600E. the 600 position alteration of the amino acid. Only that mutation can be detected by IHC, but if you have to detect the other mutations, we have to go for next generation sequencing or Sanger sequencing. All that.
So would
but
you...
approximately 45% of the PTCs have this BRAF V600E.
So when you have a low-risk patient to classify, you go in for NGS testing as she is asking for every patient? Or
Not required.
Not required. Now, there was a mention of a 7x4 mm nodule on the other side on the sonography report for this same patient. So would it change your thought process, or you would?
Of course, what was the thyroids of that? So if you have thyroids 4 and above, of course, at that time perhaps a decision for total thyroidectomy would have been taken. But if it's like thyroids 1, 2, 3, you can follow it up.
And once you are only doing a hemithyroidectomy as a definitive treatment, Dr. Sujit, how would you follow the patient?
The patient, normally what we do is to follow the patient about 6 to 12 months depending upon the risk status. If the patient is a high risk, then we can do it about 6 monthly. But normally what we follow the patient
This
is
particular
yearly.
patient who has low risk lesion?
Generally we follow yearly. Annually ultrasound can suffice in this patient also.
Okay. Dr. Divakar, any comment on whether this patient should be referred to a high volume surgeon if he requires a completion, if she requires a completion thyroidectomy, and what is your take on that?
Yeah, good. I think there's a consensus in the panel that this patient requires only further observation. There's no role for completion thyroidectomy because it's a sub-centimeter differentiate thyroid malignancy. There are no features of thyroiditis in the specimen as far as I could tell. So she is at a lower risk for long-term hypothyroidism, but still 6 monthly follow-up, at least initially with TSH and ultrasound for the next 24 to 36 months to monitor the contralateral thyroid nodule and to check for hypothyroidism, and to keep the TSH within the normal range should be our target. Once we cross 24 to 36 months, then we can be more relaxed with the follow-up, maybe an annual follow-up. For how long, it's open to debate. It's between the physician and the patient to decide.
So just in case this patient, which typically happens with our Indian scenario, where once you tell the diagnosis of cancer, they would say that get rid of it, whatever maximum thing you want to do. In that case comes into the situation play where the experience of the surgeon counts. So what is the panel's consensus? Who should be called a high volume surgeon?
So there are a lot of interesting papers, and the figure of 100 has been proposed, that if the surgeon is annually doing 100 cases, labeled as a high volume center or a high volume surgeon, you know, and the complication rate, nerve palsy and parathyroid is less than 2% and 1% respectively, you know. So that's a definition of a high volume surgeon. And of course, the completion thyroidectomy is not like reoperative, because I'm sure the first surgeon would not have gone on the opposite side and looked at the lobe. So you have a virgin field. So you should consider it as not a redo thyroidectomy, but a upfront thyroidectomy. So complication rate should not be higher. But having said that, a high volume surgeon is of course preferable to avoid any complications.
Sir, one thing more is like Professor Madan Kabre has said that reasonably high volume center, like more than 35 per year. So even the 40 is acceptable. And same like Amit sir is saying that it is not going for the completion, is not going for the like recurrence of the surgery, recurrence of the thyroid cancer. So in this case, just one lobectomy he is done, it is just like the opposite lobectomy. So same surgeon can perform the completion thyroidectomy in this patient.
I'd just like to add some interesting thing, you know, there's a British Thyroid Association, and if you want to become a member of the association, you have to upload your results of nerve palsy immediately after your surgery. So there the patients, if he wants to go a thyroid surgery, he just has to Google and see what is the palsy rate of different surgeons, you know.
Okay.
Unfortunately, this is an ideal scenario, may not be possible in this part of the world. But of course, no thyroid surgeon should produce a palsy, so whether low volume or high volume, you know. So it's really difficult to go around and define a high volume surgeon in India.
Yeah, because you're saying 100, and I guess 2930 is what is the international standard for. And I guess most of our surgeons, you have something pertinent to point? Yes, please.
So there is a paper by Duke Healthcare System, which is a US-based healthcare system which surveys the all this thing. And there in that paper they have defined what is high volume center. So starting from 0 to 5 and all. So according to them, anybody who has more than 25 cases per year is a high volume center. That's what I have recently kind of learned about it.
So what I'm quoting is a Julian Sosa's paper, and she was pioneer in defining the surgeon. But so she has defined, and is accepted by most Americans, is probably 100. Yeah.
It was a very nice case and very common case with everyone. And thank you so much panelists for such a nice discussion. I have few queries. First, can I ask?
Yes, please.
My first query is to the pathologist. What is the role of HBME IHC in this patient, as this patient has a follicular adenoma and a follicular variant of papillary cancer? Second, will you label it as a cancer? Because for the past 10 years, follicular variant of papillary cancer have been renamed as a non-invasive papillary, like papillary neoplasms. So will you label it as a cancer now? It's only 1 centimeter.
See, the WHO new classification that has come up in 2022, now we have a total shift. Now the classification goes according to the cell of origin and the differentiated and the grade. Basically, it tries to define tumors based on their aggressiveness, invasiveness, and not just on the morphological features. Earlier, we used to give a lot of preference to the nuclear features. That is how papillary thyroid carcinoma got defined. So that is why that entity of NIFT-P came into picture, because even if the pattern is follicular, we gave so much of preference to the nuclear features that it was called NIFT-P. But now, after these years, we have understood that NIFT-P is a very, very indolent lesion. It cannot be called as a cancer. So it comes under a lesion of low malignant potential. And moreover, the size also in this was less than 1 centimeter. So it is equivalent to a NIFT-P. Earlier, when NIFT-P was defined, the papers did not include lesions less than 1 centimeter. That is why that dilemma was there. But less than 1 centimeter, following the strict guidelines that for the diagnosis of NIFT-P, it is a NIFT-P. Without invasion, it can be called as a non-invasive follicular thyroid.
Thank you so much. That answered my question, because if it's a NIFT-P, then there's no role of completion thyroidectomy.
And HBME1 IHC also, it is not a very robust marker. It is used when we are in a dilemma if it is benign or malignant, but it is not a very easy to set up a test and to interpret also. It is used by pathologists, but not a very great test.
Thank you.
Anyway, while one cannot really decide where the patient lands up into with a high volume surgeon or low volume surgeon, but what the important point the panel has brought out is that whenever you're doing a surgery, a left lobectomy or whatever, try to be as clean as possible, so that if you need to go in again, the planes will be clean for the coming surgeon to operate upon. You try and not just do a nodulectomy or something like that. Try to follow the anatomical principles, demonstrate structures, and make it safe for the further surgeon to come in. This is what the panel also wants to bring out. The first surgery should be a clean surgery, so that there will be a chance of giving better results for the completion surgery if it is required. You want to add something?
Not only the clean surgery, so if the surgeon is quite enough skillful that he can preserve the parathyroid and recurrent laryngeal nerve of one side, that means he is able to do the completion thyroidectomy, and he can preserve the parathyroid and recurrent laryngeal nerve of the opposite side.
Well, the second case is a old lady, 67-year-old lady who has a swelling since 40 years, and the change of voice she experienced since 3 years. There was some difficulty of swallowing since 1 year. Then there was a sonography done in 23, and then a repeat sonography done now in 25. So the initial sonography also showed that there was a Thyroid's 3-level mildly suspicious lesion in the right lobe. However, the patient did not do anything about it. The patient came down with, because these kind of symptoms, would you consider a CT scan in this patient? Because we were saying ultrasound is good enough, so would you consider a CT scan?
So this patient has bilateral nodules which are around 3 to 4 centimeters, and there's no evidence of lymph node involvement. And I presume clinical examination shows normal vocal cord movement. And
well, that also I'll come to. The vocal cords shows paresis on the
And then the patient also has dysphagia. Is that correct? Has
difficulty.
So all these are raising alarm bells that this patient might have invasion of the upper aerodigestive tract, even though ultrasound shows kind of probably a less invasive picture. So she will be an ideal candidate for cross-sectional imaging in the form of contrast CT scan.
So cross-sectional imaging, which would you prefer, CT or MR?
I think as surgeon, I can't read an MR, so I am very happy with the CT. So CT, contrast enhanced CT. And as for your next question, whether contrast can be used or not, so that's a myth, Now the studies have proven that after 4 weeks, you can do a radioiodine scan very well. So there is no need to, not do a CT because you think that a radioiodine scanning is required after surgery. So in a PTC, go ahead and you do a CT. Gives you a lot of information. And just to add to that, for any multinodular aorta, I prefer to do a CT scan. It tells you whether there are any thyrothymic rest or not. I have seen surgeons missing out the lower pole nodule, which is detached from it. This all can be seen on a CT scan. So unless the nodule is very small, otherwise for a PTC and a multinodular goiter, it's good to have a good CT scan before surgery.
This was a CT scan, and the FNAC, however, was benign. It was reported as goiter only. So the initial surgery that was done was right hemithyroidectomy. So with this patient, any role of FDG, Dr. Solar, please?
Well, as per the guidelines, FDG PET is not indicated in staging of thyroid cancers. You straight away go for surgery after doing the ultrasound clinical examination. CD, I beg to differ. I have made my voice hoarse telling, please, thyroid gland per se is rich in iodine, and it gives you, adequate information. You use MR, and as far as possible, whenever possible, for God's sake, if you do not want to vitiate subsequent treatment with radioactive iodine, for God's sake, avoid contrast CT as far as possible.
That's an exactly opposing view.
This was a controversy, I agree, but our nuclear physicians would agree with us.
Institutions, I agree with what you said. Tata Hospital also, they do contrast CTs. Yeah. I have come across cases where it gets blunted and then the TG keeps on rising. I mean, we have divided.
No, but blunted for how much time?
As sir, betadine, any preparation which because stable iodine is imbibed not only by the thyroid, but it also is imbibed by other tissues.
Can you give a time frame? Suppose I do a CT scan, how much time later I can go ahead for a radioiodine scan? It can't vitiate forever.
2 months.
2 months.
Minimum.
2 months, 4 weeks, 6 weeks is 4 weeks is what literature says, but as far as possible we can avoid. That's a definite thing. But coming back to the MR thing, there are people who say that MR creates a lot of motion artifacts and it's not a very good tool, especially to evaluate thyroid. Is what again the literature says. I would be we don't have a radiologist on the panel, but it would be an interesting thing to see, because most of the neck now, larynx or anything, I would image with an MR. So here why we should be hesitating to use MR is a question. Now this was an angio-invasive follicular thing, and papillary carcinoma with 4 centimeter size lesion. this was how actually it was. I don't have. Can you run the video on the top? So as far as cord paresis, there was a cord paresis on the and the lower one after the surgery it recovered. So it was some kind of an odd compression. Khalsa run kara.
So it recovered.
It recovered. So it was a 4 centimeter with vascular invasion, the papillary thyroid carcinoma with no nodes on the scan. What would you do?
Can we go back to the pathology report?
The pathology report is not exactly completely available. So for the discussion's sake, we get on to 4 centimeter tumor with angio in vascular invasion, and that's all. No extrathyroidal extension.
So we have a 60-year-old lady who underwent effectively a total thyroidectomy with a unifocal 4 centimeter follicular variant of.
No, she has not undergone. She has undergone
I see.
hemithyroidectomy.
Right.
So whether would you go ahead with completion thyroidectomy?
And it was done. Completion was done. No, it has not been done. Okay,
No,
sorry.
no.
So we need a little more information from the pathology as to other adverse features, as to how much vascular invasion was there, how many vessels were involved. The cutoff is 4, and once this information is available, then we need to take a decision. She's on the older side. She's 60 years, 4 centimeter. These are all pointing towards a slightly more aggressive neoplasm. So I would be in favor of a completion thyroidectomy. And then depending on what that pathology shows and what the stimulated thyroglobulin shows, the question is whether to give radioiodine or keep the patient under a follow-up with thyroxine replacement or suppression.
So would you like to highlight the guidelines for extent of surgery in situations, generally for all the audience to?
Yeah, before that, can I ask my pathologically, angio invasion, how important is it in papillary as compared to follicular?
Yeah, normally follicular tumors show vascular invasion, and the papillary shows lymphatic invasion. So according to the new guidelines, it is expected that we write in our reports if it is vascular or lymphatic invasion, the number of foci, less than 4, more than 4. And we have to be very sure there are strict guidelines regarding invasion, because the endocrine tumors have vessels with fenestrated endothelium. So the morphological features what we feel may not be real invasion. For that there are strict defined criteria according to which we say ki it is vascular or lymphatic invasion. Plus nowadays necrosis and the mitotic activity has to be taken into account, because in a differentiated cancer also there is a high grade category, which if the mitotic count is more than 5 per 2 millimeter square, or there is a necrosis, it will confer a poorer prognosis.
So can the surgeons point out to the various situations where you can consider lobectomy and where you would advise total thyroidectomy?
Low risk or a high risk? And she was 60 years, 4 and more than 4 centimeters, so she belongs to high risk. And then you have to follow the guideline, as you rightly mentioned. She would definitely need a radioiodine remnant scanning and therapy if required. So low risk, intermediate risk, and high risk classification is mandatory. After your surgery, when your report is available, and then you reclassify it at the end of 1 year of follow-up, whether the patient still belongs to high. So that's kind of a dynamic follow-up, where you can downgrade your patient from high risk to low risk. And according to the risk classification, you decide about radioiodine and you decide about the TSH, level of TSH suppression.
She did mention about the necessary things that a pathology report should have. Now we come on to the nodal clearance. In this case, would you do a nodal clearance?
She didn't have preoperative imaging nodes?
No nodes on the preoperative.
So what my policy is, we open up the lateral compartment. If we find a node, we send it for frozen section. And if it is positive, then you go ahead with dissection. Especially if you have central nodes. And I am a man who does a prophylactic central dissection, but it may not be universally followed. But at least a unilateral central dissection perhaps would help this patient.
So this patient has already had a hemithyroidectomy, and we are now proposing to go ahead with the completion thyroidectomy. And the question is whether we would address the central compartment in the previously operated neck. If that is the case, I wouldn't do it. That neck has been already operated, and I would like to let sleeping dog sleep. I don't want to go back in an operated neck and cause more harm than good. A follicular variant is less prone to lymphatic metastasis than a papillary carcinoma. So keeping that into consideration, I would just do a left or the other contralateral completion thyroidectomy, and that will complete the surgical treatment.
So there is no role of prophylactic thyroid lymph node dissection, but if it is there, if you do the again, once it becomes the malignant, you again recheck the scan or discuss with the radiologist. If you find any node, then you can go for the, or intraoperatively you see and you find there is a node and you are suspecting that it may be positive, then only you go for the neck dissection. But prophylactic role is not there.
Yeah, so inspection of the central compartment is very important. There is no imaging method that will tell you there is central node. Intraoperatively, unless you enter the central compartment, you would not know there is node or not. So my teaching to my residents, always open up the central compartment, look for the nodes. If you find the nodes, do a clearance. If you are an occasional surgeon, you may do a hemi-clearance, and if you are an experienced surgeon, you can do a bilateral clearance. The incidence of nodes is related to the size of the tumor. So the tumor, the larger the size, the greater the possibility of a central node and a lateral node. So if a T4 tumor or a T3 tumor, the chances of lymph node is very high. So open up the lateral compartment, you find a node there on the IJV, take it out, send it to frozen section, and believe me or not, 9 out of 10 times you will find that the node is positive.
That's what the data also suggests, that positivity is very high in PTCs, and you have to be very alert on the nodal status. And as he has pointed out rightly, the intraoperative findings are very important in deciding whether you go ahead with the nodal clearance lateral or central, or both. That is also, you will have to decide on intraoperative findings apart from the previous clinical and pathological data that you have. However, though the nodal positivity is very high, the outcomes are good, and therefore you need to be very careful when you consider doing central lymph node dissection. Also, we have to be selective. In this particular case, though, I could retrieve 2 nodes from the central compartment. One of the node happened to be the parathyroid gland also. So it does happen with whatever expertise you have, you might end up. So out of the 3 nodes which I thought I had sent from the ipsilateral central compartment, one was a parathyroid gland. So this is what is, there's a differentiation made between therapeutic and prophylactic. So I'll go with the next slide, which we were discussing about radioiodine ablation. So everyone did mention that radioiodine is an important adjuvant therapy, and it should be considered. So when would you avoid giving radioiodine therapy?
Low risk patients. Yeah, very low risk as well. Yeah.
So while we do consider radioiodine, what are the typical preparations that you would do for doing radioiodine scans?
Yeah, absolute. With withholding iodized salt, as I said, avoid use of betadine intraoperatively, avoid as far as possible use of contrast CT, and all food which contains iodine, like non-vegetarian stuff, should be avoided, and cough syrups which have, or some antidiarrheals which have iodine, they should be avoided, and that's about it. And patient has to be prepared well, in the sense that you have the TSH rise of about more than 35 units, so as to allow, And the objective is to ablate the last normal and abnormal thyroid tissue. The objective is to make thyroglobulin as a tumor marker for surveillance. It's, so that the body is free of thyroglobulin producing tissue, and TG becomes a good tumor marker for surveillance. That's the objective.
So what about the iodine contained salt? So would you
iodine containing
salt, iodized salt?
It has to be withheld. What we normally say is khada meat bolte hain. So we ask them to have either that, or some people advocate to warm up the iodized salt so that the iodine. Some people advocate that you warm up on tawa so that whatever iodine content is minimized or it evaporates. That's how you can sort of prepare the patient. Those who do not have ready access to rock salt.
So would you give recombinant TSH or would you wait for 6 weeks? What is the
to answer?
The horse nail is costlier than the horse. That's what it means. I don't have the heart to tell my patients that 95,000 rupees is what you need for the 6,000 rupees for the scan and 95,000 rupees for RTSH. It makes no sense to me. So unless a patient is really, really affording, when we can, you can plan. Otherwise,
so I think two things need to be clear, and I think you are the best person to answer. Do you think the pickup rate is better with endogenous hypothyroidism or with recombinant TSH? A lot of studies have been done which have compared head to head whether thyrogen injection preparation gives you a better number on sites of metastasis as compared to endogenous hypothyroidism. So what is the answer to that?
The rate of rise of TSH is obviously going to be, the kick is much higher with RTSH,
but that is,
no doubt.
Does it translate into the pickup?
No, actually it doesn't. It doesn't.
So there is no added advantage, but having said that, there are people who like management graduates and other people who are very busy people who cannot afford a kind of lethargy for 3 weeks off thyroxine. And if they can afford it, it's a good thing to give. And I do give an option to my patients that they can have thyrogen injection so that their normal life is not disturbed. But of course, finance is always an issue.
Some people can use, T3.
Yeah, now we have Lenormand or T3 available.
Yeah.
I hadn't had the experience of using in this situation, but other situation I have used T3. But thyrogen should be advised to the patient if they can afford it. Their quality of life is maintained.
Yes.
If a patient is 3 weeks post-op, patient is having all the signs of hypothyroidism, okay? But if you have done a TSH, and I think if the TSH is 35 or 40, I think there is no need to give the recombinant, though the patient is having lethargy and myxedema and evidence of all the hypothyroidism. I think we can even go ahead and do a RAI scan, isn't it?
Of course, but for example,
I think TSH level should be given more importance.
No, suppose I'm a surgeon and I get a PTC and I cannot afford to be off thyroxine for 3 weeks.
Yeah.
I need to operate. I want to be fit. If I can afford it, thyrogen is a good thing.
Yeah.
So apart from affordability, the patient condition, sometimes some patients are not tolerate this off thyroxine, like some situations, medical situations in that case, or in case of very aggressive tumors. In those two situations, you have to be consider this recombinant TSH.
I was asking whether the TSH should be given more importance or the duration should be given more importance.
There is
TSH,
a correlation.
Yeah.
After 3 weeks of thyroxine, you will get a TSH of 30.
No, sometimes we don't get that. Those are the patients in whom.
So there are two situations, and I have had 2 patients. One who had a pituitary tumor, and there was central hypothyroidism. The TSH will not rise with off thyroxine. There will be no endogenous rise of TSH.
Yeah.
The other patient had follicular carcinoma with metastasis which are functioning. Follicular carcinoma which was hyperthyroidism.
Yeah.
So in these 2 situations, the endogenous rise in TSH will never take place.
Right.
So there you have to give thyrogen.
Okay, I am running out of time, but it's still an interesting case. I'll just put a quick one question to all the surgeons here. This is a thyroid mass which is seen on PET, papillary carcinoma, and lung mets, and isolated brain met, what would you do?
Brain mets.
Yeah, isolated brain mets, multiple lung mets, and papillary thyroid cancer.
Yeah, and radioiodine status? Negative.
Not
no uptake.
Not done.
So
no, not done. This is the presentation.
This is yeah.
This is the presentation.
Yeah, see, we have very limited options available, but radioiodine scanning is a must. Radioiodine is the best drug for, if there is uptake, nothing like it. If there is no uptake, then we move on to the use of TKIs in these patients or not.
No, means before surgery, I don't think that's an option. Surgery.
No,
so we should consider surgery or no surgery?
Yes, unless you do a total thyroidectomy, you cannot take the advantage of radioiodine. Because all the radioiodine will be taken up by the intact thyroid. So thyroid has to be removed.
That is because the patient does have a lot of lung mets, bone mets. So still a thyroid surgery should be performed.
I do recall a patient who had lung metastasis, very high risk for surgery. We convinced the anesthetist that she requires a total thyroidectomy. Unless we do that, we will not offer palliative treatment to the patient.
And even my neurosurgeons are intent to operate on this. So first would be total thyroidectomy with nodal clearance if there is nodes. Then radioiodine therapy.
No, then we can go ahead with the brain surgery.
Then brain surgery, and then
radioiodine. Because you have to remove the bulk of the tumor, reduce the amount of radioiodine that has to be given to the patient. Am I correct?
Yeah, actually surgery plus concurrent radiotherapy, external radiotherapy for the brain. Yeah. And as soon as possible, you do radioactive ablation.
He has no symptoms for the brain, so I am wondering whether, I would probably operate the brain also.
Radiotherapy will not really,
For the brain lesion?
No, if there is a solitary lesion and the neurosurgeon feels that he can safely remove it, a cytoreductive surgery is definitely required. Patient is fit for surgery, and then you go for radioiodine. So radiotherapy really, unless the patient is not fit for surgery.
In this patient, I would not like to make the patient hypothyroid after total thyroidectomy because it will increase the cerebral edema, and whole brain radiation is a better option in this kind of patients, followed by radioiodine therapy. Especially in these patients, if it is a macronodular, and if a CT guided biopsy can be done from lung mets, it is worthwhile because many a times we have seen concomitant lung cancer with papillary thyroid cancer. So sometimes we think that it is metastasis from thyroid.
How much was the TG here?
Yeah, tuberculosis is very common in India, so it could be associated granulomatous disease.
If it is sky high, TG is more likely to be metastasis.
Okay, we haven't done the TG levels here as of now.
So this is the only situation where you have a metastatic disease, but you need to operate on the primary.
Yeah.
So that's a good case.
So I will finish my panel. I thank all my panelists for an interesting discussion, and it is definitely enlightened all the audience here about management of differentiated thyroid cancer. I would like to thank the organizers for giving us an opportunity to do so. Thank you.
Thank you, Dr. Nakesh Nevis sir and our esteemed team of panelists. I now request Dr. Divakar sir, Dr. Shrikant Solav sir, Dr. Apurva ma'am and Group Captain Dr. Surjit Dwivedi sir to please wait for the felicitation. I also call upon Dr. Pramod Umarji sir, our MMC observer for the Thyroid Conclave. I call upon Dr. Tushar Khachne sir for the felicitation of the panelist. Dr. Upurva ma'am. Dr. Divakar sir, Dr. Shrikant Solav sir. And Captain Surjit sir. would now our MMC observer, Dr. Pramod Umarji sir. Thank you, everyone. We shall begin with the next session on what's new in minimal access thyroid surgery, tips and tricks, for which I would call an award-winning skilled laparoscopic surgeon. Over to you, sir.
Good afternoon. At the outset, I'd like to thank Myanmar and Pune Surgical Society, Dr. Narendra, Dr. Sachin, my friends, to invite me here. I am honored that the originator himself is sitting as chairing person, so respected chairpersons. I may talk something much more than what you expect. So, slides please. So when we talk of thyroid surgery, three things come in mind. Cosmesis, compression symptoms or malignancy would be the indications. Aim is to try and maintain thyroid function as much as possible, avoid injuries to nerves, parathyroids, attain whatever possible cosmesis with decrease morbidity and mortality. Why newer procedures came and how it has progressed, this is a physiology to understand. So, in the surgery has been documented in 952 when the goiter is to be removed under opium sedation with simple ligatures where hot irons is to be placed inside thyroids. Then it progressed to two cetons being tied all along the goiter and tightened on a daily basis so that the goiter gets separated. However, the first successful partial thyroidectomy was documented in French Revolution. So most of the about 40% mortality was documented in simple thyroid surgeries in that era. So this was a banned surgery and was left only for patients who had respiratory obstructions. Then came a revolution where the improvised anesthesia, antiseptic technique and effective artery forceps was documented, and that's where we started getting safe surgeries. And in 1909, Theodore Cocker got the Nobel Prize for his work in thyroid surgery. So classically we have large incision. So comparatively you have a longer hospital stay. The patient has whatever said done, has post-operative pain. And yes, the scar lies in front of the neck and hence cosmesis is concerned. Though laparoscopic surgery prevailed somewhere from the late 19th century, minimally invasive surgery came in thyroid surgery much later because finally whatever advantages of minimal access surgery came, Gagner was the first person who did subtotal parathyroidectomy, not thyroidectomy. However, Usher was given the credit of doing first right thyroid lobectomy, not even hemithyroidectomy, in 1997. This was the timeline how it has progressed, and one of the originators is still sitting here. So the entire concepts of minimal access surgery revolve around if you have a shorter distance between the incision to the thyroid gland, If you can provide best cosmesis, you can have a relatively good anatomic view and a explicit operative protocol. You can adhere to all oncological principles. It should be cost effective, so you should be able to do with regular instrumentations, and techniques should be simpler so that you can have a shorter learning curve. So various techniques have been devised. So you have seen yesterday a transaxillary which has been propagated by Ikeda et al. Somewhere in 2000. Professor Anuvang in Toyota. I would not go in detail of these surgeries, but I would try and show some surgeries which are not mine. I have no exposure to posterior auricular approach or the other few approaches, but I would try and show some videos which have been done, some by me and some by other eminent faculties. So let me go to it. Yesterday you saw surgery done by Dr. Parathyroid and later by me as transaxillary. This is a video assisted. So you have about 3 or 5 centimeter incision along the lateral border of pectoralis major, where you have a large right angle retractor goes above the pectoralis major, and with conventional instruments, the surgery is done with a video assisted. So the similar kind of field what you get as in transaxillary surgery, but instead of having robotic or maybe laparoscopic ports and instrumentation, you can have a clear vision. The camera goes up to the site of the organ, nearly conventional instrumentation and maybe ultracision used for dissection. So the major advantage of laparoscopy, where you have a vision going near the organ, so good magnification, understanding all parameters, and a good control without having any insufflation. You can see the right lobe being separated. You can see the superior pedicle, which has been tackled. With a want of time, I would not go in detail. So here you can see the recurrent laryngeal nerve that is being separated, and now going for, you can see the recurrent laryngeal here with the inferior parathyroids. So these approaches can be enabled for patients whom you really are not wanting to do a transaxillary approach. These are usually done by conventional, at times use laparoscopic instrumentations. So these are all feasible procedures, and just because you have a dilated port about 3 centimeters, you can take out the specimen from the incision. However, these procedures would require a drainage for this. This is what I have been shown. Now, this is one procedure which has been popularized by in Europe, especially in Italy, reserved for patients who have not more than about 2.5 centimeter nodules on either side. The major advantage of this procedure is you can do this procedure without giving any extension to the neck. However, you have about 2 centimeter incision onto the anterior aspect of the neck, and with the help of video, with proper neuro monitoring, you require only 2 instrumentations. You may require one grasper, one forceps, and another forceps like Vectis, which has an inbuilt suction device. So you can appreciate the amount of clarity what you can get, because the camera itself is going inside, and you can try and tackle small vessels so that you can avoid any injuries to the nerves as well as the parathyroids. This video is by Professor Martin Waltz. He is from Germany. I have just put my name only because he didn't want to get it circulated, that's why. So you can appreciate that the major drawback of this procedure is you can't do in patients who have been previously operated. The patients having larger thyroid glands, somewhere to a tune of more than 3 centimeters. So you can really appreciate good amount of clarity. You can identify nerves, clip them, or use a ultracision to tackle them. You can see the parathyroids being separated. and then the rest of the thyroid is separated from all sides. So usually assistant is holding the telescope in hand, standing on the side of the gland. The surgeon stands on the opposite side, and the surgery is done by looking on the screen. So it is minimal invasive video assisted thyroidectomy. I'll just go to the end. And finally, this is taking out of inferior thyroid pedicle. So good amount of magnification you get in this kind of procedures. And you can appreciate this small incision on the anterior aspect. However, this incision can be hidden in a skin crease. Pain documented is less. They have documented different hypoparathyroidism. Yes, even after neuromonitoring, they have documented recurrent laryngeal nerve palsies. Now, contraindication, you cannot have a redo surgery in this. Somebody having malignancy, these cases should not be operated by a MEVAT. Then comes stovata, which already has been shown, so I am not going to go in detail. What next lies is robotic surgery was being detailed by Dr. Amit Agarwal. Certain modalities have come up in the recent past. Radiofrequency ablation, microwave thermal ablation, laser ablation, ethanol ablations have been detected. All these procedures would depend on a thermal ablation. In radiofrequency, there you put a needle electrode. In microwave ablation, you put a wire. These are all done under ultrasound guided. So usually they are kept. They are not helpful for nodules more than 4 centimeters. The basic principle lies in heating the nodule with the electrode to a tune of up to 100 degrees. Up to 60 degrees, it causes coagulate necrosis. Above that, then it causes death of cell. Because of that current, it causes death, so shrinking of the nodule. So the efficacy of about 80 to 85% of reduction of size has been documented. Yes, there are. It is relatively painless. In patients who have a lot of fibrosis, a lot of active Graves' disease, or a lot of calcification, these procedures may not be very helpful because the reduction of size may not happen because of the conduction of current is not adequate. They have come with complications as neck pain. Some patients have documented dysphasias, the foreign body sensation, and at times skin changes. They are still under evaluation, but there are lot many projects coming on and lot many publications on it. Thank you. Any questions? I would have shown again transaxial and transvestibular, but it's already been shown for last 2 days, so there was no point in me doing same things again.
Thank you, Dr. Samir Ege sir, and our esteemed team of chairpersons. I would request Dr. Sachin Nayak sir to stay back and Dr. Colonel Vikas Gupta sir for felicitation. Thank you, everyone. I now call upon Dr. Ojas ma'am to head the next session.
Hello, good afternoon, everybody. I would like to call our chairpersons, Colonel Dr. Neetu Singh, ENT and Head and Neck Surgery, Oncosurgery, Dr. Prateek Jain, Consultant in the Department of Surgical Oncology at Tata Medical Center, Kolkata, and Dr. Ritesh Agarwal. I don't think Dr. Pablo needs any more introduction after watching so many surgeries and lectures. Over to you, sir.
Thank you very much. Good afternoon. Thank you very much again for allowing me to be here.
So I'm going to talk about the advances that we have developed in parathyroid preservation, and I will show the lessons that we have learned in the last 10 years with ICG. Okay, so we recently reported an unusual, you know that the most frequent complication after thyroidectomy and severe, of course, is hypocalcemia. And it was said that, or reported that it could be occurring up to 3%, but we all know that this rate may be underestimated, especially if we don't follow up our patients for at least 1 year. And more objective studies reported it could be up to 12 or even 14%. We recently reported an unusual permanent hypocalcemia that was up to 11%, and among other factors, the main reasons could be that we, for years, long term, for a long time, we were the only endocrine surgery for 1.5 million in Barcelona, in the South Barcelona, and 48% of our patients were cancer cases, and we performed central neck dissections in 42% of them. So we could correlate different degrees of decay and related with some permanent or postoperative hypocalcemia. It is true that until the advent of the fluorescence, no other innovation had allowed us to minimize the trauma to the parathyroid glands during thyroidectomy beyond developing a meticulous surgical technique. So it is clear that in order to avoid hypopara, we have to identify parathyroid glands as a first step. Then trying to see from where the supply comes from, then show our abilities, our skills in order to preserve parathyroid glands. And finally, the only thing we can know is to ask ourselves how the parathyroid glands will behave in the postoperative period. Clearly, for years, the only thing we could do is like this. In those cases, we can see the superior parathyroid gland. In the cancer cases, we could identify the superior, the artery supplying this parathyroid gland, and that's all. I think but this is what we have to do. The problem is that this situation doesn't happen very often because in most of cases we are blind to see the vessels. And then that's why we have included new technologies as autofluorescence to identify parathyroid glands, and also ICG to see where the supply comes from, to guide us along thyroidectomy, and even more to predict what will happen immediately. So our first studies on with ICG began. In Spain, we say we build the house by the ceiling. Okay, so we began to use it at the end just to predict how will behave the parathyroid glands. And the first questions we tried to answer is we were predicting by intraoperative PET-HSA 10 minutes after, and now we have ICG. Who predict best parathyroid gland function immediately? So, and second question, how many parathyroid glands will we need to maintain eukalcemia status? And then, of course, to answer any question on parathyroid glands, because we have at least 4 in 90% of populations, it is important to have identified 4 parathyroid glands. I mean, the sum of those in situ, those autotransplanted, plus those that could appear in the specimen. So, this is the only way to answer the questions. And then, on this, with this paper, we could see that both ICG and PTH had the same accuracy to predict immediate parathyroid gland function, that only one gland scored as 2 was enough to maintain calcium levels with a 94% of accuracy, and based on that it is not mandatory to look for the norm. So in the presence of an elusive parathyroid gland, don't get crazy looking for it, because maybe we are going to spoil its supply. So, second question was based on this paper. In this paper, there was a proposed score system in which the maximum score was 8, having into account 4 glands as a maximum 2, so from 0 to 8. And then they concluded that below 3, there was a higher chance of presenting hypocalcemia. But we have used the score, the simple score 0 to 2, and we knew that only one gland was enough. So which is better? Which score system predict best? So we conclude that one single gland score as 2 is much better than having 4 glands score as 1. So it is not the quantity, but the quality of perfusion what saves us of postoperative hypocalcemia. Question 4 comes from the ability to have information, immediate information, along surgery by injecting ICG. So the question is clear. Do we need still PTH? Well, the answer is as follows. Independently of the number of parathyroid glands that we have identified, whenever there is no gland score as 2, we don't know what will happen. Probably will be transient, but we know what will happen. And if we only have identified 3, which is the role of the missing gland? Maybe it is working. So it is important, I think, that it is essential to count on intraoperative PTH to predict. Because, important, ICG provides immediate real-time perfusion data about every single gland. However, when we don't have any gland well perfused, intraoperative PTH provide a systematic measure of overall parathyroid gland tissue, and this is, as I told you, the role of missing glands. So, after that, after having explored this step, we thought that probably we could have some information about vessels. And this is something that it is very important. We all have we are sound and we think we can explain many things. But fluorescence has some film, many things we could imagine but could not easily prove. And you will understand easily because, as I told you, in most of cases we only are able to identify the evidence of the parathyroid glands, and when performing thyroidectomy, it is very clear. So we have to take the thyroid out and leave the gland in situ. And so the surgeon draw an imaginary thyroidectomy line and perform the thyroidectomy. But sometimes we are very happy, the study was very nice, and the day after, we don't understand why the patient has hypocalcemia. Why? Sometimes because of this, because sometimes the imaginary thyroidectomy line is in conflict with the vessel feeding our parathyroid glands. That's why we thought that probably we could help. We could be helped by angiography to prevent postoperative hypocalcemia by preserving more parathyroid glands in situ and working. So in 22, in this year, this surgeon from France, Vemilut, published a few months before us the ability to use ICG. However, in this study, it was only descriptive. There was no prospective comparative. There was no clinical results. A few months after, we were working at the same time, but we took a few months later, in which we could prove that in a prospective study with a control group, we could show that by using this technique, we were able to increase the number of glands in situ and perfused as a score 2, diminishing in a significant way both hypocalcemia, transient and permanent, till 0. So then that's why we describe it. I will try to show you how it works. Angiographic thyroidectomy. We will think that this technique could help us to look for a permanent thyrohypoparathyroidism. Opposite to the classical conventional thyroidectomy, in which surgeons identify parathyroid glands and draw an imaginary thyroidectomy line, as I told you, then we inject ICG in order to look for a nice map. This map is this only happens only a few times. Not all times we have this so nice, but in this case I think it's good to show. So, and as you can see, we could understand that sometimes we injury, or not injury, our parathyroid glands remain in situ, doesn't work directly because direct injury to the vessel nourishing the gland, and sometimes indirectly because of the heat that spread laterally our energy devices in the first 2 millimeters. Okay, so, and as you can see here, you can see the thyroidectomy line, and this is the 2 millimeters thermal injury area. You can see the tree, the vascular tree, and in this case, there seems to be a couple of nourishing arteries supplying the parathyroid gland. But the most important is that doing a perfect thyroidectomy, this gland should be dead. Okay, so we learned that there are a couple of patterns when we inject. There's a defined vascular pattern in which there is only one vessel entering the gland, and this is the aim. The goal is preserving these exclusive vessels. And sometimes there's nothing. There's a mess of vessels, and we only have to do the surgery as usual, conventional, based on the knowledge that parathyroid glands are there and they should be remaining in situ. So we select a photograph of the gland that we want to preserve, and sometimes we use the black and white to guide us along surgery. For all of you doing laparoscopy or endoscopic procedures, it is not very complicated. And I will show you in this case we could save this gland just because we were able to know where the supply comes from. So, in this case, this gland was in the posterior part and medially of the upper pole, and was saved because we were able to know that. So, in this case, this video takes 3 minutes. I could not put it in double speed because it's in PowerPoint, but I want you to know this is something that is very important. This gland was easily identified, but initially it was very difficult to be preserved because it was bulging on the thyroid. I'm sorry because it is.
Shows no perfusion with ICG angiography, and therefore we are not able to.
This is the technique you saw yesterday. We protect the vessels nourishing or feeding the parathyroid glands with this device in order to avoid it gets thrombosed.
Of the capsule above the feeding vessels of the parathyroid glands. Visualization of the vessels with ICG also permits the use of high-energy devices with safety, as we are able to maintain the distance of thermal injury.
So now you will see, and I will answer some questions somebody asked me yesterday. What happened when you inject several times?
Identification of the recurrent laryngeal nerve is an important step in preserving the inferior parathyroid glands vascularization. As described,
you will see here that you are able to inject several times and you still have ability to learn about the vessel distribution. This is the nerve. Then this, I would say that this is the right inferior parathyroid gland is the most difficult gland to preserve because it's long pedicle and it is sometimes intertwined with the nerve.
Laryngeal nerve and feeding vessel from potential thermal injury that can happen within 2 millimeters of the device. Repeated doses of ICG may help in the dissection of the gland's feeding vessel, as it is often intertwined with the laryngeal nerve.
You see the nerve, you see the branches and the gland. So it is useful to inject several times to update information. I can tell you that in this case, the gland was scored as 2, so in order to save time, I will tell you, I will go on with my presentation, you will see that when we have an undetected vascular and defined vascular map, we have to do the classical surgery based on intuition. So this is a subcapsular in the lower pole of the right side. So we inject, and the only thing we can do is to make an intuition how the vessels should go. And what happened with the central neck dissection? Well, years ago, when I had this situation, I decided to include inferior parathyroid glands with specimen. Now we have the opportunity to give an opportunity to our parathyroid glands by injecting them. In this case, for the first time, we have an undefined pattern, but after working a few minutes with the vessels, you can see here that there could be a couple of vessels responsible for feeding. After repeated ICG injections, we could see probably a more defined pattern. Okay? So, overall results said us that we, in every position, we were able to increase the number of well-perfused parathyroid glands and score us 2. That are not published. And on March 25, we could conclude that we have the results is that we have no permanent hypopara. There's a significant decrease in the number of postoperative hypocalcemia, permanent hypocalcemia, mainly explained by higher levels, significantly higher levels of PTH immediate the day after with calcium levels. Now we are conducting a randomized control trial trying to show us. And now that we have so much information, the question is, which is the real role of central neck dissection on hypopara? Does it produce a negative effect? Well, so you know that after in thyroid surgery, our patients may become hypocalcemic because of thyroidectomy and because of central neck, which is the responsible. So for years, since 2006, that we began to, as you can see here, we use ICG to predict, and since 2018, we use it to see the vessel's vascular map. So we selected in this period of time those patients that underwent central neck dissection, and we could see that the superior parathyroid glands, when we performed thyroidectomy using ICG, we were able to increase significantly the number of glands preserved and well perfused as 2. Nothing happened after the central neck. When we considered the inferior parathyroid glands, there was no significance, so we did almost the same. But the most important is that by performing angiographic guided thyroidectomy, we didn't have a negative effect by performing a central neck dissection, whether therapeutic or prophylactic. So why? Because we are able to increase the median number of glands well perfused in the superior position. So, in conclusion, we could say that angiographic guided thyroidectomy preserves significantly better parathyroid glands in the superior part. And now I will invest my last minutes in giving you some tips. So, things are not like it seems unless an optic illusion occurs, and you know that tankers don't fly. And sometimes it's the same with undefined pattern, because as you can see here, as you can see here, this superior parathyroid gland initially presented and non-defined, and after partially dissect from the inferior thyroid artery, we could see the vessel that feeding the parathyroid gland. Same with inferior one, but I want to go on. So now we have immediate information, but in an spoiled or partially injured gland, could we improve its function just by knowing it immediately? Well, I think that sometimes it is very important to know where the gland is when we begin the surgery. In this case, you see the feeding vessel is very tiny. It's very tiny. Couple of them could enter, and after right lobectomy, 2 minutes more and I finish. And after, then you can see that if we put the gland in its original position, it glows more and more. So we are potentially increasing its perfusion. So it is very important to put the gland in its original position, and we define this maneuver as parapexy. We attach the gland in its original position with some sealant. Okay, go on. And another thing that happens very often is that we find a periglandular hematoma. And I don't know what you do, but I think that many of you could cut the gland in order to relieve the pressure. So this is something that we could imagine, but we could not prove till now. But you could see that after draining the periglandular hematoma, the perfusion increased inside the gland. Okay? So my last tips to finish are that repeated ICG doses help you to identify feeding vessels. We can move from undefined to a defined pattern. The second tip, I suppose that this is something that you have at your home with your kids. Your mother told you, please, my mother said, Pablo, leave things as you found. And this is especially important when you are talking about parathyroid, even if you don't like where and how they are. And finally, do not leave the gland under pressure and leave hematomas. So we learned that one well-perfused gland is enough. Second, it is not essential to identify all parathyroid glands. Third, parathyroid PTHSA is still worthy. AG and geographic thyroidectomy can enhance preservation in both quality and quantity. It may help to prevent hypocalcemia related to central neck dissection. ICG facilitates early decision making. I don't told you before, but not only pexia, not only periglandular hematoma, I don't do any prophylactic central neck dissection unless I have at least one gland score as 2 in the superior position. Okay? And finally, I don't know how to transplant unless the gland is 1 meter far from the patient, even it is scored as 0, and every single gland should be considered as the only one, because you should know and you have experience enough to think that parathyroid glands may be like a box of chocolates. You never know which is the next one. And finally, my last tip is, and maybe it's in the wish list, is that probably we could get permanent thyrohypopara. Thank you very much, and sorry for my time.
Thank you, Dr. Pablo, for this excellent and elaborate presentation. I would like to ask you a question. Sometimes there is uptake in the surrounding brown fat and the colloid nodule also, and there is no robust scoring system for the uptake values of the indocyanine. So do you often get these false positives? And secondly, are you also using a non-invasive autofluorescence method?
Sorry, the first question is about the fat surrounding the glands.
Yeah, the false positive.
I think it's very important to be very kind with the glands, because the more tightly exposed, maybe you are. But once you have the gland exposed and you see there, you could just cut a little bit just to identify the gland and differentiate it from the fat. But it is possible. I think it's very important. But wherever you are sure, the maneuver is going to be very kind. Second question, please.
Second was, are you also using non-invasive autofluorescence technique in your center?
I'm sorry, I don't.
Autofluorescence.
Without injecting the dye.
Very important question. So the problem with autofluorescence is that once you inject ICG, you lose the ability to detect. So it is very important the decision when to use ICG. It depends. I always begin with the more difficult side, and assume that if I identify both parathyroid glands in the difficult site, I inject ICG because I will try to preserve the potentially more difficult glands and assume that I will lose autofluorescence on the opposite side.
Thank you.
One quick question. Do you also depend on the saline drop test? Because that's another good way and very cheap and easily available way of differentiating between a fat and a parathyroid. So that is, if the parathyroid gets completely separated and before auto-transplantation, do you differentiate between the two by putting it in a saline and doing the drop test?
Well, of course, it is a immediate test, but if I am doing a thyroid cancer, I prefer to confirm by first frozen. But I think it is a immediate.
With your technique, and how many patients you had to do auto-transplantation of the parathyroid?
So auto-transplantation?
Yes.
Only a few. In 200 cases, I think that maybe 3-4 cases. Okay. Only a few, because my theory, there are some data that has not been published, but before getting so good results, my first research was I had to detect if I could be able to improve the perfusion of the gland by putting it in saline. Okay, as you said that, and papaverina, I only do it with saline at 37 degrees, and I could see that glands score at 0 could move to 1 and 1 to 2. So unless the gland is completely detached from the operative field, I don't auto-transplant. And if I decide to auto-transplant, I checked.
Right. Thank you. What is your preferable site for auto-transplant, sternocleidomastoid or the forearm muscle?
Sternocleidomastoid,
yeah.
Ever. Even if I do renal.
We are also using sternocleidomastoid because easily it's over there only.
Disease of the parathyroid, you have transplanted on the forearm, it will be better to detect and operate any advantages?
Yes, the advantage of doing in the forearm is that you can do, especially in kidney transplant patients or secondary hyperpara, you can do Casanova's maneuver in order to detect. But I can tell you that I think that it is easier to do it in the sternocleidomastoid muscle if you have a recurrence that it is very, very strange. Then you may have some harmful in the muscles on the forearm. So I think that in most of the cases, you have a recurrence of secondary hyperpara. Of course, it could be in the sternocleidomastoid muscle graft, but I would say that in 99% of situations, the recurrence is in the neck or in the thorax, but not in this. So I would look for another cause of recurrence. So the easiest thing, sternocleidomastoid.
But sometimes in CKD patients of tertiary hyperparathyroidism, when you implant in the forearm, the vascular surgeons complain because they need the vessels for fistulas later on. They are on long-term dialysis. So all their veins keep getting used repeatedly for repeated fistulas. So in those situations, I think you can do it in HCM also, not a problem. Only thing is that forearm you can give local and explore it in case it comes back, the hyperparathyroidism.
Another indication is a very, very, very rare case where the patient, where you have been able to do only a debulking surgery and you are going to give external radiotherapy to the patient. I think this patient also, if you need to implant the parathyroid, you have to implant in the forearm and not in the neck.
This parathyroid is such a thing where the discussion will go on and on and on. Such an interesting thing. Thank you, Dr. Pablo. It was a very nice discussion, nice presentation.
Thank you very much.
Audience. So with this, we wind up the session and hand over to organizers, please.
Can I now call Dr. Tushar Khatsane to come and felicitate Colonel Dr. Neetu Singh, Dr. Prateek Jain, and Dr. Ritesh Agarwal. We are going to have a 15-minute lunch break. I'm really sorry because we're running short of time. So there's going to be just a 15-minute lunch break, and we have decided to switch the symposia because Dr. Ritesh Agarwal needs to leave early. So we're going to have the symposium of prevention and management of complications in thyroid surgery first. I request all the panelists of the second symposium, which is moderated by Dr. Ritesh Agarwal, to come back to the hall in 15 minutes. Thank you.
तुझं काही काम नाही ना की तरी अंदाज टायमिंग
करतोय. चेक करतोय तर चेक. चेक. हॅलो हॅलो. चेक. हॅलो हॅलो. चेक चेक. नाही थोडं हल्लं ना ते व्हायला लागले. आवाज यायला लागलाय. हां म्हणजे व्यवस्थित आहे त्याचं काही नाही आहे. चेक. हॅलो. ठीक आहे. काय झालं.
Good afternoon, everyone. Welcome back from the lunch. Now we move on to the next symposium, which is Prevention and Management of Complications in Thyroid Surgery. And I would like to call upon the chairpersons for it, Dr. Deepak Balasubramanian, sir, Dr. Pablo, sir, Brigadier Dr. Manoj Kumar, sir, Dr. Raj Gajbhiye, sir, Dr. M. Devakar, sir, and Dr. Utkrant Kurlikar, sir. I also call upon the speaker, Dr. Ritesh Agrawal, sir, to moderate this session. Thank you.
Thank you, organizers. So, hopefully after such a delicious lunch, everyone is back and not sleeping. I welcome my esteemed faculty, my esteemed panelists. One change, that instead of Dr. Raj Gajbhiye, our very dear Dr. Rakesh Neve sir is here, and Dr. Pablo will be joining shortly. Thank you so much, Narendra sir, for giving me this opportunity. So, my dear panelists, today we will be discussing, next slide please, sorry. Today we will be discussing on prevention and management of complications in thyroid surgery. Please, welcome Pablo sir. So, thyroid surgery is considered as a very skilled surgery. And it was a statement a century back that in America, the hospital was considered as a good hospital when the good thyroid surgery can be performed in that hospital without complications. Such is the magnitude and such is the beauty of thyroid surgery that such is considered as one of the highest skilled surgeries in the whole surgery armamentarium. But inherently there are so many risks and complications involved, and we have to know, we have to see them, we have to prevent them, and if occur, then we have to manage them also. How? That we will discuss today. So common expected complications are hemorrhage. We have all read in our PG textbooks that hemorrhage is very common in post-thyroid surgery. Metabolic issues like thyroid storm, inability to reverse from anesthesia, this is something different we will discuss. CO2 embolism, injury to the parathyroid glands that have been extensively covered in this symposium, but we will cover a short while things again. Injury to the nerves like recurrent laryngeal, external branch of superior laryngeal, mental nerve, others like phrenic, ansa, and spinal accessory. And last but not least, cosmesis, which is a very important concern for the younger generation or any lady. Coming to the hemorrhage. What can be the causes of hemorrhage? Intraoperative causes, inadequate hemostasis of vessels, superior thyroid artery vein, inferior thyroid artery, middle thyroid vein, thyroidium artery. Here I would like to ask my panelists, especially Devakar sir, when you are operating on the superior pole, what is your strategy to ligate the vessels? How you identify them and how you ligate them? Mike, please. How to deal with the superior pole?
Hello, 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 hello.
So my technique is to use the...
That is also not working.
I'll be loud. So,
but we have audience so that we can you give some working mics, please? Anybody from AV team?
Hello. Hello. Hello.
Yeah.
Hello. Hello.
Sorry for the technical disruption.
So I use the cold steel dissection technique. I don't use any other harmonic scalpel. I stay close to the superior pole. I don't deliberately seek out the external branch of the superior laryngeal nerve, and then when I identify the superior thyroid artery and vein, I try to isolate them individually and apply clips on the patient side and cauterize the side of the thyroid lobe. So that's my practice.
Any other faculty has any other variation in opinion, please?
Yeah, I generally tie those vessels, especially on the side which is going to remain in the body of the patient. So
Okay.
With ligatures.
Yeah. Dr. Deepak?
Yeah, the easiest way to get the superior pole is you have to put traction on the upper lobe in the superior pole and pull down the thyroid. Only then you will see the pedicle distinct from the gland, otherwise you won't see it. And whenever you tie your clip, always leave a stump on the vessel, because if it slips, you'll be able to put another clip. So we use only clips, so I put double clips on top and like
Dr. Nair?
Devakar said, coagulate the gland side.
You'll agree that these are not as common as they used to be once upon a time when we used to do ligatures. What I do is similar to what Dr. Deepak said, that we tend to retract, but I try to see the nerve and try to stay close to the pole to separate ligatures if they're branching or common together.
Okay, thank you. So, I have a short video. I request audio AV team to run the sound also, please. AV team, run the sound, please. So here we have hold the superior pedicle, lateralize it. It's very important. Please hold the superior pedicle with the artery and lateralize it, so you get enough space. You can create space between the superior pedicle and the inferior constrictor muscle, and dissect with the either harmonic or whatever way of ligation you are preferring. I am operating with the use of harmonic focus. This is a sutureless technique. No sutures applied even on superior pedicle. All the vessels can be ligated easily, individually. Individual ligation is very important. Do not ligate en masse. Individual ligation is important so that there's least chance of slippage of ligature or any postoperative hemorrhage. So in this space, you can see so quick we can operate, we can dissect the superior pedicle.
The other common cause is there's a cricothyroid branch which comes off the pedicle.
Yeah.
There's a cricothyroid branch which comes off the pedicle. So if you tie it very distally, that branch still has perfusion.
So
you
that's
have
why
to look at
distally and far away from the superior pedicle, so that all the branches are shifted distantly from the superior pedicle. And in this way, external branch is also saved. There's no need to the external branch because we have ligated the vessels individually. Yeah. So coming to the inferior thyroid artery. What is your experience with inferior thyroid artery? Any panelist can take up the question, please. Inferior thyroid artery supplies superior parathyroid, inferior parathyroid, as well as thyroid. So we have to.
Correct. So when you do extracapsular dissection, you will encounter the terminal branches of the inferior thyroid artery as you dissect along the plane just outside the thyroid capsule, and you follow the plane between the parathyroid and the thyroid gland, and then you clip, cauterize, or ligate these small terminal branches as you go along, and that way you can preserve the blood supply to the parathyroids. At the same time, you can mobilize the lobe without causing much bleeding.
Thank you. Middle thyroid vein, is it always encountered, always found?
I probably see them in 25% of my cases. It's difficult to identify in all procedures.
Yeah. So middle thyroid vein, whenever you lift up the thyroid, if there's a vein running horizontally from internal jugular vein to thyroid, that is middle thyroid vein, it can be easily divided, and it should not be slipped because the trunk immediately retracts and it causes massive bleeding. It's difficult to find the cut end. Injury to the major vessels, very rarely encountered, we will not be taking unless the thyroid is densely adhered to the internal jugular vein or common carotid artery, if it's a malignancy. Post-operative causes of the hemorrhage, like increased venous pressure, how to prevent it immediately after surgery. Any technique, any maneuver you all do? Pablo, sir?
Well, I'm not sure. I think that you prevent when you do the surgery, not at the end. At the end of the surgery, what you have to do is to test that everything has been done properly in advance. And of course, increased venous pressure, you may ask the anesthesiologist to increase the venous pressure, valsalva maneuvers, to check if there is a bleeding point. After that, the only thing is you can do that, nothing. Another thing that I use, I commented so far that I don't like staples. Of course, there are many people using it, but just because you are based on experience. And I remember when I was on call many years ago, I had to reoperate a patient that was operated on by gynecologist, and I used to put clips, staples in the retroperitoneum. And well, some clip was dislodged and was the main bleeding point. And just because I used to put saline, maybe you saw yesterday, I put saline in the operative field, and in order to avoid parathyroid gland suction, I suck over a peanut. I'm afraid that the peanut, the gauze, could dislodge the staple. That is the maneuver I try to avoid, using staples.
See, the other thing is drain placement is very, very important. You should never leave it to someone who doesn't know where the external jugular is or where the anterior jugular is. You'll put the drain, it won't bleed at that time because it's common practice to put a dynaplast on the neck, but then it'll keep collecting every time the patient strains or tries to do something in post-op. So one of the other causes is drain placement, injuring the veins during drain placement.
Yes, agree. And as Dr. Pablo has told, it's very important to do positive pressure or valsalva maneuver during surgery. When you have completed the dissection, always tell your anesthetist to increase the pressure, put saline in the field, and never do a direct suction. Always do suction on some gauze or peanut over it, so that parathyroids do not come in the suction and they are inadvertently removed. It's very important, and then learning lesson for everyone. Also, another maneuver is when you finish the surgery, do the dressing, do not leave the operation theater, stay back there. At the time of extubation, there is a sudden violent cough. So just put your hand over the neck of the patient tightly so that there is no slippage of ligature or no sudden bleeding. This is another maneuver which one should regularly do. Metabolic issues, thyroid storm, any experience with the panelists? Yeah.
But they can be life-threatening, and usual way of managing this is fluids, paracetamol, esmolol, and about 400 milligram hydrocot given immediately, and then you continue with them. Unlikely to see today. It speaks more about a poor preoperative preparation than what we encounter directly.
Agree. So we should have a very good endocrinologist in our team who can manage the Graves' disease or hyperthyroid symptoms and control biochemically. Then only operate. Do not operate incomplete prepared Graves' disease or hyperthyroid patient. That's very important, otherwise thyroid storm can precipitate during surgery and you will be in difficulty. Anybody has seen difficult reversal from anesthesia? After surgery, you have done a very fantastic surgery, everything has been done. But patient is not getting reversed. Everything surgical is okay, but reversal is not being done. Why?
The most common reason is tracheomalacia. If you have a long-standing goiter, you will be able to intubate because of the Bernoulli's principle. The airway is still patent, but the moment you remove the gland and try to, it will prolapse. So that's the commonest thing that I've seen.
So there are a few other reasons where the reversal doesn't happen smoothly after surgery. One very basic thing which we as a surgeon often neglect, hypothermia. Many of our patients do not get a warming blanket or warmers, and patient gets hypothermic during surgery, and that causes, and during especially the prolonged surgery, and that causes difficult reversal. Another reason is when the patient is hypothyroid previously and not adequately replaced. So these are the things where the reversal is difficult. CO2 embolism, especially seen with the endoscopic techniques. Any experience with the CO2 embolism? What kind of gas pressures you use? Anyone using endoscopies? It's defined as nearly about 8 mmHg. It's not a high pressure, so that CO2 doesn't go into the systemic circulation, because here the big veins are in direct connection with the thyroid. Injury to parathyroid glands have been extensively covered, especially by Dr. Pablo. I am thankful to him. So there are many reasons for injury to parathyroid glands during surgery. Devascularization, one of the most common. Inadvertent removal, when the surgeon is not able to identify it is parathyroid and removed inadvertently. Trauma, during surgery the parathyroid glands itself, even after identification, gets traumatized. Or a thermal injury. So what shall we do to prevent these kind of injuries? Panelists.
So I think when we go ahead with the total thyroidectomy, we should get rid of the notion that we should actively seek out and identify all 4 parathyroid glands. When you do the extracapsular technique, the recurrent nerve as well as the superior parathyroids, they reveal themselves when you do the dissection. And then if you're lucky, you might be able to identify the inferior parathyroids. So you should be able to at least identify one or both of the superior parathyroids while doing the dissection and not intentionally seeking them out, because if you do that, you tend to go in a lateral plane where you devascularize the parathyroid. And Dr. Pablo's own colleague from Spain, Dr. Laurent Posch, he has published a paper on the Pigris score, which is totally you start with 4 parathyroid glands, and then you subtract from that the number of glands you auto-transplant and the number of glands inadvertently removed along with the specimen. So you arrive at a score of in situ glands, and that itself indicates that you don't have to intentionally see every single gland. As long as your dissection is meticulous, you go in the extracapsular plane and stay medial to the vessels coming from the lateral side. The parathyroids generally tend to be anatomically and functionally intact.
Dr. Neve, and then Dr. Pablo. Yeah.
No, use of energy sources close to the parathyroid gland is one of the most important reasons. Most of us are trained to now identify the gland, and we are able to many times identify both the glands when you're doing a hemithyroid. But using of energy sources close to it is what actually devascularizes them and not noticing them. And ICG, while it's a very good tool, but it's not practically available at most places. So to say that I would say that only 10% of my patients would actually be able to come to a facility which has got an ICG. The rest we have to be meticulous in our dissection.
Dr. Pablo?
Yes, I just was to insist in that, especially for those of us that use currently advanced energy devices or electrical devices, of course, but it is very important that once you have medialized the thyroid and you are looking for the thyroid, don't use energy till you identify the parathyroid glands, because if you do a lot of maneuvers with these devices before identify the vessels, maybe it is one of the main causes of putting the gland without perfusion.
Very well taken point. It's very important. AV team, just run the sound please in this video. Run the sound. See, here we are dissecting the superior parathyroid from the thyroid using the harmonic focus, but we have made a plane between thyroid and parathyroid, made a sufficient space, and then only dissected. So we are using energy sources, regularly using, but saving the parathyroid and its vascularity intact. And at the same time, we are checking for the nerve integrity by the nerve monitor. Can we run the sound, please? Sorry. It's not working. Slide changer. Yeah.
Have identified.
So this is the technique for autofluorescence. There are few companies which have started manufacturing the camera using autofluorescence. No dye, just hold the camera, and when you have lifted the thyroid up, you can see the parathyroids nicely. So this is one color, given intense color, the white light. That is another white one showing the parathyroid gland. On the IR mode, the red dot is the parathyroid gland. This is one case of parathyroid adenoma where it has taken the autofluorescence, sorry, indocyanine green. And in this case, it was a case of parathyroid adenoma, but when we injected indocyanine green, the two parathyroids took color, two didn't took color. So we have removed both, and both were proven to be hyperplastic. So after parathyroid, coming to the nerve injuries. Nerve injuries, most common one is the recurrent laryngeal nerve. The recurrent laryngeal nerve, most of the surgeons are fearful, but it's least injured. That I've seen in my career. All surgeons almost practically save the nerves nowadays. Your thoughts, Dr. Nair?
RLN injury is, they say it's around 1.3% or something like that. But usually what I do is after I have dealt with the middle thyroid vein and go down and through the inferior thyroid vessels, then I try to identify the RLN. And I identify the RLN, I do not dissect it all the way up. Because I believe that's one of the reasons we may end up with an injury, because it's not really required. I just have to know what plane it is and I have to stay above that. As simple as that. Going all the way up, the chances of traction and causing injury is more, and one should be aware of the anatomical variation also. In the sense, about 25% of them tend to divide into anterior and posterior branches way up before incision. And unfortunately, the anterior branch is the one which has got most of the motor fibers. Yeah. So that ends up in...
Agree.
And other thing is on the right side, it tends to be a little more of a oblique entry. Course. Left is easier.
Yeah. Dr. Deepak? Tips and tricks to prevent RLN injury?
For people who are starting to do thyroid surgery, don't tie anything without seeing the nerve first.
Fully agree.
Yeah, because you chase the inferior thyroid artery, the nerve is just below that. Excuse me. So I would agree, don't dissect the nerve, find the plane of the nerve, stay superficial to it. The commonest site of injury is at the entry point into the inferior constrictor. That is the most common site.
Because here that nerves take the curved course rather than a straight course.
It takes a curve, and there you have to use sharp dissection to remove the Berry's ligament area. Yeah. So don't tie anything without seeing the nerve. Superior, lateral, inferior approaches, there are so many approaches. And don't unnecessarily meddle with the nerve like Sir had said.
Yeah, very good. So one important point, after lifting the thyroid up, when you are visualizing the parathyroids, then first take the parathyroid down. So along with them, the inferior thyroid artery pedicle is also there, and you get enough space. Then only look for the nerve and then dissect the nerve. If you are taking the nerve earlier, before dissecting the inferior parathyroid, sometimes chances of injury of injury to the vessels of parathyroid is there. So first take the parathyroid down, then dissect for the nerve. In this picture, beautifully shown, thyroid lifted up, multinodular goiter, two parathyroids and by the green arrow, and recurrent laryngeal nerve by the yellow arrow. This patient had a parathyroid adenoma and recurrent laryngeal nerve shown with the yellow arrow. Intraoperative nerve monitoring. What is the experience with the panelists, please? Dr. Okrant, Dr. Deepak?
We do not use, we don't have the facility to use intraoperative nerve monitoring.
Any panelist is using regularly intraoperative nerve monitoring?
Yes, sorry, what was the question?
This intraoperative nerve monitoring, are you using it in thyroid surgery?
Yes.
Okay, so what is your experience? What are the tips and tricks?
To begin with, you have to understand the way the machine and the probe works, so it's better to start with routine cases. There are many types of monitoring, continuous vagal, intermittent, transthyroidal monitoring. There's so many different things. You should be able to understand what the action potential means, what is the first reading, what is the second reading, what is the vagal stimulated reading. So do it on regular cases, but it is absolutely useful for redo thyroid bed cases. Absolutely useful.
Agree. Any panelist had another experience?
So the gold standard for recurrent laryngeal nerve protection is visual identification of the nerve using the traditional extracapsular dissection. So we need to clearly understand that knowledge of anatomy and training are the most important factors here. Nerve monitoring is not a substitute for your anatomical knowledge and how you expose the nerve at its distal entry point. And so that is the thing I really want to emphasize. The nerve monitoring can only confirm what you already know, And the basics remain the same, which is visual identification.
Thank you. Dr. Pablo?
Well, I think that when you use neuromonitoring by mapping, of course, there's the time before and post the maneuver. So it doesn't prevent injuries. However, if you use the continuous monitoring, then it is the only way it can prevent an injury. Most of the times by stretching the nerve. I think this is the main issue that we may have, stretching the nerve, and this can be prevented by continuous monitoring. It is more complicated. I don't do, but I accept that it is the only way. Otherwise, well, it is helpful in difficult cases and depending the junior you are or the senior you are in more or less time. No?
Yeah, probably the continuous vagal monitoring can overcome some of the limitations with the intermittent, but still, all the studies that have been published so far in the last 10-15 years, all the meta-analysis, the Cochrane review, none of them show that the nerve monitor significantly reduces permanent recurrent nerve injury. It reduces the transient nerve weakness, but not the permanent nerve injury. So that's something we should clearly keep in mind. And when you're doing the visual identification of the nerve, don't be in a hurry to divide what you think is a vessel or a fibrous strand. Be cautious until you expose the nerve and you're confident of the anatomy. Don't be in a hurry to divide what you think are superficial, non-nervous structures.
It's a medico-legal problem now. Yeah. If the hospital has a NIM, you are expected to use it. It is a huge medico-legal issue.
I agree.
So you have to be careful about that.
So I agree with excuse me, Dr. Divakar also. Continuous nerve monitoring is not superior to the intermittent nerve monitoring. Make it clear. I have extensive experience of continuous nerve monitoring and intermittent both, and both are equally safe and good. This patient, I had used a continuous one. If you see all the green arrows are there, green ticks are there. So it can be continuous or intermittent. One small video I would like to show that how this nerve monitoring works. See, this is a special endotracheal tube, not a normal one. It has a fitted electrodes inside. Those electrodes go to the level of vocal cords. Neuromonitoring tube getting inserted into the larynx and trachea under the CMAC guidance. We are seeing the intubation of CMAC that the endotracheal is going inside and fitted at the level of vocal cord, the electrodes. Those electrodes are fitted to the panel outside. Neuromonitoring tube getting inserted into the larynx and trachea under the CMAC guidance. The surface electrodes are put on the pre-sternal area. So these all make a loop, and during surgery I hold a pointer which directly stimulates the nerve. All this complete the circuit, and then the stimulus comes on the monitor. This is an extensive dissection, medullary cancer, extensive dissection, total thyroidectomy, central compartment lymph node dissection, bilateral modified radical neck dissection, big lymph nodes, densely adhered to vessels and nerves, axillary lymph nodes also. In that we had used a neuromonitoring.
Good afternoon, friends. So we are demonstrating all the nerves in the neck with the help of a stimulator probe. And first we will put the probe on the external branch of the superior laryngeal nerve, and you can appreciate the contractions of the cricothyroid muscle. This is the cricothyroid that is contracting. Next is the turn of the recurrent laryngeal nerve stimulated. Recurrent laryngeal nerve. You can listen to the beat. And this is the turn of the. We have found some special branch, the anastomotic branch with the vagus nerve, and it is also motor branch giving signals and beat. This is the benefit of nerve monitor. We find the extra branches. Then comes the turn of the ansa cervicalis. Stimulating ansa, then contracts the strap muscles. Then we see the phrenic nerve. We can see the violent contraction of the diaphragm, and then the contractions of the sternocleidomastoid muscle when spinal axis nerve is stimulated. So all the nerves we have stimulated, we have found they are in the nerve integrity is confirmed on the monitor because the muscles are contracting which they are supplying.
This is the external branch of superior laryngeal nerve. External branch of superior laryngeal nerve runs along the superior pole, and it is classified in 3 types, type 1, type 2A, 2B by Serena. So we have to save it because it is a tensor to the vocal cord. It supplies cricothyroid. Another small video.
We are putting the neuromonitoring probe on the external branch of superior laryngeal nerve on the left side, and you can hear the signals.
You can listen to the beep sound as well as
if we
see the
put the probe on the other tissue,
muscle.
it is just seeing the stimulus, but if we stimulate the nerve, it gives the signal.
Now, non-recurrent. So, my esteemed panelists, can you focus something on non-recurrent nerve? What is your experience? How to identify them? What are the tips and tricks to identify and prevent the non-recurrent nerve? Every surgeon wants to identify a non-recurrent nerve, but how?
So on the right side, when you go in, you always assume that the nerve is non-recurrent. So that's the only way to anticipate and prevent injury. Even though the incidence is around 1 in 800 or 900, you always go in anticipating a non-recurrent laryngeal nerve. So I think that is the best way to do it.
Dr. Nair.
I have not encountered one in my life till now, but I believe this is to be correlated with vascular anomalies which are already pre-existing.
Yes.
If you have
aberrant subclavian artery
aberrant
on the right side.
subclavian arising from the distal to the left side.
So what happens that as our protocol, we do a CT scan routinely in every patient before surgery. This CT scan identifies the aberrant origin of the right subclavian artery. If it is there, we are extra cautious and careful. During surgery, we may encounter non-recurrent nerve. So in my entire career, we have operated and found 15 non-recurrent laryngeal nerves. So this is a video of non-recurrent laryngeal nerve.
On the right side, the nerve is running horizontally, coming directly from the vagus, and we are confirming it by the neuromonitoring probe. It has stimulated vagus. Now we find that there are 2 branches of non-recurrent laryngeal nerve, which is extremely rare. Listen to this beep on the superior branch. And this is the inferior branch. If we are stimulating, it is again giving a beep. So there are 2 motor branches of the non-recurrent laryngeal nerve.
So variations may occur. There are so many variations known.
Which is an extremely rare phenomenon.
Mike, please. Though it is told that sonography can predict the aberrant origin of subclavian artery by some Y sign, inverted Y sign, but practically no sonologists do it actually.
I think the best way is that you try to find out the recurrent at its normal place. If you don't find, always keep your eyes and mind open and then look for the non-recurrent.
True.
Yeah.
Agree, sir. Difficult intubations. Sometimes surgeons are blamed. We have saved the recurrent laryngeal nerve, but post-operative hoarseness is there. It may be due to difficult intubation and vocal cord injuries done during intubation. So we have to be careful about it. Like in this patient, scabbard trachea, if you see, I have drawn with a red line, the trachea is tapering, angulated and deviated because of a huge goiter on the other side. Or multinodular goiter on both sides, compressing and deviating trachea on 2 sides. So CMAC intubation is very useful technique. By the use of CMAC, the intubation is done, directly visualization of the vocal cords, and then tube is inserted. It prevents the injury to the vocal cords directly. Last complication, bad scar. That is the precise reason endoscopic thyroidectomy has started come into the picture. So who wants these kind of bad scars? So how to prevent these scars? But last 2 slides, please. Panelists, how to prevent these kind of bad scars?
Silicone gel, perhaps?
Yes. So there, Dr. Pablo.
Well, sometimes it happens that when we work with very small incisions, especially in young people, the act of traction the skin, stretching the skin, make it happens. So one thing I do when I try to perform with small incision is after finishing, I cut the borders of the scar, those scars, and I do a new one.
Absolutely right. During surgery, due to extensive traction, the skin margins got bruises and they may go into hypertrophy later on after closure. Also, avoid these kind of sutures, the interrupted sutures. Please and please never use interrupted sutures in the neck. Use only and only subcuticular sutures. That is essential. This kind of scar, it's good. We do it regularly. We have many things in our armamentarium, like certain gels which are silicone based. They are helpful. Twice application for 6 months. And silicone gel sheets. These are also applied for few months. These really help in preventing the hypertrophic scar. These are common things you can all use for your patients. So that's all, folks. Thank you so much. Thank you, my panelists. It was a very interactive discussion. Thank you, audience. Any questions and queries are welcome. Yeah, please.
The incision should be marked pre-operatively with the patient in sitting position and not when the patient is induced and the neck is extended, because in that case you find that later on the scar goes more toward the sternum and then develops a keloidal tendency.
Agree, sir. But with the experience, when the patient is intubated, we are experienced enough that after intubation also, if we mark the scar like that only. Yes, sir.
Any tricks how to avoid the injury at the Paris ligament? It is a condensation and it is a very in few millimeter.
So direct visualization of the recurrent laryngeal nerve throughout the course. See, previous teaching was that when we were doing MBBS, that if nerve is seen, it means it is damaged. Now, if nerve is not seen, it is damaged. So we have to see the nerve, see throughout the entire course, and at the Barrett's ligament, just keep on a gentle traction, keep up to the nerve laterally, and keep on dissecting the Barrett's ligament. I use harmonic regularly, and we are able to dissect it.
One thing I'd like to say about parathyroids, it's not very common that we can use ICG. Most of the setups do not have an ICG facility. So what I do to prognosticate whether the hypocalcemia is going to be temporary or for a longer duration is to do parathyroid hormone assessment between 3 to 6 hours after surgery. If your levels are less than 10 but more than 3, then it is going to be a transient thing. If they are less than 3, then maybe you need to monitor that patient for a very long time.
Fully agree, sir, because that is known as Q4 PTH. So after 4 hours or 5 hours of surgery, if we do the PTH assess, PTH comes in the normal range. That means the patient will not have a permanent hypopara, and we can discharge the patient safely. Thank you so much. Yeah. Mic, please. Mic.
So when the intubation is done for thyroidectomy, the tube is rotated to one side and it's fixed, right?
It is not necessarily one side. It can be one side, center, either side. It doesn't matter.
So most cases, the anesthetists tend to turn the tube to one side and then they carry on. So now the midline markings have shifted. So in the practical sense, when you're actually doing the nerve monitoring, does it make a difference if those lines have shifted from the midline?
Because the electrode part inside the tube is quite large. So even if it's up and down a bit, it doesn't matter. And it has a level of vocal cords only, stimulating it when we do the nerve stimulation. Yeah, Dr. Preeti.
Sir, any experience of yours, nerve monitor induced nerve injury? Have you experienced?
That's a very important point. I forgot to tell. See, when the stimulus is high, when the amplitude is high, usually we use 0.8 milliamperes. When the amplitude is higher, more than 1, then definitely there are chances of praxia. So you should use a lesser amplitude rather than a higher amplitude.
Okay, so it means this default setting which we have on the nerve monitor, 0.8 to 1.1.
That we can change.
That you can change.
Yeah,
okay.
These settings can be changed.
Thank you.
Thank you all. Over to organizers.
Thank you, the moderators and the panelists, for a very interactive symposium. I call upon Dr. Khasne sir to felicitate Dr. Utkrant sir. Moving on with the session, I would now like to introduce Dr. Deepak Balasubramanian sir, who is an accomplished head and neck surgeon and currently serving as an associate professor of head and neck surgery and oncology at Amrita School of Medicine, Kochi. I welcome him to share his insights on the topic Indian guidelines in thyroid cancer. I also call upon the chairpersons for the presentation, Dr. Pankaj Bansode sir and Dr. Nikhil Halyalka sir. Thank you.
So at the outset, I'd like to thank the organizers for giving me this opportunity. And I'm happy that so many of you stayed back towards the end of the meeting, especially because it's Sunday today. So we've seen a lot of surgeries being done. We've seen a lot of innovative techniques being demonstrated. The basic fundamental principle is that you need to know how to operate. But more importantly is you should know when to operate, how much to operate, and what parts of your management you should leave to your colleagues. When the pathologist was speaking about the new WHO stratification of tumors, these are things that we cannot really understand. So it's always better to have a combined tumor board, a combined clinic, multidisciplinary clinic to manage thyroid malignancies. So my name is Deepak. I bring greetings from Amrita and Kochi. Can we start the presentation? Oh, it's here? Yeah. So the topic that was given to me was to summarize what has been written in the Indian Thyroid Society guidelines. Now there are several ways of assessing evidence. There are several ways of basing your practice. You can have high level 1 randomized trials or meta-analysis or reviews, or you can have expert consensus when there is not enough level 1 evidence that is available. Now, why did the Indian Association put forth their ideas? Most of the concepts are quite similar to the ATA guidelines, but there are certain inherent things that are quite difficult to follow within our country, especially when it comes to evaluation of indeterminate nodules or the use of sequencing and things like that. So I'm focusing only on differentiated thyroid cancer. The important things are how do you evaluate the patient? What is the extent of primary surgery? What would you do if you saw a patient with advanced disease, meaning visceral, vascular, or extensive nodal metastasis? How do you stratify the patient after your surgery? What does that stratification imply? And how you follow up your patients after that by means of surveillance? And what is the role of radioiodine treatment? So now more and more patients are presenting to us with small thyroid nodules or incidentally detected thyroid nodules for evaluation of neck pain, throat pain with an ultrasound, or some of them have a PET-CT for another diagnosis, but there is an incidentally detected avid lesion in the thyroid. So in history is quite important. The guidelines do recommend that you ask for a family history. There are syndromic papillary thyroid carcinomas, which are quite rare, but the history should include the temporal progression of the nodule. If it is progressing within a short duration or a long duration, has it been long-standing? Is the patient in a goitrogenous region? Is there any other family history? So history is very important. The first biochemical test that people have advised and has been incorporated in the Indian guidelines is to do a serum TSH just to know if the patient is hyper or hypothyroid. Hyper generally means medical management, and then hypo, if the patient requires surgery, you have to optimize him or her for the surgery. Radionucleotide scan is only if you want to diagnose a toxic nodule or if you want to diagnose thyrotoxicosis. It is not part of the initial evaluation of a malignant or potentially malignant thyroid nodule. Serum thyroglobulin is also not recommended, but serum calcitonin in patients who have suspected medullary thyroid carcinoma, or you're suspecting Men's syndrome in a patient, then serum calcitonin is fine, but for a DTC it is usually not recommended. So 1/3 of PET positive nodules harbor malignancy. So these patients do need to be evaluated. The evaluation begins with a standard neck ultrasound. Now you have high frequency probes which are able to pick up smaller and smaller nodules. All of you are aware of the Thyroid score that has also been recommended by our Indian guidelines. Now the Thyroid score, when they developed and published it, it served two purposes. It was a roadmap for which nodules need to be evaluated with aspiration cytology, and it also gave us a cumulative score of the adverse ultrasound features that is seen. In places where Thyroid is not available, you have to recognize the high risk features: taller than wide, microcalcification, hypoechoic, increased vascularity, extrathyroidal extension, or lymph node metastasis. So you don't have to rely entirely on the Thyroid score. If it's not available, use the previous ATA guidelines recommendation for high risk features. Now, not all patients need fine needle aspiration cytology. Generally, it is accepted that if the nodule is less than 1 centimeter, it can be observed, provided it does not have any abnormal or high risk features on the ultrasound. And if the patient has worrying symptoms or family history, then the size criteria can be looked over. But generally, if you have something which is more than a centimeter, which you feel is high or intermediate risk, you follow that up with aspiration cytology. And Bethesda is what we use to report the fine needle aspiration cytology. Now, one important thing in the recommendations is that we know for sure that, as the number of Bethesda keeps growing, there is a logic for doing surgery. But in the indeterminate or in 2 or 3, most of the international recommendations have advised us to do molecular testing or repeat the FNAC. Our Indian guidelines have given the option of observation versus a diagnostic lobectomy. So when you have cases which are not suspicious or papillary, then you can offer the patient a diagnostic lobectomy. That would give you more data and more information about the overall disease pathology. So what is the extent of thyroidectomy? Do all patients need a total thyroidectomy? So when Bill Moria published his paper for the previous ATA, he said that everything above 1 centimeter has to have a total thyroidectomy. But there were several problems. It was a population-based analysis. There were several problems in the data, in the follow-up, in the type of surgery. Then Nixon came in from MSK, and then he said up to 4 you can do a lobectomy. So hemi or lobectomy is good for less than 1 centimeter, intrathyroidal, DTC with no adverse pathological features and no nodal or distant metastasis. The gray area is the one in between, and if you have a more than 4 centimeter nodule with extrathyroidal extension, with nodal metastasis, or has aggressive pathology. Now this word aggressive pathology is only on the final histopathology. You really can't make it out on fine needle. As if you do BRAF mutation, yes, it has a higher incidence of being an aggressive tumor, but this is mostly after pathology. But there's one caveat here. There are 2 papers that have been published, one in thyroid itself by Kiljuef from Sweden, I think, and one from Amrita, where patients who had lobectomy and who had adverse pathological features on that lobectomy based on the size. We did the lobectomy because it was less than 4 centimeters. We found that us and the other publication found that the risk of adverse pathological features was about 35 to 40%. Now, the impact of those adverse, I'm not talking about tall cell variants or solid variants, I'm not talking about ETE, I'm talking about features like multifocality, features like lymphovascular invasion, the tumor capsular extension. All these, we do not know what the final implications are. We don't have long-term data for it. So in Indian patients, always warn them that if this happens, they might need to have a completion thyroidectomy. So as I had mentioned, you have a thyroid nodule, history, TSH, Radionucleotide scan if there is low TSH. If it's a cold nodule, if you have done the radioiodine scan, it's a cold nodule, and you have done a USG neck, based on the tirades and based on the final Bethesda, you can take a call whether you want to observe or you want to do a thyroidectomy, and the extent of thyroidectomy depends upon the size as per the current guidelines. Now, if you have a 1 to 4 centimeter, as I had mentioned, if you have a 1 to 4 centimeter good looking thyroid cancer on ultrasound, you have done a lobectomy, and you have no high risk features, no pathological features, and R0 resection, you can follow up these patients with surveillance without any other active intervention. Meaning you can, there is no consensus whether you should do an ultrasound after 6 months or a year. I really don't know what the answer is. There is no long-term data. But you would consider doing an ultrasound after a year just to see the contralateral lobe. If you have adverse pathological features and incomplete resection and things like that, then you advise the patient for a completion surgery to achieve R0 and pathological cure. Now, one of the common things that we encounter, especially in places where patients present late, is patients coming to us with recurrent laryngeal nerve palsy. Now, the important thing is, usually if there is recurrent laryngeal nerve palsy, at least in my experience, we do a lot of laryngeal reinnervations. In my experience, the palsy doesn't go away once the tumor is removed. There is no pressure effect. The tumor generally involves the nerve unless it's an MNG. So what do you do if you have the nerve involved at the intra? So if you can shave off the tumor, you need a microscope, you need micro instruments. If you can strip off the epineurium from the nerve and get a margin there, that is fine. Don't expose any of the fibers below the perineurium. If you can do that, that is fine. But if the encased nerve is the only site of positive disease, then you have to resect the nerve and then put a cable graft to the nerve to sternothyroid or to the ansa. And you can always do thyroplasties later. But if it is the only site of tumor, you have to resect the nerve. But if there is multiple sites where you're leaving back disease, there is no point resecting the tumor. The second problem with our patients is that few of them present to us with tracheal invasion or esophageal invasion. Previously, everyone used to speak about this shaving off the tumor and giving radioiodine for that later on. But that concept has changed. This is Shin's classification. I think many of you would know this. So that depends upon how much transmural the tumor is. If it is from the outside coming to the outer perichondrium, inner perichondrium, and to the lumen. So this is the typical classification. So what we do in Amrita is, if we have a patient with tracheal involvement and we are able to preserve the inner perichondrium, we shave. Otherwise, we resect and do an end-to-end anastomosis. Now, which patients have a higher risk of nodal metastasis in differentiated thyroid cancer? So, if you're a male patient, if you're between 15 and 55, large tumors, extrathyroidal extension, if you have an aggressive variant like the tall cell or solid variants, and if there is vascular invasion, these are some of the features that are associated with increased chances of nodal metastasis. And then which nodal metastases fare poorly? So if your age is more than 45, if you have 5 nodes or more, and if the size of the node is 3 centimeter, and as for any tumor, if there is extranodal extension. So the first investigation, as I had mentioned, is an ultrasound. Someone rightly put out in the morning that you have to look for cystic nodes, but the common dictum still holds. It is cystic change, microcalcifications, peripheral vascularity, loss of fatty hilum, shape of the node is round, and there is hyperechogenicity, not hypoechoic like the thyroid nodules. The other question is, when you have lateral nodes on imaging, you obviously will do a lateral neck dissection. that is taken for granted. The extent of nodal resection depends whether you want to do a 2 to 4, you want to do a 2 to 5. It depends upon the presence of nodes in these stations. But the common question is, what would you do for the central compartment? Dissecting the central compartment has with it its morbidities in terms of hypocalcemia and damage to the recurrent laryngeal nerve. The problem is there is no foolproof method of assessing the central nodes. So here in Amrita and even the Indian guidelines mention that if the patient is going to have benefit by upstaging the tumor for RAI, then you try and do it. And then they say that if you do a central compartment, the TG values later are less. And if you have to reoperate a patient in the central compartment, it is a problem. But the opponents of a prophylactic central compartment have said that there was the single most important thing from those 4 lines is there was no effect on outcome, and reoperation was only required in about 5% of patients. So do we do a prophylactic neck dissection? If it is an advanced tumor, if there is presence of lateral node metastasis, yes. But in other cases, it offers no improvement in your survival or recurrence. So after the surgery, you risk stratify the patient. So there are 3 risk groups. This is almost the same as from ATA. So there's the low risk, intermediate risk, and high risk. The reason why you stratify this patient and it becomes dynamic as time goes on is because you need to know how much to suppress the TSH. Because once you suppress the TSH, proliferation of tumor cells comes down. So these are the values that you try to achieve in your TSH with your thyroxine with the patient. So each of them, the reason why this is not a static classification, it's a dynamic classification. So each of them, the high risk, low risk, intermediate risk, have different ways of following up the patient. So you have to see the response to therapy. Response to therapy is both in terms of TG and the radioiodine scan. There is excellent response, there's biochemical incomplete response, there is structural incomplete response. If you have incomplete responses either by your TG or your patient symptoms, then you do cross-sectional imaging. After that, this is post your radioiodine post-op. So you have to incorporate the post-op radioiodine in your management, in your dynamic management, and whatever is operable should be operated. For low risk and intermediate risk, it is not that aggressive. We don't have to repeat the radioiodine scan, and the chances of incomplete response are much lower. So this is in a nutshell what we do for a DTC which has invasive disease or bulky nodes. This is just a compilation of the slides that I showed you previously. So this is a very confusing table that I picked out from the Thyroid Society guidelines. This includes all of the 5 categories that we have to see in the patient during follow-up. So you have to include the dynamic risk stratification, the TSH that you have to follow, the follow-up regimen based on the type of response and the type of risk, what are the investigations that need to be ordered, and where do they begin with? What was the initial risk stratification? So this is a very important slide. I suggest you print it out and put it in your clinic or on the wards, because this is a very comprehensive slide by itself. So what do you do about radioiodine? So you have high stage, high risk, high nodal metastasis, and a patient who has disease that is microscopically positive. Then you look at the patient for having a post-op radioiodine scan. If the radioiodine scan at 6 months is showing a normal scan with TG less than 1 nanogram, you start T4 and then follow up a year later. If the TG is raised, you repeat the measurement at 3 months. And if the radioiodine scan is negative in your follow-up, you have to do a FTG PET because it could be tennis. And if there is abnormal uptake and the TG is raised, then you can try and do another dose of radioiodine, but never exceed the cumulative dose. There's a recent big review about the risk of solid malignancies like lymphomas for high doses of radioiodine, so that should not be, and especially in reproductive age and young children, it should not be followed. So there are patients who have tennis, which is the thyroglobulin elevated negative iodine scan. To make it very simple, if you have tennis that is operable, you operate. If you have tennis that is inoperable, there are many people who still give empirical radioiodine, but that does not really help. There are newer analogs available for radionucleotide therapy. If the disease is extensive, then TKIs and targeted therapy is what we would use. So, in conclusion, you have to understand the indications to intervene, keep the evaluation initially simple, plan the extent of your primary surgery, plan the extent of your neck dissection, get the pathology report and risk stratify the patient. The low and intermediate risks may not require radioiodine, but the high risk and high stage tumors will require. Your risk stratification helps you to follow up the patient. Always worry about redos, especially if the surgery is done by a non-routine thyroid surgeon. And always watch out for tennis and treat disease that is refractory to therapy. So thank you all very much, and any questions I'd be willing to take.
Any questions from the audience?
In your the first list which you said of investigation of a thyroid swelling.
Yes, sir.
I think thyroiditis marker also are one of the important things.
Yes, sir.
Anti-TG and anti-TPO
yes,
antibodies.
Yes.
That is one thing. And second thing, what you mentioned is in hemithyroidectomy, metastatic, non-metastatic. But unless until you do a completion thyroidectomy, how will you know whether the patient has a metastatic disease or not? Are you doing a PET CT for those patients?
No, sir. Are you asking about the lobectomies which we convert to total? The lobectomies were done because they were less than 4 centimeter FNAC proven tumors, but didn't have nodes, because that is the extent that is recommended now.
Right.
But then in the patients that we have done lobectomy, when we looked at our data, 35 to 40% of those patients had adverse pathological features who went in for completion after that.
Right.
But what is the implication? See, even patients who have multifocality, there is data from Italy and cadaveric data from Japan. They showed that even if the other side has a foci, it's such an indolent tumor that you don't have to intervene. But it's very difficult to explain this in the tumor board and with the patient. So they go in for completion. So we have to tell these patients that there is a chance of completion also.
Okay. And your timing of completion would be within 7 days or after 2-3 months?
7 days or after 3 weeks?
After 3 months.
No, sir, 3 weeks. 3 weeks.
Okay.
Because you have to do it before secondary intention healing begins. Otherwise the planes become fibrous.
Right.
No, we never do. Unless it's a hot nodule, unless the patient has a toxic adenoma, like he has a swelling but he has all the features of hyperthyroidism, we never do pre-surgery. Yes, sir. A lot of people do it to ablate graves also. So there are very good centers which ablate graves with radioiodine. So in those patients, probably a diagnostic radioiodine. One topic that I didn't cover was the role of a diagnostic scan before a therapeutic scan, but that is the domain of nuclear medicine specialists, so I didn't do that. Yeah.
Okay. Thank you, Dr. Deepak.
Thank you so much. Thank you.
So we can conclude the session. Thank you.
Thank you, sir, for a very insightful presentation. I would like to request Dr. Kolte sir and Dr. Rangbakle sir to stay for the next session. And I would like to call up Dr. Khasne sir to felicitate Dr. Pankaj Bansal sir. moving on to the final session of the event, it gives me great pleasure to introduce Dr. Pradeep Sharma sir, who will be moderating today's symposium on the solitary thyroid nodule. He currently serves as a senior consultant surgeon and the head of the Department of Gastrointestinal, Laparoscopic and Endocrine Surgery at Noble Hospital and Research Center. I also welcome the panelists for the symposium up on the stage. Dr. Aparna Atri ma'am, who is a consultant radiologist, Dr. Rang Bagle sir, who is already up on the stage, Colonel Dr. Animesh Vatsa sir, Dr. Shiv Mehta sir, and Dr. Ashutosh Ahe sir.
Good evening, and I know it's getting too late, so we'll try to finish up. Some changes in the panelists. So just a prelude or just a rapid revision, so whatever has already been said since morning, that nodules or thyroid swellings are quite common in the general population. They can be single or multiple. Nowadays we have high resolution ultrasound machines which are quite sensitive enough, and sometimes they lead to an overdiagnosis. So even very small nodules up to 2 millimeters, 3 millimeters are being diagnosed with high resolution ultrasound, more common in females than male. Though everyone or the patient at large is afraid of malignancy, that whenever he detects a lump in the neck, he starts thinking of cancer, but we have to keep in mind that only 5% of the nodules are malignant. So that means that the good news is that 95% of the nodules are benign, but the problem lies that how to identify these 5%, that is more important, how to adequately or appropriately treat them. That's the crux of the thing. And history, clinical examination and investigations are very important. So first of all, we'll come to, first we'll start with this, that what exactly is a thyroid nodule. So Dr. Shiv.
So it is a discrete lesion within the thyroid gland or thyroid lobe, and it may be solitary or there may be multiple lesions inside the gland.
Right. Right. Now, why it is, suppose it is solitary or multiple, or why we need to know all these things, whether it is solitary, multiple or cystic or solid?
Mainly to differentiate malignant from benign lesions.
Yeah, because we do get some information from that. If it is cystic, there is lesser chance of malignancy. If it is solid, I think it does carry a reasonable chance of being malignant. If it is multiple, then again lesser chance of being malignant. If it is single, again more chance of being malignant. Multiple nodule is more likely to be either thyroiditis or multinodular goiter or something like that. Of course, this is not hard and fast rule, but there's something which you should know. And Dr. Animesh, what is a dominant nodule?
A more palpable nodule, a larger nodule in otherwise also a palpable gland would be called a dominant nodule.
So sometimes we talk of dominant nodule, or the physicians or the endocrinologist tells you about dominant nodule. So you should know what is a dominant nodule. And the importance of dominant nodule is that if a patient has a multinodular goiter and you want to know from which is to be biopsied or FNA, from which you should take a FNAC. So it has to be done from the dominant nodule. So dominant nodule is the largest one in a multinodular thing. Then what are the other reasons for a nodule?
There could be multiple reasons, as we already mentioned on the slide, sir. There could be a colloid nodule or thyroid adenoma. Could be a follicular noma. And the cystic lesions could also be there.
Thyroid. So these are some 5 things which should come in your mind once the patient has a thyroid nodule. And of course, carcinoma also. So important point in history, again, I think this has been adequately discussed now in the previous few discussions. So age, we know that extremes of age is a high risk factor. So less than 15, more than 55, female sex, so male sex. The thyroid nodules are more common in females. So male sex is one of the risk factors, rapid growth. I think we'll just skip that because we have already discussed that. Pain, compression symptoms. So 3 compression symptoms. So what are the structure, Dr. Padma Sen, what are the structures likely to get compressed?
Trachea, esophagus,
yes,
and a nerve.
And the nerve. So the 3 structures likely to get compressed are the nerve, the esophagus, and the trachea. So whenever you are examining the patient or looking at the history, you have to ask the history regarding all these things. Do you have any test, a clinical test, which can tell you that the windpipe is compromised? I think this was not discussed in the previous.
So Cocker's test, sir.
Yes.
Yeah, for the scabbard trachea.
Yes, yes.
Cocker's
So
test,
can you just briefly elaborate?
When you palpate both the lobes of the thyroid from both sides, standing anterior to it, the patient develops a stridor, or patient develops a
very good.
This
So if
because
a
of
patient has a
tracheomalacia.
long-standing thyroid swelling, the trachea gets demineralized, or I won't say decalcifies because it's not a bone, it's a cartilage. It gets demineralized or it becomes very thin, and this trachea is kept open only by the ligament of Berry when the thyroid swelling is there. So you should know preoperatively whether the patient has tracheomalacia or not. So you do a Cocker's test, side to side compression on the 2 lobe, and if a patient develops stridor, you have to be aware of that. Okay, and these patients, you might even do a fiber optic bronchoscopy preoperatively in them. Lymphadenopathy, family history. Family history, again, very important because we know that it tends to run in the family, and we have to be aware of the MEN syndrome also, multiple endocrine neoplasia syndrome. Important clinical finding, again, I'll skip that because we have discussed at details at the earlier thing. Shape, whether it is regular, irregular, consistency, fixity, lymphadenopathy, tracheomalacia. These are the high risk factors. Again, Dr. Balasubramaniam, he has covered that, so I am going to skip that. So Dr. Aparna, see, we send the patient for ultrasound, and many times a young ultrasonologist, he will just give a report that this patient has a thyroid nodule 2 by 3 centimeter in the right lobe, and doesn't give anything, no other information is there. We already know clinically this patient has a thyroid nodule, that's why we have sent him for ultrasound. So what are the things which a sonologist should mention on an ultrasound report from a surgeon's point of view?
So I would like to say that ultrasound is almost an extension of the clinical examination, dare I say that. And I would like to divide it into 4 points. So first is you confirm the presence of the nodule and you assess the nodule. So what are the findings that we use to assess the nodule is basically what is the consistency, whether it's solid cystic, what is the echogenicity of the nodule, what is the shape of the nodule, what is the...
so which are the, what type of echogenicity is suspicious?
Okay, so when I would, so the nodules which are very hypoechoic,
yes.
Those are the ones which we are really worried about. So hypoechoic nodules which are actually as hypoechoic as the adjacent strap muscles. So those are the nodules that we are really bothered about.
Right.
Then presence or absence of calcifications in that.
Are you also worried about a variegated nodule?
Yes.
A
so
homogeneous and heterogeneous. There are
Yes.
2 types of nodule, a homogeneous, heterogeneous. And if at all, I'll be also worried about a heterogeneous nodule rather than a homogeneous nodule.
Yes.
Yeah.
So then we look at the margins of the nodule and we look at the presence or absence of calcifications.
Yes.
In addition to that, we use Doppler to see what is the type of vascularity.
There are 2 types of calcification found in the thyroid,
there
micro
are-
and macro. So which one is more worrisome?
So the microcalcifications are the ones which are worrisome.
And where do we find the macro?
Microcalcifications we see in papillary cancer
Yes.
of the thyroid,
Yes.
and the calcifications which have the comet tail artifact, those are the ones which are definitely benign. So those are the ones which we can use to stratify the nodule as a benign nodule and leave that nodule by itself.
Yeah,
Also you have the eggshell calcification. Now, if that eggshell calcification, the rim is not complete, then those are the calcifications also that we are worried about.
Right.
Irregular large calcifications are also some worrisome. So we actually have a stratification criteria which we use as the TIRADS criteria. And TIRADS is basically something that helps us to decide whether the nodules are benign or they are malignant. And very often, we are able to place these separately, because now if you have a cystic nodule or a spongiform appearing nodule with a very well circumscribed margin, then we are quite sure that it's benign. The nodules which are malignant, the ones which are very hypoechoic, the ones which have punctate microcalcifications, extranodal extensions, or extrathyroidal extensions, irregular margins, those we are going to go ahead and FNA.
Right.
So there's this whole gray zone which comes in between, where we need to know what is to be done with the nodule. And that's the reason why we use this stratification model to kind of actually come to some sort of a kind of a conclusion as to what to do with this nodule. That
And it is on every ultrasound machine you'll be able to comment on the thyroid, or only high resolution ultrasound machine?
No, you would be able to comment on any of the ultrasound kind of models that are available right now.
Okay.
So you need a high resolution ultrasound, in the sense you need a proper high resolution probe.
Yeah, probe.
Yes.
I'm talking about the probe.
Yes.
It requires a special probe.
So it requires what we call as a linear probe, which
Right.
has a higher frequency, so that it can
High
see the
frequency,
superficial structure in the neck.
Yes. So again, we won't go much in details about this, already been discussed. So these are the importance of ultrasound. It confirms, it gives you anatomical features, size, shape, consistency, nature, whether it's a dominant nodule or not. Important information about the surrounding gland. So if there is a nodule in one lobe, what about the other lobe? What about the isthmus? Because if you are going to do a lobectomy or hemithyroidectomy, you should be able to do a R0 resection. So whether the isthmus is free or not. What about the nodes, trachea, vessel? You can do a USG guided FNAC if it's small nodule. Big nodule, you can always palpate it under digital control. You can hit it with a needle, but if it is a small nodule, you need to localize it. And you can do some therapeutic things also, like sclerotherapy, ablation, which we are going to talk about a little later. Follow-up. If you are conserving that nodule and you would like to follow up at 3 months, 6 months, so you need some objective baseline data, that whether it is increasing, decreasing, remaining static. So for that also you require. And of course, thyroid score has to be always mentioned in the ultrasound report.
Sir, I have a small, can we go back to the previous slide, sir?
Yes.
The dominant nodule in a multinodular goiter is a clinical diagnosis. How often do we get to see a clinically dominant nodule which is sonologically absolutely innocuous, but there are other suspicious nodules in the thyroid? I would like to ask the radiologist about
on
it.
ultrasound, you mean?
On ultrasound.
Sorry, I didn't get the question.
So, dominant nodule is a clinical diagnosis.
Right.
How often have we found that a dominant nodule is actually sonologically very innocuous, and we do find other suspicious nodules in that multinodular goiter? Do we get to see that very often, or very rare?
No, it's not very often. Not very often.
Any genetic investigations additional to terminal part?
I am coming to that. This is only one investigation. These are the other investigations. Thyroid function test, again, Dr. Balasubramaniam, he confirmed about that they are very important to know what is the baseline thyroid status of the patient. And possibly earlier people used to do only a TSH, but I would recommend doing all three, because now thyroid function tests have become very cheap. Earlier thyroid function used to cost 800 and 900 rupees. Now in 150 and 200 rupees you can get all three done, TSH, T3, T4. So if at all you have that, I think it's better to do all three. Whether it tells you whether the patient is euthyroid, hypothyroid, or hyperthyroid. Then if a patient is hyperthyroid, it could be an early thyroiditis or a DTC. Okay. If a patient is euthyroid of course, is euthyroid. If a patient is hypothyroid, it can be a late stage of thyroiditis. Yeah, what are the other blood tests, Dr. Kolte?
So apart from the tumor markers like serum calcitonin or serum, yes, the thyroid antibodies for in most of the cases of like Hashimoto's or Graves' disease or autoimmune thyroiditis.
Yeah, in my practice, I always do a thyroiditis panel also, because thyroiditis, which previously we used to consider quite rare, is seen nowadays, commonly seen, and that is why I like to do TPO antibodies, TG antibodies, especially if a patient has single or multiple nodules, and especially if a patient has history of giving some painful swelling. Okay, if there is a tenderness on the swelling, then in that case I would do that, even a CRP or a ESR level. If a patient has symptoms suggestive of autoimmune, then all this ANA, C ANCA, P ANCA would be done. They help you in monitoring, and serum calcium level also for medullary carcinoma. Dr. Aparna, I think you can comment on that. I think part of it we have already covered with Dr. Solav in the earlier thing about thyroid scans. So what is the scan which is advised for a thyroid nodule? First of all, do you advise any scan for a thyroid nodule?
So I'm a radiologist,
yeah,
and this is
okay,
part of
I know.
nuclear medicine. So
I know. So anybody of the surgeon, Dr. Shiv, would you like to
As
say?
Dr. Solav sir clearly said, and even there was a discussion about the scans being going to interfere later on post-operatively. So radioactive iodine
I'm not
scan.
talking about CT scan. I'm talking about
So no, the radioactive scan. So
Nuclear
instead of
scan.
having a radioactive scan only for special tests, like when you find that the thyroid function test very low,
Right.
in only that in those cases one should consider a radioactive iodine scan.
Low, I think it is
Where we
opposite.
have a thyroiditis,
It
where
is opposite.
hyperthyroidosis.
Yeah. If a patient is having hypothyroidism, then and then only a scan is
So
indicated.
thyroid
because-
low, TSH low. That's what I was saying.
Low TSH and high T3, T4. If a patient is toxic, then possibly we need a scan, because we need to know whether it's a autoimmune, whether it's a single nodule, toxic nodule, that is a Graves, or it's a toxic multinodular goiter, because then the treatment might be different. In Graves, you have an option of many things. You have an option of surgery, you have an option of drug treatment, you have an option of radioiodine ablation. And toxic multinodular goiter, probably you might go in for antithyroid drugs or maybe a surgery for cosmetic reason. We are going to skip that because we don't have any nuclear scan person over here. Gallium scan is indicated if you suspect thyroiditis, NET, lymphomas, etc. What is a, Dr. Animesh, what is a hot nodule, what is a warm nodule, and what is a cold nodule?
A hot nodule is something which has a greater uptake as compared to the rest of the thyroid. A warm nodule is as along with the thyroid. A cold nodule is
Little more than the surrounding.
And the cold nodule is one which has barely any uptake.
So I can show you the picture how it, you just look at the picture and you can come to know what it is, whether it's a hot nodule, warm nodule, or where is it? Oh, I think it is subsequently. We'll come to that a little later. And we have to also look at the structure of the nodule. If it is a cold nodule, what is the importance of that?
So in olden times, cold nodule used to be almost a marker of this being a higher instance of malignancy.
Right.
These days, the incidence of malignancy in a cold nodule is just about 5 to 15% in different studies. 5% is the general consensus that we stick to.
Yeah. So most of the cold nodule will not pick up the radionuclide. So probably they are not functioning well. They could be degenerated nodule, colloid nodules, etc. 5% of the warm nodules are malignant, because we know that thyroid malignancy are DTC, they are differentiated thyroid cancer. They act very much like a normal thyroid tissue, so they do pick up the iodine. So it will also help you to differentiate toxic nodule from toxic MNG in case the patient has hyperthyroidism, and I think we can skip that. So FNA, Dr. Padma Sen, what about FNA? When would you do a FNA?
So before doing
there is a nodule, when will you do a FNA?
After clinical examination, we will
Right.
get a USG.
Yes.
Depending upon the size of the nodule, We can either go for USG guided FNAC.
Is it only size or you will do a FNA in all?
If it is clinically not palpable, but the nodule is there.
If it is not palpable, then USG guided.
USG guided.
USG guided. But FNA, I think, forms the second most investigation.
It will be
after
second
an
in the
ultrasound.
line before all other investigations are to be done.
So when would you do it? And what is a good FNA? How many smear? Do you have any idea about that? How many smears should be there? What is a good FNAC? So sometimes you do a FNAC, you know, and the pathologist will comment not a good smear or a lot of blood cells are seen, something like that.
Now we go for USG guided FNA.
Yeah, even if you do go USG guided, and actually nowadays we surgeons, we have stopped doing FNAC, you know. I always send my patient to the pathologist only so that the blame comes on him.
We take 3 smears.
The blame doesn't come on me. Yeah. They are expert and probably, you know, the blame goes on them, you know. If there is a bad smear, they have done the bad thing. If
Nowadays we
smear,
should
they
have
done-
interventional also radiologists doing the FNA, because more or less it is about risk stratification.
There should be 6 smears, and at least 15 to 20 follicles should be seen in each smear. That is what is called as a good FNAC. So these are the things. So what are the things, Dr. Padma Sen, which can be diagnosed on FNAC, and what are the limitations of a FNAC? What it can diagnose in a thyroid, what it cannot diagnose in a thyroid?
It can diagnose most of the benign condition except for follicular carcinoma.
Yes,
And
yes.
other malignancies also.
Yes,
Except for follicular carcinoma, rest of the things can be diagnosed.
Right. Most of the thing, it can give you a hint. I won't say diagnose, but it can point towards that. So it can probably give you an idea about whether it's thyroiditis, whether it's a colloid goiter, whether it's a papillary, suggestive of papillary, medulla, etc. Only thing it cannot diagnose is differentiate between adenoma and carcinoma, because the two most important criteria which differentiate between the two is angioinvasion and capsular invasion, and these two things cannot be differentiated on a FNAC, and that's why FNAC cannot diagnose it. 90% specificity, sensitivity. Any indication for true cut biopsy in a thyroid swelling?
Maybe when it's an inoperable tumor, anaplastic tumor, you want to compare anaplastic versus radial side thyroiditis. So in such cases, yes, you should consider.
So the only indication possibly for a true cut biopsy are two. One thing is if it is a grossly inoperable tumor where probably you are just going to diagnose and treat the patient palliatively. It's an unresectable tumor. So, and you just need a diagnosis, and if FNAC is not able to diagnose that, then possibly you might have to do a true cut biopsy, which comes sometimes with undifferentiated or anaplastic carcinoma. And second is a lymphoma, because sometimes lymphoma requires you need to do a subtyping, you know, and by immunohistochemistry, and for that you require a proper block. The immunohistochemistry or the subtyping of a lymphoma, which decides the treatment, cannot be done on a FNAC, and that time you might require a true cut biopsy. Of course, the famous Bethesda classification, which we have already discussed. So that is the Bethesda classification, divides the nodule into 6 types. Madam, you let us know when we have to stop. Tushar, Sandesh, you let us know when we have to stop, how much time we have. Okay? Pardon? Oh, Acha, we have 17. Okay. A lot of time. So that's the Bethesda classification. So Dr. Kolte, how the Bethesda guides you in the treatment?
So it's basically a combination of Bethesda as well as thyroids. What is important in whenever you are going to take a clinical decision about any particular solitary or dominant nodule, that whether it coincides with suspicious, highly suspicious, or a benign lesion, and depending on that you offer the treatment.
Right. Yeah. So we have already seen Bethesda 1. In that case, you repeat a FNAC under a sonologist control or sonography control, so that you are sure that you have hit the proper nodule. Bethesda 2 is totally benign, so just follow up. Bethesda 3 is undetermined, borderline. So this is where the molecular, that is BRAF testing, will come into place. Bethesda 4 is indeterminate, so you can do again molecular testing, and subject to that might go in for lobectomy. Bethesda 5 and 6 will require some form of surgery, which can be a lobectomy or a total thyroidectomy. Any role of thyroid suppression test? Dr. Ashif? In olden days, I think this is a given up test. In olden days, the endocrinologists, when they used to get a patient of thyroid nodule, they used to do a thyroid suppression test. That is, they used to give a hormone tablet, some 50 milligram or 100 milligram of Eltroxin to the patient for 7 days, 10 days, suppress the TSH. This will make the patient slightly go toward the hyper side, suppress the TSH. So, and they used to follow up the size of the tumor. And the concept was like this, that if it is a benign tumor, it will behave like a thyroid, it will get suppressed. A malignant tumor is an autonomous tumor, so it will not get suppressed. But presently,
following subtotal thyroidectomy, it was following subtotal thyroidectomy, it was very frequently practiced.
Correct. It's all given up now. It is all given up nowadays. It's a obsolete investigation, so it doesn't form any part of the present thing. So this again, we have already discussed that BRAF and molecular testing. If you have done the molecular testing, then you can use the biological theory, the monoclonal antibodies. You have to be aware of the familial syndrome, the MEN1, MEN2A and MEN2B, that is the Werner syndrome and the Sippel syndrome. So these are the combination. You will very rarely encounter them, but you have to be aware of them. And if you see any of these in your patient, so if you have a patient who has a thyroid tumor, parathyroid tumor, always do an abdominal ultrasound also, rule out that he doesn't have a pancreatic tumor. Try to get a eye checkup done to rule out that there is no rise in intracranial tension, which could point towards a pituitary tumor, etc. If he is hypertensive, investigate him for pheochromocytoma, that can also exist. So you have to be aware of all these various things. So again, this I think we might skip it because we have indications for surgery, cosmesis, compression, carcinoma. I always say that there are 3 indications of surgery in thyroid, 3C. So compression, cosmesis and carcinoma. Okay. Thyroid cyst. So Dr. Ashutosh, what about thyroid cyst?
Thyroid cysts, approximately 15 to 20% we can see. Mostly they are benign and degenerative nodules.
Yeah, they are mostly benign, and they are usually because of degeneration. That is, a hemorrhage happens in a nodule because of rapid growth, and the growth it outstrips the blood supply, and over a period of time degeneration happens. The cells undergo necrosis, and it leads to a hemorrhage or a degeneration in that particular thing, and that gets liquefied over a period of time and forms a thyroid cyst. So most of them are that. But then we have to be aware of this condition, that is, sometimes a cyst can exist with a papillary carcinoma. Okay, so that is why if you have located a cyst, you have to see whether it is homogeneously cystic or not. Yes or no, madam?
Yes,
absolutely. And if a cyst shows a solid component, that is a dangerous sign. Then those patients, you have to aspirate, empty it off and do FNA through the solid component.
So one thing that we actually do before doing all that is check vascularity in the solid component.
Yes.
So that is very important because that tells you whether that is a nodule that is going to be bothersome or not. So if there's vascularity, yes, we would aspirate the cyst first and then target the solid component for a FNA.
Yeah. So this is something which we have to keep in mind, that if there is a solid component to the cyst, you have to be very aware of that, and you have to FNA it, look at the vascularity. And one more thing, whether when you aspirate, the cyst should empty off completely. If it doesn't completely empty off, and if there is still a residual swelling, that also is a red signal, that also should be a red signal for you. So cyst with solid component could be malignant, so that is something which you have to keep in mind. So how can the thyroid cyst be treated? Ashutosh?
So it depends whether it is what the FNA report comes back, mostly in benign tumors.
Do you do sclerotherapy?
No, sir, I don't do sclerotherapy.
No. Anybody does sclerotherapy? Anybody has experience with sclerotherapy for thyroid cyst? Okay. Some people do sclerotherapy for a fully homogeneous type of cyst, and they empty off, and especially if a patient, of course this will be with counseling of the patient, and if a patient doesn't want surgery, so you can aspirate it off, see to it that the fluid is sent for cytology, whatever you aspirate. At the same time, the cyst should disappear completely, and this patient should be followed up very rigorously also. So this is something which you have to keep in mind. People have used sclerosant like STD, like Asclerol, commonly the sclerosant which we use for varicose veins, etc., for ablating that, if it refills again. So when it's a cyst, the cyst is to be aspirated only if it is large, symptomatic. If it is recurrent, of course the malignant would go for surgery. If it is hemorrhagic, again you should be aware of it, send the fluid for pathology. Refilling and residual lump after aspiration again are red signals for that. So this all thing have been done already. So Ashutosh, would you like to comment something on nodule aberration? Are there any minimally invasive way of treating a benign? This is a thyroid 2 benign thyroid nodule, and the patient is a young patient. She's an unmarried girl, not interested in having a scar in front of the neck, and we don't have access to all these BABA and other things, endoscopic thing.
Yes, sir. So for that we can do a radiofrequency ablation for such patients, which we are regularly doing in.
You have any presentation?
Yes, sir. I have a short presentation.
Please put a presentation of Dr. Ashutosh.
So next slide. So microwave ablation for benign solitary thyroid nodule, it is an minimally invasive technique. It is done under local anesthesia as a OPD procedure. There is no scar because we go barely through a stab on the neck, and cosmetically it is much more acceptable. There are minimal side effects, and this can be repeated if the nodule doesn't settle down completely in the first sitting. Next slide. What are the indications? Benign nodules is the main indication. Size is a little bit controversial. Few papers say that more than 3 centimeter, or the volume, they talk more about the volume of the nodule. More than 30 cc, they say go for surgery. Less than 30 cc, you can go for thyroid ablation.
So more than 3 centimeter.
30 cc.
30 cc volume.
30 cc volume of the nodule.
Volume. Okay.
Volume of the nodule, because what are the this is what the few papers say, but few papers say that it can be repeated. So even if it is a bigger size and it is completely benign, you're sure that it is a benign nodule, then you can repeat the procedure after.
Conversely, can a small nodule be treated with
yes, sir. Small nodules are very well treated.
2 millimeter, 5 millimeter.
Yes, sir, very well treated, because on ultrasound you can directly target the.
But then those nodules will not be seen also, so probably the patient may not be aware of that.
Because the active tip of the probe is 0.5 mm.
Okay, so and how you perform it under local
anesthesia?
Under
local anesthesia, it has
under
to be.
Sonographic
Under
control.
sonographic guidance and local anesthesia.
Okay, how much energy you deliver?
So they say that not more than 30.
Okay.
Yeah, in one single sitting 30, and most of the times we are able to ablate around, if the nodule is somewhere around 3 to 4 centimeter.
Right.
In that 30, there are multiple sittings in that. In 30, we can ablate most of the times 70 to 80, in between 70 to 80% of the nodule.
Okay.
Yeah.
You are using radio frequency.
Radio frequency,
right?
and micro. Yeah.
So what's the lateral thermal spread of a radio frequency?
The probe is actually cooled.
Okay.
Continuously. There is a cold saline that it has a channel which the cold saline is completely constantly circulating. So the probe doesn't heat up. You can actually feel the probe very cold. But the only active tip is 0.5 mm. Only that much is spreading the heat over there. Yes.
Okay, right. And what are the complications?
Complications barely we are having. One is because of it's completely under vision, you know where your probe tip is. and it can be very nicely seen. Hoarseness of voice, I don't think so. It is reported, hoarseness of voice, but if the nodule is very near to the recurrent laryngeal nerve. So in such cases, this is the working principle, the thermal ablation, RFA or microwave. I think Rege sir touched upon it in his talk. The temperature doesn't exceed 100, it is locked at 100 in RFA. It causes cytotoxic effect, cell death and coagulative necrosis. This coagulative necrosis is then phagocytosed by the immune system of the patient. Above 100 Celsius, then it causes carbonization, which doesn't. So for this, the temperature regulation is very important. Next slide, sir. The goal is to elevate the tissue temperatures enough to create zones of irreversible cellular damage. Thermal ablation heats the tissue to cytotoxic level through which cell death is caused. Afterwards, the created coagulative necrosis is degraded by the patient's own immune system. And as we said, while the temperature regulation is very important in this.
Okay,
yeah.
right.
Yes.
Can we use also any other energy source like
lasers? Yes, lasers are also used in some centers.
Okay.
But I don't have any experience with lasers.
Okay. I think the problem with laser, because I do laser surgery for my colorectal surgery, but then I think the problem will come with cooling. Laser doesn't have any
temperature control
facility for cooling.
Exactly.
It will raise the temperature a lot, and there would be a lot of
surrounding thermal damages there.
Okay. And how does this differ from the microwave ablation?
Microwave, sir, has a little. It is wires that are placed. Microwave, the probe, but that's working principle is almost the same.
Okay. Yes. Right. Any more slides you have?
This is a short video. This is the patient positioning, usually same as any thyroid surgery. The ultrasound is kept. You can see the coagulative necrosis that is happening over there, and this is the thyroid machine, RF machine which we have. Next slide is, so we can see the probe completely in its entire length. That is what I wanted to show in this slide, basically, why this has very less complication rates, because everything is under the vision of, and you are controlling it. And so the cooling system, you can see the blue tube on the probe in my hand. That blue tube is sending cold saline inside.
Okay.
Yeah.
Right.
Yeah.
So that blue thing is attached to some IV bottle?
Yeah, IV cold saline you have to prepare. Yeah, it is, and the machine has a circulator system.
Okay.
Right. Next, so this is the ultrasound picture. So the active tip has caused that much of ablation in one setting. Once this starts happening, you have to start pulling out the probe, pulling back the probe. You can see the capsule over there upside. So that is very important. You can't go blind. If you're not sure, don't do it. If it is a difficult angle or if it is a difficult anatomy, we send the patient back to the surgeon that
the
this
tip
is
has to be totally within the nodule.
Within the nodule.
You should not go
outside. Yes, sir.
Yeah, right.
So this is one patient which we did around 3 months back. The nodule, actually my assistant took the picture, so this nodule is not very well visible, but this was a 1 month follow-up picture for the same patient, which I took in the OPD. The patient is completely euthyroid, no hoarseness, nothing, and absolutely no scar anywhere that can be seen.
What is the sonographic endpoint? Do you don't see the nodule at all, or you see that white?
No, ma'am. You can go in different planes.
Okay.
It takes around 25-30 minutes for one procedure. We go into different planes from the same stab. You can change your angle of the probe, you can change the angle of your ultrasound. And what we try to do is go from either first in the middle, then go up, and then at the end, last, because the recurrent laryngeal nerve is down, we try and do it at the last.
And do you follow these nodules up?
Yes, ma'am, ultrasound.
What was the indication for this patient?
Cosmetic.
Cosmetic?
Yeah.
But
Yeah, many times for small nodules, this is I said the scenario that a young female, unmarried female who doesn't want a scar,
Sir, that was
and
what
we
I
are
was
sure that
showing
it's a
कि, hey,
benign
हमारे
pathology,
advisor,
something
I-
like a
हाँ.
Bethesda 2, Thyroid 2. So probably in those patients, selected group of patients.
Yeah, selected group of patients where cosmesis is more important for them.
I do agree. Yeah.
Yes.
Anything? Any more?
This was This was a young girl around 18, 19 years old. Same thing. I'll have to talk to him to take proper pictures. She had a nodule. We did the procedure. It was a small nodule, around 3 centimeters, on the, and this was the post-op picture after around 15 days, which she sent me from home. She couldn't come back for follow-up. She has not come back to follow-up. She's gone somewhere for her further studies. So she said that I'll come back after 6 months. So, yeah.
Right. Yes. No? You are basically a vascular surgeon. Why are you trespassing on our territory?
So this is as a general. So at core, I am a general surgeon, and we all should be learning every day.
Yeah, I know.
Yeah.
I'm just joking this. Take it in a lighter way. Like people, they say that you are into colorectal surgery. Why are you entering into thyroid?
No, do you take the help of radiologists in your procedure?
Why are you going at the upper end of the body?
I do most of my Dopplers and ultrasounds myself. Yeah.
So Ashutosh, when people say that you are more into colorectal surgery, why are you going to the upper end of the body? So I always tell them that the other systems of the body can function well only if the lower end of the body is perfect, and if your hormone system is working well, Okay. Thank you very much for patient listening, and I think Tushar and Narendra, we have finished in time. Thank you.
I would like to thank the moderators and the panelists for a very interactive and engaging discussion. I request Dr. Naik sir to come up on stage to felicitate the panelists. Thank you, everybody. I'd like to request Dr. Sandesh Gavde sir to deliver the vote of thanks.
Just bear for 2 minutes now. So it's an honor to deliver vote of thanks after this 2-day fully packed conference which witnessed wonderful and skilled surgeries by the stalwarts in the field yesterday and an academic feast today. Special thanks to Dr. Pablo and Dr. Anwang, who actually traveled overseas to share their experience and guide all of us. We were blessed to have eminent national faculty from India like Dr. Palanivelu, Dr. Puntambekar, Dr. Kapre, Dr. Rege, Dr. Ganchan, Dr. Amit Agarwal, and many more. I cannot take everybody's name here, but I thank all of them for sparing 2 days for this conference and guiding all of us. It is our pleasure to have Professor Vishwanath Karad sir for our inaugural and to get his blessings. Such an event is not possible without the strong support of the institutional management. And I thank our Executive Director, Dr. Suchitra Nagre Madam, for always backing up us and motivating us and even helping us in managing the minute details in the program. So let it be a smaller issue or a bigger one, she's always the one who supports and guides us. Our another Executive Director, Dr. Virendra Gaisas, who is an eminent rhinoplasty surgeon of India, I thank him for encouraging and motivating to conduct this particular event and helping us and guiding even in the management of this program. Operative workshop is not possible without the support of the backstage people at the hospital. And I thank the whole Sri Saraswati Karad Hospital Operation Theatre staff and team, and even Mr. Dinesh and his audio-visual team for a crisp and clear and flawless workshop. Thank you, Pune Surgical Society, MASI, and ASI for their association for this conference. Organization, conduction, and implementation of each and everything in such an event is possible only with the support of your own colleagues and the team leaders. Our team leaders, Dr. Sachin Naik and Dr. Narendra Lohkare, and all my colleagues at MIMER and SSKH, I thank you for everyone's contribution in this conference. And at the end, success of any conference is basically defined by the number of delegates and postgraduates who attend and get benefited with the event. So I thank everyone who got registered as a delegate and a PG student and got benefited from this conference for your esteemed presence. Sincere sorry as an organizing secretary if there is any lacune in our event and if I forgot to mention anybody who has contributed for this conference directly or indirectly. Thank you again. Thank you so much. Okay. Tea is served outside. I request everybody to have tea, and I request organizing team from MIMER and SSKH, if anybody there from SSKH, for a group photograph of organizing team.